Good evening, Noor. Aloha, Shad.
Hi, John.
How you doing?
I'm good. How are you?
You're in the hospital, huh? Oh, you're
No, no,
home.
no. I'm still at home.
Oh, okay.
It's early morning, Sunday.
Okay. Early morning. It's 8 o'clock, right?
Yeah,
Seven,
it's 8
7 o'clock.
o'clock in the morning. Yeah.
Okay. So what you been doing? Going to
Yeah,
any conference, any other conferences? You go to a lot online, right?
Yes, yes, yes.
Well, that's good. You're keeping up. Probably more
Yes.
than the kids. More than the kids.
Yeah. I love to be more on online than anything else, and I enjoy the listening to people and reacting to their and
Well,
answering. Good,
you
good.
know, we have a good future online.
Yes,
It's
yes,
going, it's
definitely.
just going to get better. It's going to get better and better and better. I
Yes,
can't believe how fast things are changing now with AI. Wow, things are really happening fast.
yes,
Things are getting more powerful. They're getting cheaper. Uh,
yes,
the work situation is going to change. A lot of people are going to lose jobs.
yes,
Uh,
yes, yes,
you better learn AI. Of course,
yes.
as a doctor, you don't have to worry about getting a job, but it's going to affect everybody.
Everybody.
Yeah, it's
It's
not
coming in a
it's
big way.
just it's not a small thing. It's not.
No.
It's huge. That's gonna. It's like getting the fire
Good.
or getting the wheel.
Yeah.
That kind of a discovery where it changes an era.
Mhm.
But
What?
okay, I'll be back.
Yeah, yeah. Sure. See you. Catch you.
Okay. Hello, Noor.
I'm in the shower.
How you doing?
Yeah, I just right.
How come you're wearing a mask?
Yeah, I'm still wearing a mask because I'm a little cautious.
It's still there in the street?
No, not that much, but still, best to be safe and sorry.
Okay.
वो अपनी माइक ऑन
Mohammed Ilyas is here, right, to help?
कर देना उसको
Okay.
ऑडियो हाँ ऑडियो इसको म्यूट कर देना
Oh, you all set? You all set, Noor?
Yeah, I'm all set, I guess.
Okay, I'm gonna leave here, okay?
Oh, okay, but you can be a co-host because I may be a little busy over here. So in that case, if you please just have a
Okay,
look
yeah.
at what's
Okay,
going on,
yeah,
okay?
sure.
Will you
Okay,
do
I'll
that?
wait.
Thank you.
Yeah, yeah,
Bye.
sure.
Yeah.
Good day, sir. Good evening.
Okay.
Sir, can you hear me? Good evening.
Good evening.
It's
Who's
Zainab.
that? Who is that?
Zainab. It's Zainab, sir.
Oh, really? Should I mention that?
Hi, Zainab. Can you see me? No.
No, thank you for coming. Yeah, I hope you did it. I hope you have to speak for the home and meet it.
Zanab, right?
Really
Yes,
sorry
sir.
about
Zainab.
I don't know
Hello,
why
what, do you have your camera?
short when I saw that like then kahan se aa gaya hai? Literally shocked by that. Thank you.
So how have you been? A long time I didn't see you.
Yeah, absolutely, yeah.
Yeah, how you doing? Where's your camera? Where's your camera?
Okay, let me try and see if I can work on it. Can
Okay,
you see?
I can't see you.
Can you see me?
Oh, yeah. All right.
So good to see you.
Okay, you need to put the light on.
Okay, sir. I will try.
Huh? Okay, that's better.
Can you see me now?
Yes, that's good.
It's 5 a.m. here right now.
It's what time?
5 a.m.
Oh, okay. Yeah, right. In Miami, it's 10 o'clock.
p.m., right? I see.
Yeah, yeah.
Okay.
And you're in the African country, right? What's the name of the country again?
I'm in Moscow right now.
And where?
In Moscow at the moment.
Moscow and Russia?
Mm-hmm.
Oh, wow, that's great.
Thank you,
Do
sir.
you know Manuel Fernandez? He's a
Yes, I
Spanish.
do.
Oh my God, is he at the same hospital?
Not really. I see him time to time.
Oh, so you just ran into him online?
No, I do see him at our hospital, the pediatric neurosurgery hospital, time to time. I think I saw him 2
Okay,
weeks
well,
ago.
say hello to him.
I will.
Give him a big kiss.
I will do that.
Okay.
Okay,
No wonder,
sir.
who's this girl kissing me?
John, will you please turn off the video for a little moment because the people are sitting here, so it may be
Oh, okay.
it may look a little less
Okay.
subtle.
Okay.
Did you know what I mean?
Yeah, we shouldn't talk.
Yeah. I'll be around. And I have to take care of the question
Otherwise,
itself.
they're listening to our gossip.
Also, we had all our are convinced that Australian is still a great. And today also understand that they explain such a good pool. You want to talk about no, I just talking about almost. Oh. Don't worry about it. Something else. So, Noor-ul-Huda is the girl who's been helping with the GNC. Tell us how many people were watching.
So we had got about 300 registrations on Zoom, and there were about 81 people who were watching on YouTube, and about 2 million there was online news. And there was another platform on the News Pacific TV that was a third platform, so we had a plenty of it then.
You know the distribution geographically?
So I just sent it to you if you want.
I was just wondering where,
Then there was from all over
who's
the
attending
world.
virtually?
Yeah, from all over the world, from Central America, there were from Korea, and also from Moscow, there was from the world, from Russia, and also from Europe. I'm still surprised that about the time some people from Georgia actually, because the time zones different. There were different regions online and different parts of the day. The more there were, from Russia, like in the evening, there were more people from Europe. And from Australia and Africa, and people
That's great.
so overwhelming, it was very nice. And they didn't have
I didn't know they endorsed it. I'd love to put you together. This was kind of amazing. You can also, I think you know, I'm not yeah. We gotta stop rocking the boat. Now we're in the kids.
Yeah, sir, I'm here. Okay.
I got the thing. I wasn't at the thing, but too much work. Barnes and Noble and all those shops and all that. I mean, I hate kids, I love it. But it's a long time. Put together public administrative you would have to have never been. We can put the book on, but at the time. When I started with I wanted to have these
Hello, Assalamualaikum salam and the chit-chat, right? ठीक है उनके सफाई
Thank you, thank you.
I'll request everybody to get seated, please. Good morning, everybody. I welcome you all to the second day of our first WFNS International Global Neurosurgery Conference. I'm Dr. Adnan. I'll be hosting the day today, most of the day. Without further ado, we'll be starting our first plenary session, which is on neuro-oncology. I can see the chairs, Dr. William Caldwell, Lal Rahman, and Igor Triffin now are already seated. Please go ahead, sir.
to co-moderate this first plenary session. We've got important talks today, and I want to thank Derek so much for being such a fabulous host and having this location for our meeting. It's marvelous. So our first speaker has been listed as Dr. Key Park, who I think needs no introduction. But Dr. Park, who's a real expert in global health and has committed his career to that, would like Dr. Mohammed Shakiri to give his talk. Dr. Shakir is from Aga Khan University here in Karachi and is a research associate with Dr. Imam. Dr. Shakir. Speakers have 10 minutes, and then we'll have a discussion at the end. Thanks, Derek. And we'll give you a 1-minute warning with a little ring.
Zoom out participants. Zoom out participants. नहीं इसमें हाँ लाइक ये क्या है ये हटाना है नेक्स्ट साइड इस साइड से नहीं है नॉट लाइक दिस स्लाइड चेंज कर सकते हैं बट इसको should we do it now or in the next talk? Yep. Yes, ma'am. Assalamu alaikum and good morning to all of you. Sorry about, there's a bit of glitch in the presentation PowerPoint. So my name is Muhammad Shakir, and I'll be presenting on comprehensive healthcare system policy recommendation for the management of brain tumor and LMIC. And this is a collaborative project between AKU and like Dr. Atar Inam Lab and Dr. Keepak Lab. And the collaboration is basically between PASNA, which is Pakistan Society of Neuro-Oncology. It is one of the society which kind of, promote to build the capacity of neuro-oncology in Pakistan. And I'm presenting this talk on behalf of Dr. Keepak and Dr. Atar Inam. So before getting into the policy recommendations, let me give you a little bit of background about brain tumor. So we know that the incidence of brain tumor, it's ranked to be, in terms of incidence, it's ranked to be the 19th most common tumor. And in terms of mortality, it's ranked to be 12th most common tumor. And then brain tumor, a little bit about the statistics by region. So we know that, like, in terms of incidence, mortality, and prevalence, so brain tumor are pretty, prevalent in Asia, and then it's in the Europe, and then in the North America. So if we look at the incidence rate by gender, so the brain tumor are pretty common in high income countries is compared to LMIC, but unfortunately, that's couldn't be the reason, since we don't have a lot of data from LMIC. So this is not the real reflections of like incidence of brain tumors by genders across the globe. So what was the rationale for like formulating these for formulating these policy recommendations? So one of the rationale was to bridge the gap between LMIC and HICs. If you look at this graph, there is a huge gap in terms of like workforce, in terms of like service delivery between HICs and LMICs. So that was one of the rationale to bridge, that gap between, LMIC and HICs. So the main objective and visions of this policy recommendations are, so the objective is to reduce the incidence of morbidity and mortality, particularly in LMIC. And the vision is to provide access to safe, effective, and affordable brain tumor care to patient, regardless of their geographical location or economic status, and particularly that, for LMIC. The main framework that we adopted, for formulating these clinical guidelines is NSOAP, which is a National Surgical Obstetric and Anesthesia Plan. And this is a modified WHO building block. So the blocks in this NSOAP framework mainly include workforce, infrastructure, service delivery, information management, and finances and governance. And we did a systematic review on the different pillars of brain tumor management, which includes early detection, surgical care, adjuvant cares, follow-up cares, rehab, palliative cares, and surveillance. So we did a systematic review on each one of the pillar, and we looked at that, what are the barrier to these pillar, so that we can formulate based on those barriers the policy recommendations, so that we can take so that we can tackle these barriers. And so the strategy that we adopted for these guidelines, so we formulated a steering committee, and that steering committee was from 15 countries, and we have like experts from different disciplines. We have experts from we have neurosurgeon, we have neurologist, we have like public health experts. And then we decided a methodology that how should we go about, formulating these these policy recommendations. So we did an extensive review of the literature of different databases, and we conducted a systematic review on each pillar, as I mentioned, and then we wrote then we wrote, these guidelines based on those systematic review. And the guidelines are under review, and hopefully it'll be published very soon. And then we will try to implement them. Now, so the data that we pulled it out, the secondary data that we pulled it out from the literatures, mainly that data was from LMIC, and particularly the data was from Southeast Asia, mainly from India, Pakistan, and then from African country and some of the Latin countries as well. This is so this is the result of one of the systematic review that we conducted for early detections. Since one of the issue in LMIC that most of the patient, they present pretty late, right? So we were trying to look at what are the barriers so that we can tackle, those barriers. So one of the common barrier for early detections in LMIC is the financial issue, and some of the other barriers like limited diagnostic facility and misdiagnosis. Since a lot of healthcare provider, they don't have the understandings, like the understandings of like what are the signs and symptoms of brain tumor. And some of the strategy that were mentioned in the literature is to educate, the providers on early sign and symptoms, so that we can sort of curtail, the delay in detection of brain tumor. And the other strategy that was reported in the literature to improve the referral system, since we have like many LMIC have like a fragmented referral system. So that was one of the strategy to have to improve the referral system. And these are the results for follow-up care. So the barrier that were reported for follow-up care was long distance travel, since many people, they go like, pretty far to get, the healthcare. And the other main issue for follow-up care was the financial issues. And some of the strategies that they were reported was to have a documentation system. So that will improve, the follow-up care, and some of the other strategy are mentioned in the graph as well. Now, this is the result for adjuvant care that we have. So the barriers, again, the barrier for adjuvant cares of brain tumors, one of the most common one is that we don't have a proper referral systems. And and a lot of people, and the other issue that is reported is that majority like patient, they have radiation related adverse effect, and they sort of lost to follow up because of that. And these are the strategy that were mentioned to tackle, these barrier. Now, based on that data, we formulated, these policy recommendations. So these are the recommendation for early detection that we have, and these are in terms of every ENSO block. So we formulated a recommendation for workforce, infrastructure, service delivery, information system, financing, and governance. So if we look at the workforce, our recommendation is there should be a local training program, and there should be, we recommend that there should be international collaboration. And we also recommend task shifting and task sharing and rural area to bridge, the deficit in workforce. And for infrastructures, we recommend that there should be a hub and spoke model for resource limited area. And for service delivery, we recommend a robust primary care referral pathway, since as I mentioned, that the referral systems and many LMICs, it's fragmented. So we need to work on that, and we have like this recommendation for service delivery to improve the service delivery. For information system, we recommend that 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 there should be cancer registries, right? And then we also recommend that there should be a local clinical guidelines for brain tumor, and there should be a proper surveillance, like electronic data management system. For financing, we recommend a cost-effective collaborative education model so that that will improve the workforce and LMIC. And we also recommend funding allocation and innovative strategies to improve the financing for neuro-oncology and mainly for brain tumor. And then for governance, we recommend that there should be a national brain tumor management program and awareness and advocacy through public campaign. And there should be a multi-stakeholder governance structure. Now, these are our recommendations for surgical care. And we recommend that there should be a building of multidisciplinary teams, improving the workforce conditions, and we have a separate recommendation for infrastructures, and then we have recommendation for service delivery, financing, and governance. And these are the recommendations that we have for follow-up care. And these are the recommendations that we have for adjuvant care of brain tumor. And this is the summary of all the recommendations for every single pillars and for every block of NSOAP. So this is the whole summary of all the recommendation that we formulated for brain tumor, particularly for LMIC. And thank you. If anyone has any questions, I'll be more than happy to take them.
So,
All right.
okay, now the next presenter should come.
Okay.
The next paper will be presented by Dr. Rahil Ahmed. He will present about developing epilepsy surgery program in low and middle income countries. Please be in time. You have only 10 minutes. So you should finish it in 9 minutes. Dr. Rahil Ahmed. He's not here.
Okay, we will go to next speaker, Dr. Saeed Athir, introducing evidence-based or use of radiosurgery recommendations for low middle income countries, please. Oh. 15.
Yes, I think we're hijacking your meeting there, guys. So first of all, I want to say to Mohammed, where did he go? Outstanding talk. That was, to squeeze that in 10 minutes is a lot, but you did a great job explaining. I want to give a little bit of context. Remember, global neurosurgery is not about how to do neurosurgery better, but it's how to better deliver neurosurgical care to those who need it and who are not getting it today. And we did this set of recommendations first with Tariq on the comprehensive policy level recommendations for head and spine trauma. We called it Peshawar recommendations. And it's designed for health ministries. It's not for clinicians. It's really about governments, how they can improve their service delivery. Then we did one on spina bifida and hydrocephalus. And this is our third iteration on brain tumors. And we're really happy to collaborate with Aether at Aga Khan University. They did an outstanding job. You really led the project, and Mohammed was the key person for that. So great job. And what we need to do now is to take these recommendations and support the countries. And so why would countries be interested in adopting any of these recommendations? Well, the stars are aligned because at WHO, there is now a global action plan for epilepsy and other neurological conditions. All the countries signed on to it, including Pakistan. So the ministries of health are already looking for ways to improve care and delivery of care for neurological conditions, including brain tumors. So I just want to give a little bit of context, and over to the chairs. Sorry.
You were catalyst. And everything, right? Okay. So thank you very much for the organizers, Tariq, and all those big professors for inviting me on this one. So this is a part of the supplement that's coming out, which is based on global neuro-oncology. So I've been talking about global neuro-oncology for last so many years, and this supplement has about 12, 14 guidelines that we want to mention. And this is just the first draft, so it will be revised over years as we improve things. So from there, I have just chosen the radiosurgery because that I find is a major problem, major issue. I just want to point out the Pakistan Society of Neuro-Oncology. It's been about 5 years now doing excellent work, and the Pakistan Academy of Neurological Surgery, which is the main aim is to just educate and train, and that's it. No politics, no elections, nothing. So there are different type of brain radiation we know about. There was a time, maybe half of those who over here, they don't even know what WBRT is. But then other half of us knows what WBRT is because that's what we used to do when we were residents. That is gone now. And what we have is something what we use as a traditional, just a second, where is the laser pointer? Okay, here we go. Traditional radiation, where we try to use the tumor and not radiate the whole brain. But then the stereotactic radiosurgery came in. What's the principle of stereotactic radiosurgery? I know most of you know about it, is that you focus the radiation beam from different angles so that the tumor gets radiated more and the surrounding tissue does not get damaged. But the problem is that still there is a lot of radiation dose that is delivered at the surface. Now, when we come to the proton beam, that has the Bragg peak effect, is that, think about it like you have multiple layers of sheets and the light is passing through it. The light will be shining the highest at the first layer, and then as it goes deeper and deeper, you will not see much of light. But that's what the X-rays or the gamma rays, which are all electromagnetic radiations, does. But when you use proton beam, then it actually penetrates through those initial layers, and then it drops at certain point all the energy. So, but then until proton beam therapy comes to Pakistan, we have to use SRS as a wonderful modality. Look at this graph. At the surface, this is megavolt X-rays. That's what the SRS, like CyberKnife, is, and even the cobalt gamma rays. They deliver most of the energy at the surface. But using different beams, you can focus it on the tumor, and that's the benefit. And this is a great technology. But the problem is this, because when all you have is a hammer, everything looks like a nail to you. And that's what's been happening for the last several years in Pakistan, maybe at least 20 years. So I will go through some cases, and I'll mention to you what are the problems. This is a gentleman, 28-year-old male with a history of vertigo. 3 weeks, he had a contrast-enhancing lesion involving the floor of the fourth ventricle and infiltrating into the brainstem with mild hydrocephalus. And he got SRS. So we don't know what this is now. What are we going to do with it? And he still has symptoms. And they never got the MRI of the spine either. So this is a case that I'm struggling with the last couple of months. Here's another case. This is a patient who was 21 years old. If you notice, there's a lesion over here, and got SRS early on about a couple of years ago, and then the lesion started to grow in size. And as it grew in size, it caused more symptoms after SRS. We did not know what to do because SRS was already given. So eventually we went ahead and removed it, and it turned out to be pilocytic astrocytoma. Now, what's the treatment for pilocytic astrocytoma? Surgical resection. Why did we give SRS to that patient? Another patient over here, 66-year-old female, who presented with weakness in her arm, on the left arm, for 3 months. She had a very long history, much early in the past, about 10 years ago, she had ovarian carcinoma. Now, this patient had a single metastasis, had a neurological deficit, no evidence of any disease anywhere, and she was gonna get an SRS. Is this a right treatment? Because there's a mass effect. There's a lot of edema over there, and if you give SRS, the neurological deficit is not gonna get better. So we had to remove it. It's a single metastasis, solitary metastasis. There are written guidelines on it. Another case. This is a gentleman who received, 56-year-old gentleman, who received surgery for this lesion. And then after surgery, nothing was done. That's it. No radiation, no chemotherapy, no diagnosis reported to him. And then he presented with a much larger lesion after a few months. And then the question was, should we give SRS to this patient? Of course not. I mean, you have to get the diagnosis first and then think about the concurrent chemoradiation therapy and things like that. Another case over here, a 52-year-old gentleman came with headache and confused speech. And this contrast-enhancing lesion with a lot of perilesional edema, and received radiosurgery. After about 3 to 4 months, he presented with generalized tonic-clonic seizures, and the lesion was much increased in size. And at that time, obviously it had to be removed, but earlier the better. It should have received the right treatment early on. This is a case, and these are all just cases in the last few months, of the last couple of years. This is a 45-year-old gentleman with a KPS of 90, and had headache and vomiting, gait disturbances, fourth ventricle tumor, hydrocephalus, underwent VP shunt, which is another point that I've been raising, that don't just put VP shunt, do something for the tumor. If there's an urgency, yes, you put a VP shunt and try to temporize the effect. But then if the patient is not that bad, don't do that. Try to treat the primary cause. So he got a VP shunt, and he was sent for SRS. Again, we intercepted it before he went for SRS, because we needed a diagnosis for this patient. Another patient over here, if you look at it, this is like a low-grade glioma, no contrast enhancement. This is a 44-year-old female. This should have been resected. It's very resectable tumor. It's on the right side. It's in the frontal lobe. I mean, come on. It can't be easier than that, right? But then this patient received SRS. And then, obviously there was a reaction to that, or it was, well, we did not know what it was. So we had to resect it. There was a lot of edema. It turned out to be already necrosis. The patient was neurologically getting worse. Then look at this patient. This is a 29-year-old male with KPS of 90 with absence seizures, had a lesion in the left temporal lobe, and received SRS a couple of years ago. But then the lesion continued to grow and the symptoms increased. And then once it was resected, it turned out to be DNET. Why would you radiate a DNET? Come on. And then there are a lot of cases. Here I've intercepted this case. What is this? Does anybody know? I'm talking to junior guys. This is the arachnoid cyst, right? This patient was going for SRS. Was sent. What is this? Vein of Galen aneurysm. This patient was being sent for SRS. And I'm talking about professors. I'm talking about those people who actually are going to examine you in your exam. These are the ones. I'm not going to reveal the names. I have letters also, which shows all that. This patient, 60-something-year-old patient, no known primary, and she was going for SRS for this lesion. Do we know it's an infection? In fact, do we know it's an abscess? Do we know it's a TB? do we know it's a tumor? And that's another problem. A lot of patients get ATT without any diagnosis. It's just same thing. So there are indications for SRS without any histopathological diagnosis. For example, a small, less than 3 centimeter acoustic neuroma, vestibular schwannoma, and you can see it's going into the canal, and there's nothing else that does this. So you can give SRS no matter how little. There's no edema around it. So that's an SRS. So based on all these things, this is what we have come up with: the judicious and evidence-based use of radiosurgery. We did a scoping review, and what we found that the Key, you took all my 10 minutes, man. So what we found is that so this is the guideline that's coming out. The newly diagnosed brain tumors, when they come to you, you go for histopathological diagnosis first. Only one kind, where vestibular schwannoma and maybe something related to special cases where histopathology is not required, you can take it directly to the SRS if it is a small, less than 3 centimeters. Everything else should go through the regular treatment, and then if there's a recurrence or something like that, then it should go through a neuro-oncology tumor board. So this is the Pakistan Brain Tumor Consortium, and I'm glad, I'm thankful to a lot of you guys who are part of the consortium, who have supported this thing and endorsed it, and hopefully we improve our treatment plan for brain tumors. Thank you very much.
I think we're going to next session, and we need to change this.
Sure.
Thank you very much. I'm glad that we've got new chairs now. Dr. Syed Athar Inam, Dr. Key Park, and Dr. Anila Darbar. All right. That's fine. Dr. Darbar. Try yours.
First of all, let me just say, Tariq, how much I've enjoyed so far the conference. My first time in Pakistan, and it won't be my last. So our next speaker is Bill Caldwell, as I think most of you know, he's a chair of neurosurgery at Utah. We're on the same flight over here, and so anyway, he's talking about orbital surgery and the neurosurgeon. So, Bill, are you ready to go, or?
Yeah, I think I'm just waiting for the.
Great.
They're all hooked up. There you are. Beautiful. Great. Well, we're going to shift gears a little bit. I'm not going to talk about global health, but I'm going to talk about where I think neurosurgery should be going and where the future of skull-based surgery is. And I'm going to show you some of the things that I've learned over the years. This is where I'm from, Utah, beautiful place. But the unique problems that we face in skull-based surgery are the variability in tumors. And it's not stereotypic surgery. And I think that's important. It's not like doing carotids or bypasses. And I do those. Those are much simpler and than a lot of the difficult skull-based tumors are. And so where are we going with skull-based surgery? And I would liken this, I'm going to show you a couple of cases to have you just think about this. Here's a case of a 45-year-old man who's got proptosis and a painful eye, and he's got an AVM in the orbit, okay? So what are you going to do? And who's best equipped to take care of this patient? So our endovascular people looked at this and they felt it was too risky to try and embolize because it was being fed from the ophthalmic artery. So we'll do a transcranial orbitotomy on this case. And so we'll go ahead and do a frontotemporal approach, extradural dissection here, drill off lateral sphenoid ridge, get down to the periorbita, do an anterior clinoidectomy. This is all, you're all familiar. This is all within the wheelhouse of a cranial skull-based surgeon. And then we'll open up falciform ligament and over the optic nerve, you'll see, and then we'll go ahead and do an orbitotomy. So I'm opening up the dura, getting intradural here, and we'll find the optic nerve and the carotid. This is right side. And so then we'll have to locate this AVM within the orbit. And so what we'll do is we'll measure the distance between the orbital apex and where the AVM is in the orbit. And here we are dissecting down through the periorbital fat. The retractors that we use are beautifully used for orbital surgery because the fat herniates obviously and obscures your view. So what I'm doing is I'm dissecting down to find the feeding branch of the ophthalmic artery. And so we'll go ahead and continue dissecting down and find the feeding branch. We'll temporarily clip it and we'll make sure that everything looks good. And then we'll go ahead and dissect around the AVM. And it's interesting because these are actually much more difficult to dissect than they are in the brain because the periorbital fat is stuck to them. So what I'm doing now is I'm trying to identify the superior ophthalmic vein, the draining vein, which is what we have here. And we'll isolate this and we'll go ahead and ligate the superior ophthalmic vein. And that way you've got proximal distal control of the AVM. And then we'll go ahead and remove that. And here you see we've got the superior ophthalmic vein cut. And we'll just remove the residual AVM now in the orbit. And it's a fairly simple matter. They tend to be less fragile than they are in the brain. But it's the same technique. And I would say that the neurosurgeons are best posed to take care of this type of disease. So here we then remove the specimen. And we'll go ahead and do an operative angiogram and make sure that the lesion has been removed, which it has here. And he's done very well. We've preserved his vision. And then I'm going to show you another case. This is a sphenoorbital meningioma in a woman who had radiation when she was a child. So she's got residual disease in the bone here. It hasn't been removed. And then she's been followed. She had a middle fossa meningioma at that time. You can see the bony tumor was not removed. Now it's encroached upon the orbit, extended into the orbit. She's had radiation with gamma knife ×2, orbital surgery with partial removal by the ophthalmologist. And then she ends up with this. And she's got now complete orbital involvement, prosthetic globe, cavernous sinus invasion, and is threatening the contralateral cavernous sinus. So this, in my mind, is a failure to act more aggressively with the tumor initially, because what they did is then they chased it with suboptimal procedures and surgery and radiation. And I won't go through this because of time, but this then requires a complete orbital exenteration and a free flap to close. And here's the removal after surgery. And she lived for another 3 years after this, which is great. So skull-base surgeons must be familiar with the orbit. And I want to call out Dr. Albert Roten, who, as you know, left such an amazing legacy for us. And when I was a young neurosurgeon, we were interested in the cavernous sinus, but we didn't venture into the orbit. And I would say that it's a different mindset now. We need to extend our knowledge into the orbit because our disease extends into the orbit. The neurovascular relationships are important to study. They can be studied in an anatomical lab. This is the beautiful dissections of Roten where they've removed the fat, and you can see it's a relatively simple structure. You just need to be able to predict where the neurovascular structures run within the orbit. And that's teachable and learnable. We've written a big review here on different approaches to the orbit and using the orbit itself as a window into the transcranial space. And that's beyond the scope of this talk. For instance, the endoscopic and endonasal and maxillary approaches for the inferior disease and the medial disease. Here's an angioma of the orbit with proptosis, visual loss, and remove that endoscopically. And then these complex tumors, this is a series of patients that Sam El-Mefti and I published on these skip lesions of schwannomas that can involve all the way out to the peripheral divisions. And they have normal intervening nerves between the lesion. It's a section of schwannomatosis. It's a unique genetic disorder. And then these dreadful cases. This is the worst case of fibrous dysplasia that I've ever seen. I've operated on this boy, I think 5 or 6 times. It's the most dramatic case, and he had, actually compression of his intracranial space from the fibrous dysplasia. They can be very difficult, but you can see they often involve the region of the orbit, and you'll have to be familiar with that. This is the bone windows of that boy. But I just want to spend the last couple of minutes talking about sphenoorbital meningiomas. And I showed you a case earlier of a case gone awry where it was insufficiently treated and then ultimately resulted in shortening of her life. The problem is that the tumor's in the sphenoid bone and it's in the orbit, and it's often subtotally resected in those locations. And so here's a woman from Eastern Europe, terrible proptosis. And she came in extremis, but the tumor here is in the sphenoid bone, as they often are. It's extracranial, it's intraorbital here, and it's intracranial. And so you'll need to remove all of that. And I've become very aggressive with how I remove these tumors. We've got a very large series that's being published right now, and I just want to give you the highlights of where my thoughts are of this and where we need to go. I was very disappointed when I was younger about the ultimate results because the proptosis would not get better. And these are patients that you've all seen in your practice. And so I became progressively more aggressive about what I removed. I became progressively less aggressive about what I did to reconstruct the orbit because it was inhibiting the reduction of the proptosis. And so we published this technique some years ago with a smaller series. But basically, you're lucky in these tumors because the orbital rim is not usually involved. It's spared. The disease involves the bone behind the orbital rim, so you can retain the orbital rim and then remove all the diseased bone behind the rim. And we'll look at the CAT scan and see exactly where the bone is thickened. And that's our planned resection for all the bone. So here's a tumor, like a patient from Las Vegas, again, a middle fossa meningioma. He had progressive proptosis, and you can see he has no intracranial disease. It's all in the bone, and it's some extending into the orbit as well. And so we'll drill all that bone and take all the time necessary to drill that bone to try and give him relief. I don't have time to present any more videos, but we did develop a grading scale when we reviewed my series of over 90 cases now, which is just being published. And these grade 1 tumors that just involve the bone, will make sure that we try to remove the bone because this will be a nidus for recurrence if you don't. And so the tumor may often involve middle fossa or anterior fossa tumor, but you'll remove that with the involved dura, and we'll drill all the involved sphenoid bone. Grade 2 is when the periorbita gets involved. And this is where a lot of neurosurgeons, I think, are intimidated by, or they stop, they leave the tumor beyond the bone, and the tumor in the periorbita can be removed. And then the grade 3 can involve the muscle, often the lateral rectus in this particular case. And then grade 4 is when it gets into the posterior apex of the orbit, which I believe is unresectable unless you're willing to give them more deficit. We will do the grade 4 resection like you saw on that previous case if we're planning to do an orbital regeneration. So again, this is our grading scale that we came up with, and the whole grading scale was designed to predict the resectability of the tumors and what you should try to achieve to try and reduce the risk of recurrence and improve the proptosis in these patients. So we believe the grade 1 and grade 2 tumors can be removed. The grade 3, you'll have to decide. Oftentimes they have diplopia already. If they do have diplopia and they're young patients with meningioma invasion into the lateral rectus muscle, we'll remove the lateral rectus muscle as well, because they can straighten the eye afterwards. The ophthalmologist can do that. And then grade 4 tumors, we do more limited resections. We try not to make them any worse. If they're blind, that gives you a hunting license in my mind to be able to go ahead and do a resection exenteration of the area if they've completely lost vision. So here's a grade 1 tumor. You can see the sphenoorbital bones involved, and it's thickened, and that should be easily removed if you take the time to drill it. Grade 2, where the periorbit is involved. Again, the periorbit, as long as it's not invading the muscle, you'll be able to remove that, and I'll show you that. And then grade 3 is where you clearly have involvement of the muscle, and you can be surprised how much you can remove if you take the effort to try and do it. And I'll show you just a snippet of this video. This is an older man with this particular tumor that you can see up here. And what he's got is he's got involvement of his orbit, obviously. And what we'll do is we'll go ahead and and remove the lateral orbit here and do a removal of the clinoid. Here we're decompressing the optic nerve. He's still got functional vision here. And open the falciform ligament, get the tumor out from the canal itself. Here's the ophthalmic artery. And then once you do that, we'll go ahead and inspect and dissect out the region of the orbit. And you do this by making longitudinal cuts within the orbit and then removing the tumor and getting down to the periorbital fat, because this will be a buffer for you to be able to remove the tumor. And you can see here, we've decompressed now the orbit completely. And I'm removing tumor down into the pterygopalatine fossa now. So you can achieve much more than you think if you take the time and remove the tumor from the orbit. And you can see his proptosis is resolved now, and he's had tumor removal. All we did leave tumor within the cavernous sinus.
Can you wrap up?
Yeah. So I just want to say in conclusion that orbital surgery should be familiar to skull-based surgeons. And only the neurosurgeons can perform all the approaches used to orbital pathology. It's generally forgiving, and it's a common area for tumor occurrence. So it's an important frontier. And I think we must take responsibility for the natural history of the disease. You can't just say the tumor can't be resected. We need to try and resect it. We need to get minimal residual disease. And we need to avoid using early radiation on these patients if we have disease that can be surgically removed. So I want to thank you very much. Thank you. Good.
Okay. Thank you. Well,
Thank you.
So our next speaker is Corrado Ecarino from Università degli Studi di Modena e Reggio Emilia. Oh, good, right? Thank you. Yeah. So he's going to talk about impact of fluorescein-driven surgery on outcome of high-grade glioma resection.
Yes. Thank you. Thank you for introduction. And special mention also all the people connected by internet, by John Bennett's site. So it's incredible, amazing success of this Congress. So Tariq, congratulations once again. My topic is to talk about the impact or outcome of fluorescein-driven surgery for glioblastoma. We know that the extent of resection is a good impact of overall survival, and also because the tumor that had to be underwent radiotherapy depending on the amount of the extent of resection. And because of the fluorescein can have an impact of resection, it's natural to understand that the fluorescein can have an impact of overall survival and progression-free survival. But if we analyze the literature, we see that for sodium fluorescein, main studies are all retrospective, just one prospective study. But what is very interesting that few studies have focused the attention on overall survival, and just one study focused attention on progression-free survival. All the studies are focused just to the gross total resection. So this present study wants to analyze the impact of overall survival and on progression-free survival, more than extent of resection. So 143 patients and compared to 67 patients. If you take the period, we use fluorescein from 2017. And this is the sample size distribution compared with the main publishing paper about this topic, and we have the higher amount of patients underwent fluorescein-driven guided surgery. And about the prognostic factor of the two groups, the fluorescein groups and control groups, is quite the same prognostic factor. So the age, location, preoperative Karnofsky, and EDH status and MGMT status are absolutely not different. There is no statistical significance difference between the two groups. So the two groups are comparables. And overall survival in our results, the flourishing group have a better overall survival compared to the control groups. And these results is a better results compared to the other papers published on these topics. And about the progression-free survival, in the present study, the progression-free survival, the median at 3 months, at 6 months, at 12 months, the results are better always in a flourishing group compared to the control group. And the only paper that take these analyses from Acerbi, and also in Acerbi, the flourishing has these results, but Acerbi didn't show it comparing with the control group. So Acerbi report the results just for the flourishing group. There is a limitation of our study. It's a retrospective study, of course, and for most patients, the extension of resection was evaluated just on postoperative CT scan, not on MRI. So this is the reason, because we have not to analyze the results about the extension of resection. Anyhow, also, if we analyze the residual on the brain CT with contrast or the less patient with postoperative brain MRI, we have results comparable, not better, but comparable. So the conclusion is that the sodium fluorescein represent an aid to improve results for patients with glioblastoma multiforme. Overall survival could be improved. Also, the progression-free survival could be improved. But when we analyze this kind of studies, the overall survival and progression-free survival should be considered most effective that documented gross total resection. I mean, when all the literature until now about fluorescein is focused on gross total resection, and less papers report the results about clinical condition. So this is the first study that compare overall survival and progression-free survival, patient under fluorescein and patient without fluorescein. Thank you.
That was quick. So we have a few minutes if anybody wants to make a comment. Yes.
Can also be for Bill's presentation as well.
Just to say, it's just nice to hear people being honest about glioblastoma, because it's an industry, isn't it? And of course, the easiest thing to measure and the easiest thing to sell your product or to sell the unit that you're working in is the extent of resection. But we all know it doesn't make as much difference. But it's very, very interesting to hear this. I think it's lovely. Thank you.
Thank you. Amos.
Thank you. Beautiful presentation, of course. Sorry, except I'm not getting something right. I thought fluorescein-aided resection should make you to be able to extirpate more tumor than without. But there's a slide that suggests to me that resection on fluorescein base was less total than without. Am I getting something wrong?
How I calculate the resection without fluorescein, you mean?
Yeah, this slide suggests that it's less. Please help, go to the slide.
Which slide?
I don't know. Go back, please. The 2 to 3 slides to the last slides.
Okay. I'm trying.
Oh, residue. Yeah, residue at post-op surgery shows an inflorescing group. There's 13%, 14%, and 0 in the control group. Or is this mix up?
Yes, it's a but it is CT scan. So the limitation is the evaluation of CT scan. So we didn't analyze these data. in the results of paper, but we reported the same data. I mean, in the paper, we didn't analyze this. We do not add these like results because you cannot analyze a residual on brain CT scan. Anyhow, we see when we analyze with the MRI, we do not have we can have less residual than CT scan. But if you operate with fluorescein, of course, for sure, you do not reset totally tumor always. There is always some part that you can have a residual.
Thank you.
Yeah.
So that was a great point, and as you know,
And this is the way, because we propose to measure the results more than clinical results, than radiological results. But if you take a look on the literature, on the main, all the papers analyze results on gross total resection, and less papers analyze results on the clinical status.
Thanks, Corrado.
Corrado was just presenting it honestly.
Yeah.
Yeah. Okay.
Thank you. We have one more speaker for this session. Is Sakib Bakshi ready? Okay, great, great.
Good morning, everyone. I'm Saqib. I'm a consultant neurosurgeon at the Aga Khan University, which is the largest academic medical center in the country. I'll be talking about a systematic review and meta-analysis comparing awake craniotomy and surgery under tumor resection under general anesthesia. I have no disclosures. So we are aware that during the past 2 to 3 decades, awake craniotomy has gained popularity, mainly because of preservation of neurological function with tumor resection. But the evidence basically mainly talks about preservation of neurological function, and there is less homogeneity in the evidence regarding other parameters like length of hospital stay or gross total resection or extent of resection. So, and plus, when other outcomes apart from neurological function are compared, we see that in the literature there are heterogeneous results. So our objective was to compare outcomes apart from the neurological function and to see if there is any evidence regarding better outcomes with either one of these modalities. So we had registered our systematic review with Prospero, and as per the inclusion criteria, eventually 10 studies were included. So without wasting any time, I'll jump on to the findings. So on comparing extent of resection between tumor resection under awake craniotomy and general anesthesia, there was no significant difference observed. Some studies under general anesthesia also reported better extent of resection, whereas some with awake craniotomy reported better resections. Similarly, when we talk about gross total resection of tumors, again, there was inconsistency in the outcomes, and the results were there was no statistically significant difference with either one, supporting either one of the modalities. When we talk about operative time, although most studies reported that surgery under general anesthesia took more time, mainly because of more time taken by the anesthesiologists. However, the difference was not statistically significant. When we talk about length of hospital stay, most studies reported that patients undergoing surgery under awake, as in awake craniotomy, had shorter length of hospital stay as compared to surgery under general anesthesia. However, again, this difference was not statistically significant. So if we compare these outcomes apart from neurological preservation, the overall outcomes are comparable between the two modalities. We can safely say that as per the evidence currently reported, although the evidence for neurological function supports that awake craniotomy has better outcomes, but for other parameters, although we see that in some studies, awake craniotomy has better results, but it's not statistically significant. Secondly, the one factor in which it was partially significant, that was the operating time. However, we are aware that awake craniotomy also involves other modalities like doing neurological examination during the procedure, cortical mapping, and monitoring, which actually takes a little additional time as well. So maybe that is the possible factor why this factor was not statistically significant. So there were a few limitations of this meta-analysis, and one mainly because, as with other neurosurgical pathologies, there is lack of randomized controlled trials comparing these two modalities, and plus our systematic review did not take into account other associated factors which might be influencing these outcomes, like tumor grade or tumor types, because we are aware that some tumors are more aggressive than the others. So if we conclude, awake craniotomy is a viable and non-inferior surgical option in glaucoma surgery. And I say this because some proponents of doing tumor resection under general anesthesia do mention that awake craniotomy requires more expertise. It requires more time to be done as compared to awake surgery under general anesthesia. However, as we see, the evidence does not support that. We are already aware that the evidence supports better neurological function. However, our systematic review did not study that. Thank you.
Questions?
And by the way, Dr. Saqib Bakshi's data showed very clearly in our setting also. You want to just say in 2 seconds?
Yeah. So we conducted a study comparing general surgery under general anesthesia with tumor resection as an awake craniotomy. It's currently under review at a journal. So we compared 200 cases of awake craniotomy with 100 cases of tumors done under general anesthesia, and we found statistically significant better results with awake craniotomy, including tumor resection as well as some of the other factors like the length of hospital stay. However, it's still under review. It's not been published yet. That's why I did not share the results.
Thank you. Turn
Thank
it
you.
over and change the room for the next panel.
Okay, sorry. Yeah, but I'm gonna go over there. Yeah, so I'm gonna go over there, right? Okay, all right, okay. Right, so, so the next session is a panel discussion from the perspective of global neuro-oncology. And I would like to invite Dr. Richard Moser. Is he here? Right, okay, awesome. And Dr. Anila Darbar. I don't think she's here. Dr. William Coldwell. Yes, I think, well, we will have three. I'm going to move over there. And Dr. Graham Fegan. Is Dr. Graham Fegan here? Yes, okay, great. Thank you. So we have 3 chairs. Yeah, and I'm going to move over. I'm going to go there. And Anila is not. Anila is not. Oh, okay. Anila is not here.
3 here.
No, if you leave them there.
But so with the permission of Dr. Adnan and the permission of Professor Tariq, can I invite some Pakistani neurosurgeon also? I saw just Asif ran away. We will need. Well, I just wanted to have a discussion. Do you feel like coming up here? Okay, thank you. So Professor Tariq Salahuddin has offered himself to put him to sit on the hot seat. Yes. नहीं नहीं वहाँ बैठेंगे. Yeah, those are the hot seats, sir. This is the cold seat. Yeah. All right. Okay. So, well, actually, it's nothing very to be nervous about. I just wanted to highlight the issues, over here, and many of us have those who practice in Pakistan have worked in foreign countries. I practiced in USA, in Michigan, at Henry Ford for a while before I came over here. And, it has been a journey that I'm still traveling and trying to understand how to handle these things. So I will start with the first case. This is what I'm going to do is to just present 3 cases over here and ask for the opinion on these patients. Okay. So, yeah, is this okay? All right. Yes, exactly. Free opinion, right? Except that this is done. So this is a 63-year-old gentleman who came to from the north part of Pakistan, and he you can see this MRI. Although 63 is pretty good age nowadays, but his frailty index was pretty high, and he was very lethargic, hemiparetic on the right side, and basically was not able to follow command or interact. He was sort of moribund on bed, and his son, who was 30-something-year-old, brought him from through a railways train. And I came to know that about him, this patient. I saw him. So looking at this MRI, what would be your thoughts? What should we do with this? And first of all, what does it look like? Any thoughts? We can. Yes.
It looks like a GBM.
Thank you. Yes, it does look like a GBM, and it looks like it's crossing the midline. More like a butterfly glioma. So, what should be the first step in taking care of this GBM? Any thoughts on that? Very simple answers.
Obviously, I think we are talking of debulking the tumor, and that will also give us, decrease in the ICP, and also have a histological, diagnosis.
Yes.
And from there onward, you can take up the future management.
Thank you. Do we, our esteemed foreign guests, do we agree with that plan? Right, that's what we would do.
Absolutely.
Okay.
So could I put a contrary view for the purpose of the debate? And looking at this in the context of global surgery, I think it's incredibly important for us to also think about what we're trying to achieve. And in South Africa, we currently have increasing resource limitations, and we're being forced to now consider what we're really offering patients and what the benefit is of treating. I'm not sure, in all honesty, as neurosurgeons, we have anything to offer this patient in terms of real improvement in quality of life. And in a resource-limited setting, I'm not sure that the resources consumed by managing a patient like this with an elderly individual, I'm in my 60s as well, so I'm not being ageist, an elderly individual with a GBM, I think we can all agree it's overwhelmingly likely to be a GBM, it's crossing the midline, for goodness sake. What can we really offer?
Yeah.
So, sir, I don't like you because you stole my thunder.
I'm sorry. I'm sorry.
Yes.
So, if you remember, we had a discussion some time back on particularly this sort of a thing, and we agreed on exactly what Graham said,
Yes.
which I suppose you were.
Yeah,
going
I mean,
to say.
yes. So thank you. I was just gonna put a little more spice into it, and you just like,
So, I'm sorry.
That's not right. Okay. So here's the next line. So we did talk about, as we would do it, as we all agree that Oh yes.
I have just one question. Are we treating the tumor or are we treating the patient?
That's right. So I'm coming to that point. And then you have to go beyond that, Dr. Khalik. Are we treating the patient or are we treating the whole family? You have to look at that. So I talked to the patient who was 30-something years old. He had his own few children. And I said, this is what we can do. Debulk it, get the diagnosis, go on CCRT. And he was very gung-ho about it. He wanted to go ahead with it. And, I socioeconomic status looking at it, I said, how are you going to pay for it? Obviously, about 2.5 to 3% of patients in Pakistan have insurance. So he said, well, I can manage. I said, oh, how can you manage? This craniotomy is going to cost you about 14-15 lakh rupees. In AKU, we can manage it for free. If you go to public sector institutions, you will not be charged much, but then you have to go through radiation therapy. For a quality radiation, there will be significant charge. And for a temozolomide, you have to buy on its own. It's very difficult to get that. So it will still be something about 20 to 30 lakh rupees. He said, that's okay. I will sell a piece of land. And I said, what do you do with that? He said, I till it and I earn it for my family. And how much you will sell it for? It will be about, 16 lakh rupees. And I said, okay. And the rest, I'll get some loans. So I said, think about it. If I do this surgery, I will give him on average maybe 9 months. But then your family, your children will be out of school. You will have probably no home and you will be on the street for the rest of your life. So what do you want to do? I mean, there's a comfort care that one can provide, this gentleman, or one can do surgery. Surgery is what standards are across the world. But then here in this LMIC, as you are pointing out also from Africa's perspective, I just gave him those options. And he realized, so he left. Next morning, he went home. And so 63, man, come on, I'm 62. So, and well, nobody else is more than 62, I suppose, right? No, right? Yeah. So the thing is, this is just one of the cases that I wanted to talk about, that the standards are one across the world, and what we have to think from our perspective. And I'm afraid that one of these days I may get sued because I'm not following the standards. Standard was to, and in USA, I would never think about it. Just go ahead. Yes.
Sorry, could we explore that a little bit? I'm not sure that aggressive treatment of a patient like this is actually appropriate care. And even if one has the resources, are you really actually doing the patient a favor? I mean, I think that is something, and in a way, it's questioning the paradigm that the more you can do for a patient is, the better the care you offer.
Right.
I think we need to be incredibly, and I'll talk a little bit about this just now when I talk about neurotechnology. We need to be, I think, very critical of what it is that we're really trying to achieve. None of us, even in the wealthiest countries, have unlimited resources. And I think the challenge is only going to get greater as the technology continues to progress.
Great.
I wanted to make one comment. I think certainly if this patient presented in America, I don't think anybody would question that they would get treatment.
That's exactly what I would have done in Michigan.
And the reason I think is that he's 63, he's not 83, he's 63. I think there's a big difference in that. And secondly, decompressing him could probably help him functionally right now. So I'm not quite so nihilistic is my point. I do think it's probably worth, and he certainly would get treated in America.
So it's 9 months to the father versus a lifetime of misery for the family.
Yeah.
That's what I was just proposing.
You said if you went to one of the public hospitals, you wouldn't have to pay as much, right?
Well, for surgery, but he would still have to pay for radiation therapy to get a good quality, and for chemotherapy.
Can I?
Yes.
Well, while counseling such patients, obviously, we don't have that kind of authority of the law or whatever. Nobody can ask us the questions in this country, at least. Most of us get away with it. You can't in USA, for example, from the public point of view. But I think the important part in this is counseling. For example, if they still insist, that's a different thing. But for example, I always counsel them that, look, he'll be back in the hospital in 6 months or 8 months. So can you really afford to go back and forth? Apart from that, there is no facility to support the family or the patient. For example, there is not a very good rehabilitation programs, for example, everywhere. Similarly, the person who is coming from, there is not, if he had some problem again, he will have to go in the queue in order to go for an MRI or a CT scan and all blah, 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 everything else. So, and no support, no insurance, the money has to come from, for example, ultimately selling his house. So keeping all those points in front of the most educated or the most illiterate person, whoever the family is, they usually, the decision is still theirs. So, and most of them, they agree that, look, we would like to look after him the way he is, rather than being cut and then handed over to us and we have to look after.
Professor
So
Salahuddin.
counseling is the most important bit in this.
Thank you, Professor Salahuddin.
So what I get here is that are we talking about the patients who are affording and who are not affording? Are we going to decide the what is the professional opinion about this patient?
Absolutely.
Why we are talking about the different modalities of treatment?
So if
Are
the
we
person is
sending
rich,
all our patients for radiotherapy because they have 18 months and because you see health and education is the state responsibility. So why we are saying that this patient is affording and he's not affording? He gets this treatment and the one who is not affording, he gets this treatment.
so that's a very deep disparity, and that's something that we need to. So really, there's no true answer to this. Thank you for bringing that point, Professor Salahuddin, because that's a very valid point. Are we talking about two different classes of people treating one versus the other? So I'm going to move on. We have got two more cases. This is a 13-year-old girl who developed early morning headaches and vomiting in 2018 when she was diagnosed with obstructive hydrocephalus due to a tactile lesion. A neurosurgeon placed a right VP shunt and referred her to a pediatric neuro-oncologist. She has kept her on surveillance, and since then, and several MRIs till April 2023, did not report any increase in size of the lesion. In March last year, or the year before that, the symptoms had recurred when she was diagnosed with a blocked shunt. So the shunt was revised. But then she started to have some mild gait impairment, occasional headaches and vomiting. On the exam when she presented, she was awake alert oriented ×3. Her vision and extraocular movements were fine, and there were no motor deficits. But both shunt reservoirs were found collapsed at the time of the exam. So neurologically, no symptoms, but some neurologically no deficits, but some symptoms. The last MRI in April 2023 showed slightly more dilated ventricles than in May 2022. Although there was still no hydrocephalus, this may indicate a partially blocked shunt. They sought consultation for SRS for the tactile tumor from a radiation oncologist who referred her for a stereotactic biopsy. So this is the lesion that was seen in 2018. You may notice that, just let me do this. Okay, so you can see this slightly hypointensity over here with some enhancement. You can see this in tactile region, and then on slightly hyperintensity, or it's sort of iso-intense in here, but more hyperintense compared to the brainstem. You can see over here, and on this T1 wetted image, it looks slightly hyperintense, as we saw over there, with slight enhancement with contrast. This is May 2022. FLAIR showed this lesion pretty solid, engulfing the whole tectum, the corpora cordigemina, and pushing onto the rest of the midbrain. You can see over here, but not much edema extending into the epithalamus and the thalamic region. But then there was slightly increase in size and enhancement. The pattern was changing, so one can discern a slightly increasing in size. And then further follow-up showed no significant change further. In fact, maybe slightly decrease in size. So if you compare these images on the here, so here, so 2018 to 2022, slight increase in size. That's what it looks like. But then if you compare the from 18 to 22 to 23, not much change. So now what do we do about her? She's stuck in here. If we do surgery to get a biopsy, it will be an expensive deal. And yes.
May I think this is a different ball game. 13-year-old young kid, tactile tumor. I think they are in the eloquent areas, and I personally feel not many of us would like to put hand on it, even a stereotactic. And I think if you have a good radiological report, you can go for either a gamma knife or radiosurgery and, maybe a CSF diversion procedure and to follow.
Yes, and
No, I'd like to hear your thoughts on it.
So thanks. That's a great case to consider. The first comment would be to identify the first neurosurgeon who saw her and send him or her on an endoscopy course, because this patient should not have had a VP shunt. And I think
that was one point I was going to thank you.
One opens a cascade of unnecessary morbidity here by putting a shunt.
So I have to make sure next time I make a panel, you're not in that panel. Okay, all right, great. Yeah.
So that's the first thing. The second thing, I would certainly echo the view that in children, one would be very conservative. Does she have neurofibromatosis? Because that can play a role. I've seen some of these lesions progress in the context of NF paradoxically.
No, she does not have any
neurofibromatosis. It's
neurofibromatosis.
about treating the hydrocephalus and then leaving it at that, and not pursuing the tumor.
Thank you. Bill, you were going to say something, or like to?
No, I wanted his opinion because it was really a pediatric brainstem glioma. But we would have done a third ventriculostomy at presentation on this case without question, just to avoid the problems with the shunt, and then watch the tumor. If it continues to grow, I think we'd biopsy or radiation.
Okay.
And we would continue to just watch the tumor.
Okay. Yes.
Got a question. Is there any role of MRS, MR spectroscopy?
So MR spectroscopy will not give you anything conclusive because it falls in the intrinsic tumor. It will be something of a low-grade glioma because it's been static all along. You may get a choline peak, and the choline peak may not be very high because this is not a tumor that's growing very fast.
Well, just a little out of experience. I had treated a few cases like that, and because MRS was not conclusive, as you said, we put them on empirical anti-tuberculous treatment, and they improved.
So, okay, so that's a good point of discussion. What would make you think you want to put on ATT based on what parameters? Right. But the enhancement is very limited, very little enhancement. It's more of ISO intense, slightly hyper intense on T2. It looks like a glioma, nothing else. And the ATT has its own issues in terms of somebody young of 13 years old. So that's one point of contention. The other point of contention is radiosurgery. Would you do radiosurgery on this without a histopathological diagnosis? Any thoughts on that?
Well, that's if only if MRS shows something that, for example, falls towards malignancy.
Okay. So, I mean, remember, it's been, what, 5 years? It has been sort of static. So TB is out pretty much on an MRI characteristics also. And SRS, that's another controversial point that one can discuss. Without histopathological diagnosis, the guideline doesn't suggest that. Yes, Doc Beverly.
I think the tumors in this area are very rare. There are very few neurosurgeons who can attempt to reach that area.
Right.
Nobody has extensive experience of one neurosurgeon operating more than 100 or more than 100 cases in a whole career. I think if you have got the expertise, you can do it.
But otherwise, so we're discussing this case for the whole country. I mean, yes, you can send it to one place, but then these patients have to travel 500 kilometers, to get there, to get to certain center, and will that be fair?
I think you need to watch it.
Okay. Even if it is a low-grade malignancy, you have given him the radiation
Sure.
first time.
No, there was no radiation. No. Because because, we don't know about the diagnosis.
Without
Right, right,
diagnosis,
right,
they don't
right.
get the radiation. Even the gamma knife is, people refuse to give the gamma knife without
Yes,
histopathology.
yes.
So
Jerry.
even stereotactic biopsy is
It's going to be
sometimes-
difficult because, we're talking about vein of Galen right there, and, so unless you are actually
sometimes
endoscopically
in
right.
safer areas, you are going blindly sometimes.
Yes.
I have the experience. The patient get worse after the biopsy.
Yes.
In this area.
Thank you. Beverly, you had.
Yes,
Sorry,
I'll speak after him.
She came first. I was watching. Sorry.
He's my senior.
Right. Oh, okay.
Uh,
You just stay quiet. Why don't you?
Yeah, probably she's going to say what I wanted. Because we work together at Mende Orthopedic Institute, performing endoscopic third ventriculostomy using the flexible scope. And this is what I wanted to share the information with everybody, that if the radiologist can help actually show the tumor is in close proximity to the pineoresis. And then a flexible scope can help getting the biopsy very easily.
True.
Yeah.
True. And with ETV at the same time, you get a biopsy.
Yeah,
Right,
yeah,
right.
that's it.
Yeah, we've done that. So yes. Yes, Beverly.
Yeah, so the comment I was going to make, since it's a global neurosurgery meeting, is that whereas we may advocate for ETVs, the availability of the instruments and the upskilling of surgeons across the globe. Many of the surgeons in Kenya, for example, are pioneer surgeons. So we are recommending something that may not be accessible to them. Even in my center, sometimes we have equipment issues. So even though something is a gold standard or ideal, you may not be able to effect it. So you then choose the next safe thing in managing the acute hydrocephalus. So that's the first thing around global surgery. The second one is around referral pathways. So it would be interesting to know, as we're starting out all these new centers, whether as you're developing the comprehensive plan, there's a way of feeding these people into a follow-up pathway that allows for surveillance, and as the information that we have about managing different conditions gets updated, then these patients who've had maybe an initial intervention for hydrocephalus can get opportunities to engage with more modern treatments or be involved in databases. And then the final one is around diversity and representation. You talk about NF, but most of our textbooks represent NF in the context of white skin. So if you are not white, sometimes there's an under-recognition for syndromic presentations, especially if we're looking at cutaneous markers. And that's another thing that, we need to consider in how we train.
Great. Wonderful points. Thank you, Beverly. So that was much better than your superior, obviously, those points, right? I'm just kidding. Yes. Okay. So, you have. Okay.
Last one.
Yes.
Really, to wait and watch, sometimes it's functioning, but sometimes better maybe to do something that I think it's not harmful, like gamma knife. Yes, sometimes gamma knife, they need to have a biopsy, but I asked to the more expert than me, what's your concern regarding gamma knife? Does gamma knife harmful? What kind of tumor it is? If we apply here gamma knife, what will be wrong with that in the next 10 years, 15 years?
I showed you two cases of, one was polycystic astrocytoma, one was DNET. Just in 1 year, I got all those cases who received an SRS. I'm not using gamma knife as a cyber knife but then that's the problem. We end up using radiation. If you got a hammer in your hand, everything looks like a nail to you. So, but I don't know if
Well,
most
even if radiation therapy were the decision, I don't think that the gamma knife is an appropriate method of delivery, a single fraction. We would treat this possibly with 5 fractions, still qualifies as radiosurgery in the US anyway, with 5 fractions, and maybe even more likely, more fully fractionated. Of course, image guided, everything else, but rather than the gamma knife. I think gamma knife is in fact the wrong approach to take if you were to do radiation.
Yes,
Bill. One thing I just want to make sure everybody is aware of is that there was a recent New England Journal article published about 2 months ago, and our group was involved with it, So there's IDH inhibitors used now for low-grade gliomas. And I just want to make sure everybody understands that the idea is that you need, they were actually gave them to patients without biopsy. But it's better to have a biopsy to see if there's IDH wild type or mutated IDH. But it's the first really effective treatment for low-grade gliomas. And that's now on the horizon. And
Right.
so in America, we would biopsy the tumor and see if it was amenable to treatment for low-grade gliomas medically before we radiated the patient.
So now we are seeing IDH staining on, and that's only IHC based. Very few centers are doing PCRs on that one. So the IDH status is, and then you're talking about even the next thing, using protein kinase inhibitors and things like that. That's like, so we will
But I
be,
just want to make sure people
right,
are aware of
right,
that.
right,
That's
right,
all.
right, right.
You know,
Great,
I
thank you.
understand
So
it's impractical.
we'll move on to the third case. This is a 30-year-old male who presented with complaints of headache and absence seizures for 2 months. And there you see, it's insular glioma extending into the temporal lobe. Pretty much pushed the vessels to the side, so easily resectable. And I'm just going through the images, no contrast enhancement. And this is what looked like in coronal flare. And this is post-surgery. If you notice that there is some residual left over here, and again, little bit over there, you see that. And this is the histopathology. Turns out to be IDH mutant, IDH wild type, hypercellular, though IDH wild type, ATRX retained, Ki67 was low, about 2%, and p53 again wild type. And so it was an 1p19q co-deleted. So it's a oligodendroglioma grade 2 according to new classification. So what are your thoughts? What should we do with this patient? Now, if I can bias you a little bit, so if if Oogie Dufault is over here, what will he do? And what will you do? My esteemed panelists, any thoughts on that? Please note that there is a residual over here, and it's a grade 2 oligo.
My inclination would be to operate as was done here and to attempt a gross total resection. The only question would be whether I do it as an awake procedure or not, and then go from there.
So it was done awake actually, and the problem was in awake, he could not tolerate pain. For sometimes, and when you're around the sylvian vessels and the arachnoid, just for some people, it's very. So he was not able to tolerate pain. So that's what was limited getting into that area. Although an attempt was made to go through the inferior frontal gyrus also, pars triangularis, to get to that. But again, once the sylvian vessels arachnoid was reached, it started to give him a lot of pain.
I think you did a good resection considering, but I realize that intraoperative MRI is probably not available. But I think you did a good resection. We would probably watch this, or if it grew, give him chemotherapy.
Okay, so I will put this in the context of another case, and this is the last slide. So this is a 36-year-old female whose initial surgery was done in October 2015. It wasn't awake though. And if you notice that in this picture, it's pretty good resection, except for a little bit hyperintensity in the corpus callosum. And it was 1p19q co-deleted. IDH and MGMT was not done in those days. We have recently started to do that. She was supposed to follow up in 6 months, because she again came from a very far off distance. I haven't put the slide. Our Pakistan brain tumor epidemiological study that we conducted 2 years ago has shown that in HIC, typically it's about 10 kilometers distance patient to the hospital, and in LMIC, and it is about 30 to 40 kilometers. In Pakistan, we found about 50 kilometers. About 60% of patients had to go more than 50 kilometers, and 20% of patients had to go more than 500 kilometers. So it's a huge, and then that's the reason for loss to follow-up. About 40 to 45% of patients are lost to follow-up, and about 55% of patients, once we neurosurgeons operate, we say, okay, I'm done. My healing hands have done their work. And then nobody knows what happens to the patient, whether they got their radiation or chemotherapy. So that's about 45 to 55%. That's the PB test data that I published. So this is patient that did not show up until March 2019. That's about 3.5 years later. And she had a lot of seizures. And if you notice in this MRI, there's a recurrence and all this over here. It was pretty spread out, and could not manage her any further for certain reasons. And they actually left against medical advice, and I don't know what happened to them. So with this thing in mind, coming back to this residual, what will be your thoughts? Will that change your plan?
I think now we are talking of the local conditions here, and as I think one of our guests must realize that, as somebody has made a very relevant comment, that think globally but act locally. So I think if you have problems of a follow-up, and you did a good resection, and she was neurologically quite intact, and if it was a high grade, she was even recommended to have adjuvant therapy. And if she did not, and if it was high grade, I would not waste any more time, and either would recommend to go straight away for radiotherapy or whatever type of radiation therapy, or to do nothing.
Okay. So is that
this is basically we are handling the local factors.
Right.
They are economical, they are distances, they cannot come to the right place. So these are all local factors.
Right. So global healthcare is two main things: affordability and access. So access is an issue over here. The patient coming from a distance with this lesion over here, Ugi Defoe will just kill me if I tell him that I'm gonna go for a CCRT for this patient. But then, that's what we need to do with this one, because if I take him back to surgery within a few weeks, they're gonna be a big hue and cry, and I'll be the demon of all kinds and demonized in their family. So the only thing that I can do is suggest a CCRT at this point, so that the patient goes away, at least some further treatment for their residual. That's a thought. It's a thought. Yes.
Sorry. Yeah. So thank you. Those are great cases. I just want to add maybe one point, and maybe direct a question to Dr. Caldwell, if you don't mind, Bo. So you gave a magnificent talk on skull-based tumors, and I really loved your point about the diversity of skull-based tumors, the complexity of managing them. And that, in a sense, goes to the heart of what the challenge we're faced with in terms of priority setting, that we're starting to ask hard questions about which patients we shouldn't be treating, because we have, at the present time, about 70 skull-based tumors on a waiting list, patients who losing vision, losing other function, potentially even dying on a waiting list for tumors that we know we can make a massive difference as neurosurgeons. How do we advocate for those patients? Because in a sense, that is the essence of neurosurgery, putting huge amount of effort into individual patients where we can really make a difference. And then the context of global neurosurgery, how do we do a better job of making the case for those individuals who need enormous resources invested in them, but we know within the context of neurosurgery, we can really make a difference to them?
I'm not sure that question is answerable. I'm sorry about my voice. I would just say that I'm from Canada, and they prioritize cases, as you mentioned. And my mother waited a year in a wheelchair for a hip replacement. because it's a resource limited system.
I used to see patients from Windsor in
Right.
Detroit. Yeah.
Yeah, and
Yeah.
but I know that they have a list of people with acoustic tumors, for instance, and they just take the biggest, most symptomatic one to do this week. And I think, but the cost benefit of taking out an acoustic that's symptomatic from Mass Effect is very good, as he mentioned. This is shades of gray, what you're dealing with here, because in a resource, non-limited resource environment, you do everything you can to avoid another surgery or radiation, committing them to early radiation. So they would, those are oligodendrogliomas, gliomas, and they would go ahead and try to treat them with chemotherapy, which is probably not an option for you. And I understand that. So it is, I think it's important to recognize what is optimal treatment and what is the rational treatment that you can deliver within the system. I think these gliomas are very difficult for you because they require follow-up, they require vigilance and routine follow-up, and you're not available to do that in your environment. So I think that's a problem. So in the county hospital in Los Angeles, we used to just radiate them for the reason that you mentioned, is because you're worried about follow-up. And so we just go ahead and do that. I think that's
Okay,
very
great. Thank you. We are short of time. Right. Sorry. So, well, thank you very much, my esteemed panelists. The idea was not to challenge anybody. We all gave excellent thoughts, but this is the shade of gray, as Bill, as you mentioned. So, thank you very much.
We'll be moving on to our next plenary session on global neurosurgery. I would ask chairs Dr. Randall Chestnut, Dr. Rashid Juma, and Dr. Khaliquzaman to please come to the stage.
Shall we get started? Since we're on times frame. Graham, I think you're up first, aren't you? Have you running Broncos here? So we'll start this session. Welcome everyone. With Graham Freegan, South Africa. Ethics of neurotechnology, and see what fascinating statements Graham has on this.
Okay, the slides up, please. Cool. Great. Well, thank you very much. Sorry, you've probably heard too much of my voice already this morning, but thank you very much. It's a real honor to be here at this first Global Neurosurgery Congress of the WFNS, and thank you very much to Tariq for the invitation and to our Pakistani colleagues for the incredible hospitality. It's the second time I've been here in Pakistan, and I really love this country. And we go back a long way. Our rivalry on the cricket field between South Africa and Pakistan. I'm really sorry we won this game. It was so close.
Right.
You guys really deserve to win, but next time, eh? Anyway, and maybe one of us will.
Well, now that you've alienated everybody.
Well, we won't talk about rugby. Anyway, so the reason I'm giving this talk, and it kind of feels like I'm not really sure it belongs in a global neurosurgery session, but anyway, that's where I am. So I'll try and justify why I'm here. I got invited to go to the session at UNESCO last year, and a topic I'd never really paid any attention to, and that is the ethics of neurotechnology. And I found myself there as the only neurosurgeon, which really quite alarmed me, which is why I've become, I guess, a bit of an evangelist for this issue now. So UNESCO, as you know, is this big kind of massive organization based in Paris, where every single country in the world is represented. And it looks at issues of profound importance to society, ranging from scientific research through to culture, preservation of heritage, and all sorts of really, really important things. And the idea here was UNESCO were trying to develop a guideline around neurotechnology and trying to give some sort of sense of where this field is going and how different countries around the world, and particularly through governments, should perhaps start to regulate this. Just by way of introduction, neurotechnology, I don't think a single person in neurosurgery needs a refresher on what neurotechnology is, but it's essentially, it's a whole gamut of technology that's used to diagnose and then manipulate the nervous system of humans, obviously, but also of animals. And it's a fascinating field because it sits at the convergence of really probably the hottest fields of human activity at the moment. So not just neuroscience that obviously we all feel is incredibly important, but engineering, data science, information technology, communication technology, and artificial intelligence and machine learning. You check all these things together, you've really got the most exciting area of activity, I think, worldwide right now. And this really kind of considers what happens at that intersection from the point of view of human rights and the legal frameworks that will govern this. So the different kinds of neurotechnology, the sort of history of the field is dated back to the early advent of EEG. About 100 years ago, kind of neuroimaging is clearly important. Increasingly, the devices that are being used to interrogate the nervous system, such as DBS, cranial electrical and transcranial magnetic stimulation. More recently, actual brain-computer interfaces, and I'll talk about that in a moment, and now artificial intelligence. And the main driver of the sort of ethical questions now is the extent to which artificial intelligence can start to build in a feedback loop between the nervous system and some implanted device that then could potentially start to manipulate function of the human nervous system. So UNESCO did a really great job of drawing up these guidelines on ethics of artificial intelligence a number of years ago. So now the challenge they're now grappling with is developing these ethical frameworks for neurotechnology. And there are four kind of key values that are enshrined in this UNESCO approach. And it's worth just mentioning them because I think it does reassure one that this is really a kind of valid process. The first is human rights, and Universal Declaration of Human Rights, I think, is probably one of the finest documents that we have produced as a species. I think it's very hard at the moment, given all the conflict in the world and all the discord, to kind of really see ways that we can start to kind of rebuild the kind of human unity. But I think the Universal Declaration of Human Rights is a great place to start. And that's clearly a fundamental underpinning of a process like this. Living in peaceful, just, and interconnected societies. Something like neurotechnology is going to spread all over the world. We have to find a way to do this collectively as humanity. Ensuring diversity and inclusiveness, Beverly's comments are absolutely fundamental. This is not just about technology for the privileged, it's about technology for the whole world's population. And to also think about this in the context of all the challenges our environment is facing. Why is this relevant to us as neurosurgeons? Those of you who were at Lucas's amazing meeting towards the end of last year, I thought that we were holding the World Congress in Cape Town. Turns out World Congress happened in Serbia. There were, I think, more people in Serbia at that meeting. Is Lucas here? But Lucas got the Minister of Health and the Minister of Science and Technology up on the stage, and they spoke about this. From governments are really kind of paying attention to this. It's a really important issue. Those of you who were in Cape Town for the World Congress on the last day, we were really privileged to have Grégoire Courtine and Jocelyn Bloch talk about work that they're actually doing, implanting these devices in human subjects. And so this is happening. And of course, one of the more famous South Africans, Elon Musk, is also kind of making some waves in this field with his company Neuralink and kind of potential applications to an incredibly wide range of different normal and abnormal sort of human conditions. So when one looks at neuroethics, there are two different concepts here. One is the ethics of neuroscience. So the framework that's going to guide research within our discipline of neuroscience. But the flip side of that, which is probably even more fascinating, is the neuroscience of ethics. In other words, trying to understand how humans go about making ethical decisions and what sort of neural pathways are involved in these questions of morality and ethical decision-making. That's a kind of a variation on the theme. The kind of ethical principles that become important in this discussion around neurotechnology are the notion of what's called cerebral and mental integrity, So your kind of jurisdiction over your own brain function and your thoughts and human dignity and the link between that, the link between your personal identity and psychological continuity as a human being. Autonomy, which for us in medical practice is enshrined in the notion of informed consent. And then the notion of neural privacy, mental privacy, that neural data that can be downloaded from these devices is obviously incredibly sensitive personal data and should not just be treated as ordinary health data. And all of our countries now, I'm sure in Pakistan, just as all other countries all over the world, there are increasing laws around sort of protection of personal data. And then social justice, and this is fundamentally important, I think, particularly in a global neurosurgery setting, that it's about kind of equity and ensuring access to this kind of technology for people all over the world. Another really interesting dimension to this is that I certainly probably quite naively thought about this just in the context of medical interventions. Turns out that there are a whole bunch of other kind of probably more important applications of technology. Some of them are a bit wacky. The idea of neurocognitive enhancement, I think we're a very long way away from devices actually improving our sort of mental and intellectual and emotional performance. Even more wacky is the notion of sort of moral neuroenhancement. So you've got somebody who really has kind of behaved really badly and somehow try and kind of modulate their behavior with some sort of device. I think that would be kind of quite a stretch. But here today, present, the big reality is recreational use of these devices. And the millions and millions of people around the world, particularly children, who are using all sorts of computer games and other virtual reality worlds that start to kind of engage with the nervous system, and particularly at a young age, sort of what sort of vulnerability kind of could potentially lie at the heart of that. And then finally, the use of this kind of technology in a military setting where soldiers are being manipulated in some way by these devices and obviously have very little control over what their own sort of agency in that setting. So it's an extremely wide range of applications of this technology. For us as clinicians, we're obviously used to making ethical decisions around these four pillars of beneficence, non-maleficence, autonomy, and justice. And obviously within a research context, we've got our kind of well-established kind of research frameworks for making ethical decisions. And it's interesting the extent to which the challenges now being faced by neuroscience, in a sense, mirror the challenges that were faced by genetics and the Human Genome Project 20 years ago. And a lot of the principles that are being kind of now refined around neurotechnology, in fact, were developed in the face of the Human Genome Project. So we've got a very good foundation to work on with this. From the law point of view, because obviously ethics, the rubber hits the road when it comes to kind of enshrining these principles in law. It's really important that governments understand in terms of application of constitutional principles what these new technologies mean. And in fact, Chile has actually written kind of neurotechnology into their constitution and have taken the view that, in fact, this is so complex and so sophisticated that you need a whole new set of laws to govern this. I'm not so sure about that. And I think that if we go back to the fundamental principles of the Universal Declaration of Human Rights, and we adhere to that, to the spirit and the letter of that declaration, I think we're fine. I think that is applicable, whatever new technology comes down the track. And then I said, in terms of governance, there's an organization called the OECD that has already developed about 5 years ago a really good framework on the responsible use of this technology and how we can go about innovating. And I'd really encourage you, anyone who's interested in this field, to look up that document. It's only about 4 or 5 pages, but it gives a really nice, sensible approach. And I think for all of us, it's incredibly easy to get completely entranced by the new technologies coming down the track. But it's really important we think about the process by which that technology actually finds its way into kind of clinical application. And then we take it for granted that people sort of understand about the brain, understand all these risks. But it's really important for us to kind of be part of this, engaging with not just with the public, but also with industry and public-private partnerships, and really trying to help people to understand the implications of this. So as I said earlier, either we need to refine kind of existing frameworks like Universal Declaration of Human Rights, or come up with a whole new set of laws and principles to govern this. I'm not really sure that's necessary. So UNESCO are kind of busy with this at the moment. And I guess the most important reason to talk about this is really to kind of encourage all of us as a community of neurosurgeons to kind of really engage with this and be part of it, because I think that there's a real risk that we're a small specialty, and particularly when you talk about global health. I mean, it's really amazing the extent to which neurosurgery has really embraced global surgery. I'm really proud of that. I think neurosurgery has kind of stepped up in global surgery in a way that very other few specialties have. And we need to kind of broaden that impact that we have across all the areas of activity that are relevant to us. And I think that this area of neurotechnology is massively relevant. And a very inspiring example of what we can do when we get organized is this amazing legislation that a number of people in the room were involved in helping frame this and drive this as neurosurgery and start to actually influence WHO policy. And I think that's a great example of what we can do when we get organized. Okay, so on that note, thank you very much to everybody who stayed at home to do the work while I'm in Pakistan. And I'd love to be in touch with any of you who'd like to take this discussion further. Thank you.
We have a couple of minutes here. Graham, let me ask you a question. You've painted a brave new world, and clearly we need to be cognizant of this problem. Conceptually, it's such a moving target. To identify specific risks is difficult. The actual problems that requires kind of a watchdog group, right? Is UNESCO going to do that? Are we supposed to do that?
Yeah, so that's why it's so important. It's a partnership. And one of the words on one of the slides there was anticipatory guidance. So it's about putting frameworks in place that will enable us to kind of keep pace with the, as you say, incredibly rapidly changing terrain. And I think if we go back to basics and we go back to the Universal Declaration of Human Rights and work within that, to kind of really recognize what the limits are to ways in which we can kind of interfere with individual nervous system. I think that's a good start. But I think it's also really important for us as neurosurgery to kind of be part of that and not let industry and other agencies kind of drive that.
Graham, just slightly related. Graham?
Yeah, right.
Just slightly related. So I'm interested to see that in the whole unfolding of the Neuralink story, you just don't know who the scientists are. You don't have a peer-reviewed publication. I haven't seen the original FDA submission, but the scientific team is unknown. They're hidden behind the mask of Elon Musk. Yeah. And for every development or every movement forward, it's Mr. Musk who comes forward and speaks to the world. So this is like a changing paradigm in science, where the corporate sponsor is the face up front. So I just want your views on that. Is that a bad or dangerous trend? Because it'll eventually, because one of the things that drives scientists is recognition, particularly peer recognition. So if you take that out of the equation, are we entering uncharted territory?
Yeah, Rashid, it's a great question. I mean, clearly Neuralink. So I don't know how many of you were at AANS last year, but there was an amazing session on the last day of AANS looking at brain-computer interfaces. And pretty much every program in the US that is working in this field presented their work. It was incredibly exciting, inspiring session. And the question of Elon Musk and Neuralink's impact on the field kind of came up at the end of the session. And the consensus was actually this has been positive in the sense that it's attracted huge investment. I think the figure quoted at the UNESCO meeting was something like $30 billion have been invested in this field over the last 5 years. So there's a huge amount of corporate investment. And as you say, a lot of that happens kind of behind closed doors, a lot of cloak and dagger stuff, and not the usual process of publication in journals, peer review, and absolute disclosure about what's going on isn't there. So, and I don't know how one changes that. Clearly, there's enormous amounts of money not just being invested, but profits that these companies are looking to make in the future, and how one could kind of flip that model and get back, as you say, to the more conventional way where it's more of a science-driven endeavor, I simply don't know. But I think the one way one can try to achieve that, I think, is through more open debate and open discourse and challenging what's happening and greater public awareness and people not just being seduced into believing that because, there's some shiny new technology that is going to be good for you.
Thank you, Graham, for
Thanks,
a fascinating talk and making us think. If I may take the liberty of asking you to go back 2 slides where you said the recommendation.
So I need to obviously skip over the cricket one.
This one. Yes.
Oops.
You indicated that amongst the recommendation, there didn't seem to be the need for revising the Universal Declaration of Human Rights. The issue I have, or now that we've been listening to you, is there's this huge plethora of technology coming in. And the patency laws as they exist prevent us in the LMIC countries, even when we wanted to, and if we have the capacity to develop that kind of alternates to the technology that's being developed, are being restricted by the patency laws. And what's going to happen over time is that this divide between the haves and the have-nots is just going to grow wider. I know that in India, they just said, to hell with your patency laws. We're going to do what is necessary for our populations. And I think that's like an aggressive approach. It's something through the Universal Declaration of Human Rights that we need to address those patency laws. I mean, yesterday, Randy's talk on ICP monitoring made us think, and Bev and I and Alistair were discussing, why can't we not copy, but certainly recognize the technology that exists in ICP monitoring, but avoid the situation where this excessively expensive for us technology cannot be used. And we have the mental capacity and the engineering capacity and the others over in our local environments to be able to modify some of those, but we are restricted.
Last 10 seconds, please.
We're restricted. So I'm just wondering, where does the patency laws come in with the development of this nanotechnology, neurotechnology, or whatever you call it? Thank you.
So Moody, thank you. It's a great question. We maybe need to discuss it over at the coffee break. But I guess for me, the central concept would be social justice, that has to become more and more part of the framework of how big corporates kind of engage with the rest of the world. But one can't be naive about, there's got to be patent protection in order for people to invest huge amounts of money in developing these technologies. And I think that's indisputable. And we saw that to a large extent with the COVID vaccine. I mean, that very profoundly challenged the validity of patent laws versus, unfettered access to these technologies. But clearly for big corporates, if they really do want to develop the global market, there's got to be ways in which products are available to the 80% of the world's population that don't have enormous resources. But let's discuss that further over tea. But I think social justice for me has got to be the pathway that one explores. Thank you.
Graham, thank you very much. Actually, you were the ones from South Africa who went to the International Court of Justice for social justice and human rights. And your thing was vetoed. Is there any veto power in neurotechnology as well?
Yes, I wonder.
So that is the question for the whole of intelligentsia
to
think about the human rights, for example, and social justice in Palestine, Kashmir, etc. Thank you so much.
Thank you. Thank you.
Thank you so much.
Update on stroke in the developing world.
Great. Well, it's a pleasure to be here. Thank you, Tariq, for this invitation to be here. I want to talk about stroke in the developing world. My background is neurosurgery, like yours. I did a cerebral vascular fellowship at UCLA with Neil Martin, and I thought I was an expert in stroke. I studied it a lot. We operated on people that had strokes. And when I was at the World Health Organization, they asked me to review this paper by Aaron Berkowitz, who is the directed the Center for Global Neurology, if you can imagine, at Harvard, on managing acute stroke in low resource setting. Said, sure, I can do this. And it was with, I have to confess, a fair amount of humility that I really didn't understand stroke in the developing world at all. I was an expert in stroke in California, maybe the US, but I was far from an expert in stroke in the developing world. So that annoyed me. And then the fact that WHO is doing so little for strokes also annoyed me. So we had to write a editorial, which they made me tone down because it was way too abrasive for them. But let me share with you what happened after that. So stroke is entirely linked directly with poverty. We think in terms of lifestyle, we think in terms of these other things, but the lower per capita GDP is associated with higher incidence of risk of stroke, higher case fatalities, higher rates of hemorrhage, and lower age of onset. If we're all familiar with the world map, which is good, but if you look at the distribution of public health spending, many parts of the world virtually disappear. And if you look at, let's go, the distribution of the poorest billion on the planet, suddenly areas of the world become grotesquely enlarged compared to the other parts of the world. In 2020, the Lancet Non-Communicable Disease and Injury Poverty Commission was published. And I'd just like to quote a little bit of this. But public health discourse and global solutions have generally focused on preventing non-communicable disease, including stroke, through changes in human behaviors and not addressing the inadequate resources available for the poor to be properly nourished, to live safely, and to access healthcare. Meanwhile, treatments for NCDs and injuries account for the largest gap in health financing from low and middle income countries, making a mockery of international commitments to universal health coverage, which are really ensconced in the Sustainable Development Goals. So I came to find out, this is the facts about stroke. 70% occur in LMICs, and almost 90% of the burden of disability adjusted life years and deaths occur in LMICs. The incidence has doubled over the past 4 decades, while in high income countries, it's almost cut in half. The incidence of those under 55 years of age has increased rapidly. 15 years of age younger, when people are in their peak of productivity, they're often the breadwinner of the family. Incidence of intracranial hemorrhage is much higher. This is the minimum that's been published, is about 34%, is probably much higher. And to me, this screams uncontrolled hypertension, which is in many cases the case. In some countries in sub-Saharan Africa, it's estimated that 40–50% of the population, of the adult population, are uncontrolled hypertensive. This is a huge issue. Higher case fatalities, and stroke is actually one of the top 3 causes of death in every country. So it's pretty apparent that primary prevention has totally failed. Acute diagnosis and care, little is done, and usually it's too late. If you look at imaging, imaging is almost non-existent, and even if it was existent, the patient couldn't afford it or the family. So it's not done. So you don't know if they had a stroke, if they had a hemorrhage, if exactly what's going on. The number of people that die in their villages with no idea of what's going on. And it creates economic catastrophe for families, for societies, and has political consequences. So I mentioned the Sustainable Development Goals that came out in 2015. There's very little progress. SDG 3.4 is to reduce premature mortality from NCDs by 1/3 by 2030. We're so far away from that goal. Well, most of the SDGs. And achieving SDG worldwide will cost a fair amount of money, but without it, there's huge amounts of cost associated with it. I mentioned my annoyance at the WHO and how little they were doing for strokes. Well, their stroke program is called HEARTS. And I'm like, well, where the hell is the brain? And they said, well, it doesn't matter. The risk factors are the same. I'm like, well, so some doctor in a district hospital has someone come in with a new fixed neurologic deficit. The first book you want to reach for is called HEARTS, right? You can tell my tone in the editorial was less than kind. So with my work at WHO, I started working there in 2015, right after the Lancet Commission on Global Surgery was published. And when the SDGs came out, there was a number of things happened in 2015, including a resolution. So with my connections with the Lancet, I wrote them a long email saying all the things that I've put in the previous slides. We need a Lancet Commission on stroke in the developing world. And the editor of Lancet Neurology came down, and like all my important meetings at WHO was held in the coffee shop. And they agreed we should have a Lancet Commission on stroke. And because of COVID and because of a number of reasons, it was just published last October, launched at the World Stroke Congress in Toronto. And it's available free online. You're welcome to read it, and I hope you do. But basically, there's 4 pillars: surveillance, primary, secondary prevention, acute stroke diagnosis and care, and then most importantly, rehabilitation, which doesn't seem to exist outside of high-income countries to any great degree. So surveillance, we're really looking at establishing frameworks for regular monitoring and assessment, and these are then used for prevention, acute care, and rehabilitation. They drive that information drives those further processes. And you can see how these fit into expanding healthcare delivery systems and obtaining resources for treating stroke patients. So I want to go over a few of the key findings. First of all, stroke is the second leading cause of death, third leading cause of disability, and a leading cause of dementia everywhere, even the poorest countries. Multiple factors contribute to this. I mentioned poverty. It's usually not on our top list of things that influence people to have a stroke. Major barriers to all of these, what we call the quadrangle or the pillars, is there's low awareness. Nobody knows what's driving these things. There's little evidence base, particularly in low and middle income countries. Policymakers aren't aware. There's scarce surveillance data. Just as mentioned for cancer, if you don't have registries, you don't measure it, you don't know the extent of the problem. The total cost of stroke will rise over the next few years to over almost $2.5 trillion, and a global investment in each of these areas will be needed to accelerate the achievement of SDG 3.4. we used our friends at IHME at the University of Washington to do some modeling to give future predictions on mortality incidents, et cetera. And if you look at the top graph in blue is the global estimates. The next one is LMICs. And then at the bottom, the high-income countries will continue to drift downward over the next several decades. But that gap widens between the low LMICs and the high-income countries. That gap widens with mortality. The incidence, the dailies, disability adjusted life years, all that gap widens and the burden is carried by the low and middle income countries. So key messages that came out of this commission, because of population growth, aging, all this, absolute number of people dying of stroke worldwide will increase by about 50% compared to 2020. It'll go up to almost 10 million people by 2050. Dailies will grow by about 30%, by about a third. The proportion of global stroke deaths counted by LMICs will rise to over 90%, as will the disabilities that come from that. And the costs of stroke are going to go up to unsustainable levels. This is just one disease of the NCDs. So the key priorities: surveillance. We need to measure the number of strokes. We need to see incorporate stroke events and risk factors into national stroke plans, establish low-cost surveillance systems that are sustainable, that are doable in lower resource settings, and embed regular national risk factor surveillance in the census procurement. Similarly, with prevention, we need to establish intersectoral systems for population-wide primary, secondary stroke prevention that emphasize lifestyle modifications, but also get to the undergirding problems of poverty and how people live and where they live and what they eat, et cetera. And primordial prevention, we're talking about those underpinning things that build healthy cities, universal health coverage, have access to decent medical care, wherever it is. And then primary, secondary prevention, we're more familiar with. Acute care, we need to prioritize effective planning of stroke centers. What to do with people when they have a fixed neurologic deficit and they come to the hospital. Well, make it in minutes instead of days. Establish regional networks. I don't know if any of you heard the excellent talk by Dr. Bashir yesterday on what's being done for stroke centers in the Punjab. It's extraordinary. It was absolutely phenomenal what's being done there. Looking at stroke system components so people in the community can access care quickly, and then through acute care and treatment, discharged with rehabilitation back into the community as a functional member of that community. WHO has this great cartoon of emergency care system frameworks, which picks up the happy patient, takes them to the hospital quickly and efficiently, gets them in the door towards surgery, towards acute care or stroke treatment, and then back into the community. That's great. Except the reality of it is, and you can read this, the ambulance is always broken. There's no fuel. Even if there is an ambulance to take us, there's no health worker. We just go with the family member and the driver. There's no oxygen. There's no blood pressure cuff. There's nothing except some type of a vehicle to get the person to acute care. And this is, I'm using sub-Saharan Africa, but there's many countries of the world that is exactly the same, if not worse. But ideally, there would be some kind of a stroke center that could then transport through a hub and spoke model to more advanced settings all the way up to advanced stroke centers and stroke treatment. And then rehabilitation, establishing multidisciplinary rehab services. We used even simple videos that would train family members how to transfer a patient from a bed to a chair and back to the bed again, get them up, move, range of motion exercises. Not really difficult stuff, but if families don't even know how to do that, the patient stays in the back of the house, they stay in bed and need constant care. Rehabilitation is one of the weak links, and not only for stroke care, but orthopedics, neurosurgery. All our patients that in high income settings go to rehabilitation routinely doesn't exist in much of the world. So I wanted to bring you updates on Lance Commission on Stroke if you weren't aware of it. I think it was a great thing. I take great personal satisfaction in it, even though I had to take a very good dose of humility for my lack of knowledge about strokes, but hopefully it will make some impact with this disease. So I thank you.
Thank you very much. That was, we could talk for the rest of the afternoon on this, I think, quite easily. In the interest of time, unfortunately, I think we have to move on, but.
So, it's a pleasure to invite our own Tariq Salahuddin to speak of neurosurgical training, a global perspective. Tariq.
Thank you very much, Professor Juma and the chair. I would like to thank Professor Tariq Khan for inviting me and giving me the opportunity to come and present my talk. It's always a great pleasure and privilege. But I would especially like to thank the faculty who have traveled long distance. Despite travel alerts, you are shown your courage and commitment for neurosurgery and to share your knowledge with us and with our residents. Thank you very much. I'll straight away go to my talk on the neurosurgical training programs. Neurosurgical training program is a serious and a challenging job. My paper looks into the recommendations which are global perspective and also the locally what we are doing here and how we compare it with the local with the global perspective. It starts with the recruitment of neurosurgical residents, and the neurosurgery is one of the cornerstones corresponding to a large scope of clinical pathologies and is a highly regarded surgical specialty. What we need to do, because of the lack of early exposure to neurosurgery, lack of quality mentorship programs, institutional curriculum entering prolonged periods of training and study in neurosurgery, duration of required training, and kind of a lifestyle. I think these are the factors which are responsible for decreased number of applicants. It's probably the lifestyle-friendly factors, the job dissatisfaction, long period of surgical training in neurosurgery residency, depression and anxiety. We have just talked about GBM, diffuse axonal injuries, and last but not the least, I think the number of female residents have also decreased. How to recruit the best of the best? I think we need to have strategies devised to improve this recruitment program. Strategies for the resident recruitment, mandatory clerkship in neurosurgery, medical student mentorship. I think these strategies, if you look at the different papers, neuroanatomy lab initiative program, creation of a neurosurgery interest groups, student interest groups, surgical exploration and discovery, all these above programs have shown up to 85% increase in recruitment in neurosurgical residencies. A global perspective and contributing factors of barriers to access. This is the paper which shows that, very interestingly, that in lower middle income countries, there are estimated 2.5 neurosurgeons, excuse me, per million population compared to 14.1 per million population in higher income countries. The average cost of neurosurgery in training in a higher income countries is $200,000 while the average cost in lower middle income countries is $50,000. Only 1% of neurosurgeons are trained in lower middle income countries, even though 80% of the world population lives in these countries. It is estimated that there will be a need for an additional 23,000 neurosurgeons in 2050. There's a diversity in neurosurgical recruitment programs, and what we need to do is to increase investment in neurosurgery training. This includes the development of neurotraining programs and the provision of financial support for trainees, development of standardized training modules and curricula. This would ensure that all trainees receive the same level of training, regardless of where they are located. Increased support for research in neurosurgery. This would help to develop new treatments and procedures, as well as improve our understanding of the diseases that neurosurgeons treat. Development of mentorship programs. This would provide trainees and the opportunity to learn from experienced surgeons. Is simulation training an important part of the neurosurgical training program? This paper looks into 72 studies that evaluated the effectiveness of simulation training in neurosurgery, and it showed the studies included a total of 2,500 participants. The authors found that simulation training was effective in improving the skills of neurosurgical residents in a variety of areas, including technical skills, decision-making skills, and teamwork skills. The author also found that simulation training was a cost-effective way to improve neurosurgical training. What is the future of neurosurgical training in lower middle-income countries? A call for action. The author proposed a new model of neurosurgical training that would be based on the following principles. A, flexibility, responsiveness, and cost-effectiveness. The training programs should be flexible enough to accommodate the needs of trainees in lower and middle-income countries. The training program should be responsive to changing needs of the neurosurgical workforce in lower middle-income countries. The training program should also be cost-effective so that it is accessible to trainees in lower middle-income countries. What is happening locally in Pakistan? This article shows that we need to provide a review of literature on neurosurgical training in Pakistan, lack of access to training, high cost of training, lack of standardized training programs, and shortage of mentors. This survey was done, I think, 4 years back, and I think this needs to have a very critical analysis that we did, and it showed that there was a subscription of more than one index in less than 40% programs, lack of proper evaluation of training programs in 50%, no exposure to neuronavigation technology in 70%, though it has improved to about 50%, lack of scientific publication 85% of the 85% programs, and lack of academic sessions like basic science journals club, mortality and morbidity mentoring, and in about 30 to 40%, and availability of internet facilities in about 40%, which is again also improved to about 20%. This was another good paper locally presented from Aga Khan University, and which included the distribution of the neurosurgical teams and the neurosurgical expertise services available in the country. For our 2,300 million people in this country, there are over 300 neurosurgeons available. We have about 75 neurosurgical training programs. How we are at pace with the developing countries? Africa, for number of neurosurgeons per 100,000 population, 0.01%, Asia 0.03, Eastern Mediterranean 0.37, for America 0.76, Europe 1.04, and for Pakistan 0.14. A critical analysis of the current state of neurosurgery in Pakistan shows that we need to develop new training programs. Recommended that new surgical training program be developed in an area to increase access to training. It also recommended that the government subsidize the cost of neurosurgical training to make it more affordable for trainees. Also, that the government develop a standardized training curriculum for neurosurgeons in Pakistan. And of course, recommended that the government provide financial support for experienced surgeons to mentor trainees. Are hands-on workshop helpful in training neurosurgeons? Yes, it is an important component of neurosurgical training. Hands-on workshops are an important component of neurosurgery training because they allow trainees to gain practical experience in performing surgical procedures. It can be conducted in using cadavers, animal models, or simulated patients. They allow trainees to develop their technical skills, to learn from experienced surgeons, and allow trainees to practice in a safe and controlled environment. Research is the most important segment of our training program. Research is an essential component of neurosurgical training because it allows trainees to learn about the latest advances in the field. Research can be conducted in a variety of settings, including academic institutions, hospitals, and private practices. There are a number of benefits to research. For example, trainees to stay up to date on the latest advances in neurosurgery. It allows trainees to develop their critical thinking skills. It allows trainees to publish their work in peer-reviewed journals. Medical database. You need to have this equipment, this tool to have your research publication. A medical database or record-keeping neurosurgery provides a comprehensive learning resource with a level of real-world cases, enhancing trainees' educational experience. It enables evidence-based decision-making by analyzing clinical data to identify treatment of efficacy and complication. Additionally, the database supports continuous quality improvement in training program by monitoring outcomes and refining educational strategies. A very important segment that we must look into is the number of female neurosurgeons coming to neurosurgical training program. According to one study, it makes about 17% of practicing neurosurgeons in the United States of America. It is from 3 to 7% in Pakistan. And the female neurosurgeons face a number of challenges, including lack of role models, work-life balance, and gender bias. What we need to do is to provide more role models, address the work-life balance issues, and challenge gender bias. Does the training finishes once they have completed a program of 5, 6, or 7 years? No. I think they need to go into fellowship program. Fellowship program offers specialized training beyond standard residencies. Neurosurgeons gain expertise in fields like skull-based, endoscopic brain and spine, functional neurosurgery, and endovascular procedures. Benefit includes improved patient outcomes, reduced complications, and advancement in neurosurgical techniques. Exposure to complex cases and cutting-edge techniques, mentorship from experienced specialists, collaboration and knowledge sharing among institutions and regions, development of specialized centers of excellence, and strengthening the neurosurgical community through networking. It is very important that we must embrace ourselves with the recent advances. Technologies like robotic surgery, assisted platforms enable precision and dexterity in delicate procedures, improving safety and reducing invasiveness. Animal lab are also important parts of the training program. Last but not the least, I think collaboration and support from developed countries can significantly enhance neurosurgery training in underserved regions. For example, by providing knowledge exchange in training programs, technology equipment donation, research collaboration and funding, training workshops and outreach program, and sustainable partnership and mentorship. With this, I thank you all very much.
Thank you very much. Big problem and obviously very regional in the solution. Do we have, I mean, I was thinking on both ends of the spectrum, do we have good information on why students don't choose neurosurgery rather than why they do? And on the other end, how can we improve the attractiveness of neurosurgeons practicing where they're needed?
Yeah, I think the responsibility is both on the trainees and also those who make the policy. Because you see, we need to provide all those facilities where we are going to send our trainees or the neurosurgeons who are going to work and practice in this area. So I think we need to have that environment. Until unless that environment is there, even a trained neurosurgeon will not be able to serve. So I think it works at both ends. We need the onus of responsibility with the trainees to train them to meet the bare minimal standards and the challenging standards, and of course the recent advances. And as I said, what are the recommendations which are international recommendation? But at the same time, the policy makers must ensure that the job availability and the environment is there for them to serve in that area. Gail.
Yeah. Whoops. Thank you very much, Tarek, for that really interesting and well thought out presentation. Wanted to just follow up with two comments about the gender issue, as you can imagine, and also an economic equity issue. And it just underlines the importance of all of us being here for a conference like this and being able to talk about differences geographically in the problems that we face. So for instance, the gender issue, I'm sure there are things that we can do to talk about issues in Pakistan. It's not perfect anywhere, but I'd like to share a positive thing about the Global Neurosurgery Committee and this community. And that is when there was a political crisis in Afghanistan, just a few kilometers from here, there were 8 women neurosurgeons, residents already in training, and some faculty who were immediately excluded from operating rooms. And it's this community that I'd like to thank for having found places for them outside of Afghanistan where they can continue their training. So a basic fundamental thing that we're doing right together. The second thing that you highlighted that we can work on together is the economic equity issue. It is a basic problem in countries where neurosurgery residency, in fact, all postgraduate medical education is tuition-based rather than salary-based, that you're going to have a very hard time developing your workforce. Now, that's going to involve a lot of debt restructuring issues, and that's why we're working with the World Bank and at WHO, but that may be our next target, is to make sure that residents are paid a salary rather than being tuition-based. Otherwise, it's very hard to establish a specialized workforce.
Very right, Gail. Thank you very much. And I think that is what is required by the leadership, which is the global leadership of neurosurgery, and also the policymakers. It is very, very difficult for people like us, and I think hats off to Tariq, that despite whatever is happening around, and we have our share of political problems and other economical problems, but the economic constraints, it really creates a major problem when we do not have that much funding available to create that environment where we can have the best possible training programs.
Right. Just another reason why groups like this need to continue to meet on a regular basis to work together to solve these problems. Thank you.
Well, so I think we have time for one more question and then we can continue.
Just very quick comment. I just want to say, we keep thinking that Europe and the US is sort of the gold standard, but I'd say there's a lot that the gold standard could learn from what's going on in the developing world, how to do it efficiently. We've got very inefficient neurosurgery in the developed countries, and maybe we can learn by partnerships a lot from what's going on in Pakistan and sub-Saharan Africa. So you don't always need a lot more money, you just need to be more efficient.
Very quickly, we are actually slightly back on time. We'll be a small announcement. The tea break has been cut short to 15 minutes. It will be taking place at the exhibition hall, where Dr. Franco Cervede will be opening the exhibition. And we have actually instructed the organizers to help you get to the venue. We'll be starting our next plenary session near the pool. Yeah. The next plenary session is on neurotrauma. I'll ask the chairs, Dr. Sirajuddin Bilkhair, Dr. Tariq Salahuddin, and Dr. Ahmad Ali Shah to please come to the stage and take the chairs.
Okay, we will start with the next sessions, which is a neurotrauma session. The first presentation will be biomarking neurotrauma outcomes in LMIC against international database. And the presenters are Rabal Akbar and Rashid Juma. Are they here? Rashid Juma?
I'm here.
Yeah, okay, please.
Okay. Assalamu alaikum and good morning, everyone. I'm Dr. Rabi Akbar, and today I'll be presenting our ongoing research, which is titled Benchmarking Neurotrauma Outcomes in Lower Middle Income Countries Against International Databases to Globalize Standards of Care. I do not have any relevant financial relationships with any commercial interest that pertains to the content of my presentation. Okay, so TBI, traumatic brain injury, is a silent epidemic that not only affects the patients, but its consequences reverberate on a much larger socioeconomic state. And multiple landmark papers and traumatic epidemiological studies have been carried out in the past. And these show the risk of death significantly decreases if the patient presenting with a TBI is taken to at a specialized trauma center with dedicated trauma teams than a non-trauma care centers. Realization of trauma centers not only decreases delays in care, but they also ultimately reduce the number of preventable deaths and irreversible injuries. So after establishing that, further researches were done to see the efficiency between various trauma centers in particular regions. And it was shown that despite being labeled as designated level 1 trauma care facilities with similar resources, there was a wide array of difference of outcomes at all of these trauma centers. And this was then further attributed to actually the quality of care that was provided at these trauma centers. So the quality of care that actually pertains to these institutions, the differences in these quality of care actually led to different variations in the outcomes of the patients who presented with traumatic brain injury. So there's a need for monitoring and identification of specific quality care indicators at these various trauma centers so that good outcomes can be achieved. The goal here is to aim for good outcomes, basically zooming in on and to basically zooming in on the quality care indicators that can be further improved. So it is also a well-established fact that traumatic brain injuries affect lower middle income countries more than higher middle income countries. And there's a long list of exhaustive reasons for that, so we will not really delve much into it. However, rapid urbanization in lower middle income countries with poor road infrastructure, combined with the fact that the general population is not actually aware of the habits which predispose to traumatic brain injury, such as low use of helmets or seat belts, actually lead to a higher prevalence in lower middle income countries. Another fact is a glaring paucity of published data on TBI mortality and morbidity, which leads to poor assessment of the quality of healthcare in lower middle income countries. So most of the data that is published in the literature comes from higher middle income countries and not from lower middle income countries. So assessment of quality care and improvements in the system of the healthcare cannot be properly established. So the traumatic brain injury guidelines are actually made by higher middle income countries, and they're not actually representative of the local population seen in the lower middle income countries. And these lack of relevant traumatic brain injury guidelines actually they cannot be adequately practiced in lower middle income countries due to lack of resources and technologies. And there's no organized set of databases of the past cases which can be used to actually improve or modify these TBI guidelines according to the relevant population of lower middle income countries. So there was a study, a large European study called Center TBI. And then China compared their findings with the Center TBI guidelines, and they found out that across various trauma centers in China, there was a difference in outcomes. And this is what we're aiming to do in our study as well. We want to compare our data set with Center TBI, and we want to see the differences in outcomes to identify areas of improvement. So another important factor which adds into the mortality rate of traumatic brain injury is third delay, which is a delay that occurs when the patient presents to the emergency department till he actually receives neurosurgical care. And the odds of death increase with Third delay. So Center TBI is a large registry of 20 European countries with more than 22,000 patients, which was conducted between 2013 to 2031. And the aim of the study was to identify healthcare policies so that improved quality of life is actually the goal. So what we did was that we compared our cohort of patients with the Center TBI core study. And the aim was to identify what are the differences in outcome and if our current in-hospital management is adequate or comparative to these large international globalized studies. So this study was carried out at Jinnah Postgraduate Medical Center, which is one of the largest tertiary care hospitals in Pakistan. It is situated in Karachi. We have a specialized trauma team with a dedicated neurotrauma ward consisting of ICU and HTU. The inclusion criteria, patients of all age groups were included in the study. And these patients had clinical diagnosis of traumatic brain injury based on the history of injury, the symptoms, as well as the neuroradiological parameters. Patients who presented after 3 hours from the time of trauma were excluded from the study. So were the patients who were directly discharged from the emergency department not taken to the neurotrauma care center. So we used a 95% confidence interval for the large population and with unknown prevalence of traumatic brain injury, unknown frequency of traumatic brain injury. And the sample size was approximately 384. And we rounded off to 400 to account for missing data and patients who were lost to follow. This is an observational prospective cohort study. And the data that was collected using medical records. And then follow-up was done using telephone call at 6 months. And we assessed 2 types of outcomes, the primary outcome and the secondary outcome. The primary outcome is in-hospital mortality, and the secondary outcome is Glasgow outcome scale extended at 6 months. This is the outcome scale that we used, which has 8 parameters, 1 being dead and 8 being upper good recovery. And then a structured interview was done using telephone calls and patients' dependency, as well as dependency after trauma was done. And these are the patients who were discharged at home. And then at 3 monthly and 6 monthly, we followed up these patients. So after acquiring approval of ethical committee from both hospitals, that is JPMC and Aga Khan Hospital, data collection was started. Complete data was collected until death or discharge, which is the outcome, for 265 patients. And follow-up is done at 6 months, which was completed for 211 patients so far. So talking about results, in our study, 79.2% of the patients were males, whereas only 20.7% of the patients were females. We compared this data with Center TBI data, and we found that 67% of patients were male in the European study. And in the Center TBI China study, 74% of the males, which is actually closer to our number. So the age population in our cohort was between 90 to 60 years of age. That is young and the middle age group. Only 6.7% of the patients were more than 60 years of age, and 26.4% were less than 18 years of age. And this is in stark contrast to what we saw in the Center TBI study, in which majority of the patients were either elderly or children. And as you can see, then in Center TBI, the median age was 52 years, whereas in our study, the median age is 30 years. And this is actually just to show the population pyramids of European population and Pakistani population. And in Pakistani population, the younger age group, the middle age group, and the children predominate compared to the European study where the elderly population predominates. And that could be one of the reasons of the differences in the populations in both these studies. So in 70% of the cases, motor vehicle accidents was the cause of traumatic brain injury. In large part, that is because of the road mix that is seen in Pakistan, which is basically unhelmeted motorcycle population as well as pedestrians. In the Center TBI study, motor vehicle accidents were actually lower in frequency, that is 38.3%, and patients having falls were higher. They also, because we just mentioned previously that it was the children and the elderly that presented with traumatic brain injury to the trauma centers, and that is another reason why the frequency of fall is higher. In our study, we saw then more than half of the patients which presented to us actually had moderate to severe traumatic brain injury. And this is in big difference to the center TBI, in which only 1/3 of the patients had severe traumatic brain injury. Only 41.8% of the patients had a mild head injury. Another reason for this could be that a lot of the patients were actually just seen in the emergency department, not brought to the trauma center, and were not included in our study. So that could also account for the lower number of mild TBI. So in our study, we noticed that women had 300% higher odds of in-hospital mortality than men. And in center TBI, it was seen that in females presenting with mild TBI, there were more unfavorable outcomes and worse quality of life. And in moderate to severe TBI in the center TBI study, they did not find any difference. However, when we applied Fisher's exact test to our study, we saw that women had higher odds of mortality than men, irrespective of the severity of the traumatic brain injury. So out of 265 patients, 232 patients had intracranial injury in the form of a hematoma. And the most common injury that we saw was a contusion. Interestingly, subdural hematomas and extradural hematomas actually had similar frequencies. Okay, so talking about the outcomes, the primary outcome was in-hospital mortality. And as you can see in our study, the mortality was significantly higher. It was 29.5% as compared to center TBI, which was 8.7%. A big factor for this is that more than half of the patients that presented to us actually had moderate to severe traumatic brain injury. Therefore, they had high mortality rates as compared to center TBI. We also compared this study with the center TBI China comparison study, because the age population in the China study was closer to ours, as well as the gender demographics. But even then, center TBI China study actually had only 5% mortality, which is lower than the center TBI study. And the patients who actually discharged had good recovery. They showed good recovery. We followed up 211 patients for 6 months, and we saw that good recovery was seen in majority of these patients. The 6-month mortality rate was quite low. It was actually lower than the center TBI study. And a GOSC of less than 5 was seen in 1.8%, whereas in center TBI study was 25.4%. So our long-term outcomes were actually better than the center TBI study. So in conclusion, I would like to say that TBI severity in female sex have higher odds of in-hospital mortality. Young males during RT are the most common demographic that we see in our population. TBI severity and mortality are higher than center TBI, but the outcomes at 6 months are actually better than what we saw in the center TBI. Future studies should be done with collaborative and comparative studies with international standard databases, so that we can identify areas of improvement, and a detailed comparative analysis with center TBI dataset is coming soon, because the study is still ongoing, and we've already sent a proposal to the center TBI, and they've accepted to do a comparative analysis of our dataset with their database once the study is complete.
Your time is up. I'm sorry. So you please conclude.
So I would like to conclude by saying that good collection of data with meaningful comparisons with more developed healthcare systems should be done, and this is necessary for improved quality of care of these patients, especially in countries like Pakistan, so that we can identify specific quality indicators and monitor them. Good patient care and favorable outcome is the goal. So I would just like to acknowledge the center TBI study for their help in our study. These are the references. Thank you so much.
Thank you very much. Thank you very much. I think we need to go on to the next talk, and the speaker is Mario Ganao. He's going to talk about the traumatic brain injury and chronic traumatic encephalopathy.
Thank you very much. Okay. Yes, my name is Mario. I'm Mario Gano. I'm a consultant neurosurgeon from Oxford. I'm going to discuss today a little bit about the wide spectrum of traumatic brain injury and what eventually might be a risk factor for developing chronic traumatic encephalopathy. I do not have conflict of interest for this talk, and the aims will be to discuss the heterogeneity of TBI with a focus on concussion, and provide some historical consideration on CTE and the unmet needs of neurotrauma centers in MTCs. Heterogeneity of TBI. This is a slide that I often use for my medical student in Oxford, and I like to classify TBI in open and closed. And obviously, there is a wide difference between the two types of TBI. Similarly, the management of a penetrating brain injury such as this one would be extremely different from the management of a patient with diffuse axonal injury. And those conditions are completely different in terms of clinical presentation, in terms of medical and surgical challenges, and in terms of diagnostic criteria. And certainly in a patient with diffuse axonal injury, despite the lack of large post-traumatic space-occupying lesions, there is evidence of severe destruction of the structural integrity of the axons. And this is the reason why the diffuse axonal injury has its own classification according to Adams. I'm not going to show images from concussion because we know that by definition, concussion should have a negative CT and negative MRI scan. And this makes it extremely difficult to define concussion. However, as I say to my students, and perhaps you will laugh, concussion is like love. When you have it, you recognize it. This is a study which was conducted in Toronto, senior author again, Charles Tatter, looked at all these studies that have been included in the clinicaltrials.gov database. And out of those studies, he had 225 interventional and 95 observational studies. Only 109 had a definition of concussion. And the interesting thing is that the definition of concussion was very variable within those 109. So they could not even provide a unified definition. Because of this lack of a unified definition, then we also have a difficulty in trying to map the incidence of concussion all over the world. From our perspective, our contribution from my team to global neurosurgery, we provided a mini review which was published in neurosurgery, and we expanded the research not only to clinicaltrials.gov, but we included all the other databases from other parts of the world: Germany, Japan, South Korea, Brazil, China, the Netherlands, New Zealand, European Union, and Africa. And we identified a significant number of other articles. However, we reached the very same conclusion from the Toronto group, a very wide definition of concussion. So this indicated the need to work collaboratively to identify this large subgroup of patients, particularly because there are two aspects that are related to their management. One is it's extremely difficult to understand how to deal with concussion, particularly for us as neurosurgeons. We do not have a surgical indication for them, so we might tend to downplay the significance of concussion. However, we very well know that there is a syndrome called second impact syndrome. And this is intrinsically related to the lack of a recognition of concussion. If a young player has sustained a concussion, for instance, and returns to play and unfortunately sustain a second impact, there is a small but significant risk of dying instantaneously as a result of a sudden brain edema. So historical consideration on CTE. If we look at the publication on CTE, they expanded very rapidly since 2010. And this is related to the very, very, precise definition of CTE. This slide has a factual inaccuracy. And this is related to the fact that by using the mesh term CTE on PubMed, all the publications started from 1949. However, the very first definition of punch-drunk syndrome, which is effectively what we now define as CTE, is dating back to the late 20s. And this condition was eventually defined as dementia pugilistica, thinking that it was affecting mostly boxers. And then, thanks to this man, Dr. Omalu, who was practicing in Pittsburgh, we had a formal definition of CT, which was based on histological evidence. And Dr. Omalu is kind of a hero of mine. He's a Nigerian doctor who migrated to the United States, completed his training there, and eventually was involved in the post-mortem of Mike Webster, a very famous center from Pittsburgh Steelers, who unfortunately died. And at times of his post-mortem, it was possible to identify very specific histological features on his brain. And this led to a seminal publication from Dr. Omalu, in which he defined the pathognomonic lesions of CTE as an accumulation of abnormal phosphorylated tau in neurons and astroglia. And the position of this tauopathy is very pathognomonic. They tend to occur around small vessels and at the depth of the cortical sulci. So that in recent years, we had a classification of CTE from stage 1 to stage 4. And you can see from these images taken from McKee et al. How the tauopathy progressed till to a very demarcated destruction of the cortical sulci. And this movie was based on history of Dr. Omalu. And effectively, this gave me the opportunity to discuss something else which is relevant also in terms of global neurosurgery, how inputs from movies and social media might enter the public debate and influence the decline in exposure to risk factor. In fact, what happened is that the participation to American football at the material level has constantly declined since 2006. Also as a result of the public awareness about concussion and its impact on our youth. So what does it tell us in terms of unmet needs of neurotrauma services? This is an article that I had the pleasure to co-author with Professor Tariq Khan and with one of our senior neurosurgeons working in the UK with us, Mr. Amir Panezai. And in this article, we conducted a scoping review of the literature, assessing basically the protocols, guidelines, and best practices for management of traumatic brain injury in neurotrauma services. And I'm grateful to Dr. Akbar, who has just concluded her talk, who gave a very good definition of neurotrauma services based on center TBI study. This is our original contribution. We created a matrix of unmet needs. And as you can see, some of them relate to the lack of structured pathways for mild TBIs, for concussion, and eventually for management of patients that are at risk of developing CTE. Why it is important? There is a recent study which was published on JAMA surgery, which indicated that 95% of brain donated by former football players showed signs of CTE. So this is an epidemic. It's not something that is that rare. The problem is that it is still unrecognized. So which framework should you use to consider a prevention intervention? So I want to refer to this a very important book, which identify 4 types of prevention interventions. One is meant to change in individual behaviors. And as I say, there has been a decline in amatorial participation in tackle football. Or intervention modifying products or agent of injury. And we know how important has been the development of new helmets to prevent, and to, in a way, decrease the severity of injuries. And then intervention meant to modify the physical environment. I think something like the shift from tackle football to flag football, which obviously expose less to the risk of concussion and is an entirely different type of game, is an intervention that is meant to reduce the risk of exposure. And then there is something else, modifying the sociocultural and economic environment. And I left a question mark here for a very simple reason. So I don't know how many of you have watched the Super Bowl. During the breaks, there was a very nice spot, which was about the program for international players. And this is good, provided this is an opportunity to give access to people from all over the world to play in the NFL. And I personally believe this is a very good intention. However, in the spot, which was shot in Dakar, there was not even one child with a helmet. And so we really need to have equity of opportunity. We need also to have the same type of protection and pathways in place all over the world, so that everyone can get the chance of thrive, but also the opportunity to avoid unnecessary risks. With this, I conclude. We are currently writing a special issue on TBI and CTE.
Time is up. You need to conclude.
Yes, I would be very happy to welcome your submission, and there will be no article processing charges for low and middle income countries. Thank you.
Thank you, Dr. Mario, for a nice presentation.
Thank you so much.
We don't have time for questions, so we'll go with the next presentation. Dr. Hanashi Shabani. The title of the presentation will be Trauma, Including Neurotrauma and Becoming the Leading Cause of Morbidity and Mortality.
Assalamu alaikum and good morning, everybody. I thank the organizers with the leadership of Professor Tariq for inviting me. It's my first time to be in Peshawar. So I'm going to share with you a very short story of our success with management of neurotrauma in Tanzania. The information is based on a single center. We have 4 centers which actually are referral centers in Tanzania, which deal with the management of neurotrauma. And 2 of those 4 centers, we have managed to do a clinical audit. We have terrible data. We have terrible database on TBI. So I don't think this audience is ready to hear about our bad stories. So I chose to share with you something which is so nice, and this is on spine trauma. So this is the hospital I come from. We have 90 beds located for neurosurgery, 16 ICU beds, and 16 HDU beds. These were just completed very recently since 2020. There were 2 neurosurgeons in 1996, where there was an affirmative action to train neurosurgeons. And currently, our institute has 13 neurosurgeons and 6 spine orthopedic surgeons. So you can see we are capable of doing spine surgery with this number of staff. The department is also a training institution, and we're collaborating with the universities abroad. And we're dealing with all the scopes care. And except epilepsy surgery and the other one. I shared with you this slide before, and you can see the burden of neurotrauma. Yeah, this is just a single center, and this is just a monthly encounter at the Muhimbili Orthopedic Institute. And just to give you a nutshell, because we published this paper in 2017 of brain tumor, of traumatic brain, the mortality from severe TBI is 70%. And adherence to the guidance of the Brain Tumor Foundation was actually far away from the reality. So I cannot share with you this data. But if you want to read, you can find in the Journal of World Neurosurgery. We published one paper there. So let's move on to the spine. And for 5-year, just 5-year audit, this is the number of patients whom we collected at our institutes, about almost 600 cases. And the surgery rate is low, but you can see that surgery improves the outcomes in terms of death. And this is the trend of our audit. There's a rising number of cases as we keep on. And most of the patients in this data are young patients. And they come from motor traffic crash, mainly the motorcycle. The pattern of the disease is mainly lower cervical and mid-thoracic. And they come with variable neurological deficit. Almost all of them have neurological deficit. So we did, this audit was done just before requesting for grant, because at this time we had no enough implants to give to patients. And you can see here that only 40% of cases would get surgery. And this surgery was actually related to the patient affordability to the service. So mainly the public who were subsidized. Of course, here you can see the number is much higher than those who could pay, but it took very long for them to get the service. So it accounted for the length of stay, and this one was also associated with the rise in comorbidity in terms of urinary tract infection, chest infections, and also the pressure ulcers. And if you compare with the previous data, with mortality as well. The paradox here you can see, most of our patients, because of they cannot afford the services. So the tendency of surgeons was to, after the X-ray, straight to the MRI. So CT scan was rarely used. Another reasons for delay was the location, the distance from the hospital. So those patients who were very far from the hospital came to hospital very late. And this was related to the referral system and also the transport. So we had a chance to collaborate with Weill Cornell University, and we developed this protocol. And our objective was to increase the surgery rate and reduce the time to surgery. And we got free implants from the Puys in this at that time. And if I can show you the grant period we received in 2018, and you can see there was a sharp rise in surgery rate. And this grant stayed was only for 2 years, and you can see immediately after grant, we remained again to square one. So, but I will talk about this on the next topic. So let's move on. But what happened when we got the grant? Everybody was very enthusiastic. So each patient who arrives to hospital, because now we have the protocol, which actually says patient should be operated within 3 days of admission. Fast track for radiology services, fast track for the blood donation, for blood transfusion and everything, and prepare the cases for theater, central surgery. There was an increase in mortality, and this mortality was mainly in the patient's category of cervical spine. And we noticed this was our fallback because of the preoperative care. But the other good story was that this is the one I want to show you. But the other good story was that the cost of care has been analyzed by other systems, was correlated with what we did, and the bed sore rate actually significantly reduced at this period of time. So in summary, this is what I can tell you. I mean, low and middle income countries, we can adopt surgery for spine trauma patients, and actually it confers a better advantage than not doing surgery to these patients. Thank you.
Thank you very much. I think we can have one question. If somebody wants, we can have just one question. Okay, thank you very much. We have to proceed for the tea outside, and I think it is only for 15 minutes. Please come back in 15 minutes. We are really running short of time. Thank you very much.
It is in the exhibition. It's in the exhibition hall, please. Thank you. I'm Siraj. I'm originally from Libya, but I'm the chairman of Ali is Ali Reza. Right now, no, actually, we have 17. Really? Yeah, I'm 15 residents. And we do more than 1,000 cases per year. It's a big department. We have intraoperative CT scan, intraoperative MRI, hybrid room, all the tools. Also, our residency program, I want to give a comment to you.
Hey, you're everywhere. Like you. Well, you can't get everywhere, unfortunately. Yes, if you meet with this, it means about very big stuff. It's a very guys, yeah. It is, and then about the Joseph have 2 planes in the air, and in both planes at the same time, it's the same guy. So, well, in Dubai, we have delays, and I think I already did on the CIA flight yesterday afternoon. The frigate comes up and Pakistan and Iraq. Yeah, they fly. Well, they fly more quickly. It's just worked out time, but and both our planes were, I think, from India and we came from Cape Town. They both were delayed. We almost missed the flight. Yeah, I met more people in lounges than I've ever seen. The guy from San Francisco that I met in Asia too, but I don't see it all. It's 30 miles away. Yeah, I guess when you're in the States, you work all the time. Anyway, it's always so pleasant to see you. Yeah. Oh, yes. Yeah, I saw the SENS meeting for the EANS in the fall.
The Budapest one. What kind of?
Budapest is right, a good time.
When is it? Budapest is.
Right before the.
Yes, back to back.
Yeah.
For those who come from far away, it's good. For those who are in Europe, do you think you will go? Literally. From Sen's area, will also go.
We direction. Yeah, it's like one day, everything goes the next day. I mean, I get those. Yeah, by car, it's Italy. By car.
Hopefully it will go. No, it's whether people can be away from work. That's the only difference, right? It's whether you can get the result. But
Calling sick.
I mean, always. I know, but and then they see a photo of you on the on the internet.
Party afterwards.
But on the whole, Budapest is beautiful.
Yeah, I haven't been there. I haven't been there either.
Sofia is modern. Yes, yes.
That whole area.
So,
We'll be ahead. Yeah, okay. Yeah, I've got to run. But having some basic surgical exposure beyond neurosurgery would be really helpful, if it was possible. Thank you, Norm. Wow. Oh, what is this? Oh, yes. Okay. In your house, right? Oh, did it? Wow. Beautiful. Okay. Really? That's why they did it in the Philippines. Because I did recognition, medical mission, I do. Those are my
I think it's all the I don't know. All of those that they because it's in audio. Before the pandemic. This one I just visited last year. This is like
Thai food, yeah, it's very beautiful. Yeah, I saw that. Yeah. Oh, the whole car.
I'm speaking and talking also.
Why is why?
See? Are you going up? Oh, are you, where are they going? See? Oh, see? The tea is downstairs. I thought here it's. Okay, wait, maybe we'll just bring this. It's downstairs. Are you bringing, should we bring our bag? Maybe we should bring our bag.
You are bringing.
Yeah.
No problem. No problem. There's no problem.
Let's bring one. Okay. This one I leave here. Okay. Okay.
It's no problem.
See, okay, see. It's downstairs.
Yeah.
Okay, oh no. So I'm just saying that.
अच्छा डिवाइडर लगा था वहाँ पे क्या करना वहाँ पे क्या करना है वो मुझे उसमें क्या करना तो है तो इसमें डिफरेंट डिवाइड कीजिए इसमें क्या है हाँ?
So this is the scientific session 3. The chairs are Dr. Ahmed Fawad Pirza, Dr. Imad Talama, and Dr. Riaz Ahmed Raja. I don't see them here yet. Okay.
Yeah.
So each presenter will have 10 minutes. Please restrict your talk to 8 minutes, and then we'll have 2 minutes for the question and answers.
So welcome to this session. And we'll take the first presentation from Professor Corrado Carino from Italy. Posterior wiring with sublaminar polyester bands, titanium peak fixation system for C2 fracture management. Professor Carino.
Thank you. This presentation is about a system. This system is object of a publication in a recent published on Journal of Spine Surgery. It's about this device is a flat and flexible polyester bands with a band tensioner and fixed with this small titanium peak fixation system. This is the intraoperative imaging. It's thin bands. There is a dedicated instrumentation to pass under the lamina, but you can pass for every kind of instrument that can help in these maneuvers. And after that, you pass the band under the lamina on C2 and C1 or C3, C2 or C1, depending on the band, you can fix with this system of tension. It's a manual system of tension, so not automatically. So there is the sensitivity of the surgeon to understand when the tension is reached. And this is the intraoperative control. This C2 fracture. And you see how there is the reduction of the fracture during the maneuver on tension. So when you reduce the fracture, you can fix and close the system. And this is our casuistic, our cases. We use these in case of failure of conservative treatment for transverse course C2 body fracture. Is a 69-year-old male, and at the emergency CT scan, there is the evidence of this transverse full thickness C2 fracture. And the patient was treated with 1 month of rigid Philadelphia cervical collar. And this is the control after 1 month with increased fracture with a diastasis of 2 millimeters. So we decide to treat the patient with this technique of posterior fixation with the C2 wiring with tension band. Or we use this technique in case of failure of conservative treatment for Anderson-Alonso type 3 fracture. Is a 2 patient. Case A is male, 47 years old. Case B is a male, 76-year-old. About the same kind of story. The case A waited 3 months, the Minerva cervical thoracic collar. The case B, 11 months. The CT scan showed instability with increasing of diastasis of fracture. So just the case A waited for additional 6 months, bivalve collar. Anyhow, when also case A reached an increased fracture diastasis of 3 millimeters, so we decided to perform the surgery with additional period of cervical collar in postoperative follow-up. So this is the case 1 and case B when there are the CT scans after failure of the treatment. So it's showed how the diastasis is increased. And this is the control, 12 months postoperative for case 1A and 3 months for the case B, where there is a reduction of diastasis and a pseudoarthrosis results. Another kind of patient, this is a Jefferson type 1 plus Anderson-Alonso type 3 fracture, is a female of 80 years old. The first row is, the first column is the preoperative CT scan, and the patient is 80 years old, with obesity, under DOAC, with a chronic obstructive bronchopathy, diabetes mellitus, and another additional prognostic factors that is a mother-in-law of our intensivist. And so we decide with him the best treatment, and we decide for the wiring, posterior wiring. This is the postoperative. The second column is a postoperative CT scan. The third column is a 3 months postoperative CT scan, and the last column is 1 year after the treatment. And the last patient, the last case, is Langman's type 2 fracture. He is 24 years female, and this is the last case because we became much more familiar with this technique. So we propone in this fracture the techniques, and this is the 6 months postoperative CT scan for the results of reduced fracture. So the results is during the surgery is more or less 2 hours of operating theaters with a maximum fracture reduction on average of 2.4 millimeters, blood loss, less than 10 days of hospitalization like average. And the pain was soon showed a soon resolution with just first day of painkillers pills, and all the patients who had worked prior returned to work. So the advantages are very simple, and with no need of navigation and minor lateral dissection of the paraspinal muscles. Of course, the disadvantage is still now we have to reach the tailor-made indication. I mean, there is no absolute protocol, so it's the disadvantage that you have to choose this technique for each patient, talking with the patient and to reach the best solution for the patient. And in some cases, not with this instrumentation, not with this device, but we know that the posterior wiring could be associated with the passage of the instrumentation, but this is much more linked with device, with metallic device, while these polyester bands are a minor risk of spinal cord injury. So the key findings, final key findings, and that maybe for patient, fragile patient, elderly patient, or failure conservative treatment, this device could be much more indicated. Thank you.
Thank you, Professor. Thank you, for Professor Aikarino. One question, please. Yes, sir. Professor Chestnut.
For the last one,
Any like a hangman's, I'm just thinking one fracture type, but with the hangman's fracture, if you just pass 2 lag screws and lag it back and do an osteosynthesis, it's very cheap because it's 2 orthopedic screws, and it automatically reduces the fracture line. So I'm just wondering how you would balance
respect to the screw. Respect to the screw. Yes, the period of the surgery and the risk of the damaging of the artery or the nerve, but but essentially for the duration of the surgery, and it's much more easy. There is some surgeons that are not dedicated to the spine surgery, and this technique could be dedicated for that surgeon. To screw C2, C1, you need some much more skilled surgeon. To pass a band under the spinal could be proposed also for a simple spinal surgeon that make degenerative disease, but without instrumentation.
Dr. Credio, thank you for your presentation. I just have a question. For the first few cases, how did you justify, since you don't know what's your results, how did you justify using it in the first place? Secondly, those patients that you showed, I would have done surgery from the get-go because they're ultimate for failure. I mean, it's like C1, C2 harms the procedure. But my first question, how did you justify your first few cases with this new technique?
How to justify to use in case of failure?
Yes.
because the conservative treatment is favored, and we cannot be much more aggressive with screw instrumentation, and this could be proposed as a rescue. I mean, this is not a technique that have to substitute the screwing technique. This is a rescue technique. It's a simple technique. All we know that the screwing technique is not for all surgeons, but for spine surgeons. This is a reality. If we are talk about real world, of course, if you have a surgeon that is able, that is skilled for screwing, it's natural to screw. But you can propose this, especially in some environment where we know that we have no available skilled surgery for surgery. So the C2 screwing for example, the last patient with the fracture of C1, a fracture of C2, 80 years old, obesity, DOAC, mother-in-law of intensivist. So the intensivists know very well the complication of screwing, and he accepted this kind of solution. It's not the best solution, but it's enough solution.
Fair enough. Fair enough. We will go with the next presentation since we don't have much of time. The next presentation is Salman Sharif. Thank you. The next presentation for Dr. Salman Sharif. It's for perioperative and what's that? I could not see it.
Perceptions and beliefs regarding spine care.
Perception and belief in spine care. I could not see it. But
Glasses or
that looks like them.
Thanks.
The light.
Assalamu alaikum. Good morning. So my name is Dr. Riba Tariq, and I will be presenting our study with Dr. Professor Salman Sharif about beliefs regarding back pain and spine care among suburban population of a lower middle income country, that is Pakistan. So we know that back pain is a common medical condition that affects millions globally, and the number of patients suffering from back pain is expected to increase to 843 million by 2050. This is a study. In 2018, a study showed that 28% of men and 31.6% of women aged 18 and older experience low back pain. But literature failed to show any study in Pakistan regarding the bias in seeking care for back pain based on patients' personal beliefs. We saw a study from Canada that showed that 38% of people who sought care for their back pain when they had one. A demographic study was done in Ghana also, which also showed that influence of social cultural factors on low back pain and late health seeking behavior of patient. So what we tried to do is that in this paper, we explored the challenges that are faced by the individuals with back pain in slum areas of Karachi and discussed their opinion on how things can be changed. So the objective of the study was to determine perception, beliefs, and associated factors regarding seeking care among patients with back pain in 2 suburban communities of Karachi. It was a cross-section study. We collected this data from the local welfare clinics, which were located at Landi and Bath Island. Bath Island is an area which usually receives patients from Hijrat colony and usually slum population by a team of investigators that were asking questions. A survey form was made on Google Forms, and it was filled by volunteers on the field. 259 patients were included in the study who had back pain, and the inclusion criteria were adults over the age of 18 who had back pain in the last 12 months. So we used descriptive statistics like chi-square and Fisher exact test, and a total of 259 complete responses were received and analyzed in the study. The median age of participants that we found in our study was 32, with an age range of 18 to 75 years. And most of the study participants were female. This is the demographic data of our study. So we divided patients into different age groups. In 18 to 40 years, this was the majority of our population. And then 40 to 50 and above 60. And gender, male and female. As you can see, females constitute a major group of our study. We also divided patients on the basis of their monthly income in Pakistani rupees. So patients who were earning less than 500 were around 24.8%. Those who were earning between 500 to 1,000 rupees, like this is very less. It's 46.9%. And between 1,000 to 5,000, 16.3%, and more than 5,000 Pakistani rupees per month were only 12% of the population. And we also asked them if they have a government-funded hospital or a spine care unit available in their reach. So the majority said that there was no hospital in their reach for spine care specifically. Some other participants said when they were asked about what they do for their back pain, they said they do nothing when they have back pain, 31.9%. The majority said they usually apply gel and take usual medications when they feel back pain. And only 10% said that they seek medical advice when they have back pain. The frequency of doing nothing when back pain was significantly higher for the lower income groups. The use of gel and medication and when feeling back pain was higher for people with higher monthly income. So this was the bias that we saw in our study. So the most important part of this chart is this monthly income chart. So as we can see that patients with low monthly income usually do nothing for the back pain, while those who have a monthly income between 500 to 1000 Pakistani rupees usually take gel and use medication. And the frequency of seeking medical advice is usually more in patients with higher monthly income. And this p-value is significant as well. Then we asked an open-ended question that how things can be improved. So the more and why they don't seek medical care. So the most common reason was financial restraints that was seen in 64.5% of the population, followed by lack of medical facility in the area, a lack of time, social construct, and 3.1% patients said they have some religious beliefs on why they don't seek care for their back pain. This was an open-ended question and how things can be improved. So according to majority of the population, things can be improved if they have better healthcare facility available in their reach. While around 18.6% said they have no idea on what to do, 17.4% were of the opinion that if medication are easily available, things can be improved. While 4.7% of the population thought that rest and exercise, these things can improve back pain. So what are the important points of discussion? Is that currently we don't have any high-end study from the lower middle income countries regarding back pain. 85% of the world population actually live in lower middle income countries. And in Karachi, Pakistan, extensive slum areas harbor residents which endure harsh living conditions, inadequate healthcare access, spinal issue, proliferate due to strenuous labor, and substandard living condition. So our study showed the perceptions and the beliefs of people on back pain and how things can be improved. The study results were similar to a study done in USA with definitive implication of financial status on seeking healthcare. We also surveyed the population, asked them their opinion on how things can be improved, which was something different. But our study has limitation, like all the studies. First, it represents a small convenient sampling, so findings may not generalize to whole population. And again, we take our sample from the patient who actually presented to the clinic. So those were the patient who actually thought that their back pain is severe and wanted to seek medical advice. And again, interview was conducted by the volunteers. So there's a bias there as well. And usually the study was done in data was collected in daytime. So the male population was usually laborers and they were working and were not present in the clinic. So females were the most population that was present in the clinic at that time. So to conclude our study, it showed that back pain is a common condition, but its treatment-seeking behavior is dependent on the income of the patient. And patients with low income, usually they do nothing when they have back pain, while those with higher income take medication and they have access to specialist care. So making spine care affordable and easy access to poor can improve care in the slums of Karachi. Thank you.
Thank you, Doctor, for a nice presentation. Any question for her? We have one question. Yes, go ahead, please.
So I guess it'd be interesting to find out over time, what is the difference in the outcomes of the people who didn't seek care because they didn't have the money and those that did that. So we'll be interesting to find out a year later, what was the status. I note that you say back pain and you didn't mention leg pain. So, and I say that because in a very large study that was published from Holland a number of years ago, about 10 years ago, the recommendations that came out were do nothing, minimum rest, followed by a period of light activity, and simple measures was good enough. So your majority population that don't have the money obviously know something that is important to listen to.
Okay, we'll go to the next presentation.
Thank you.
I don't see him around. That's what I'm wondering. The next presentation is, according to this schedule, is supposed to be from Professor Shabani from Tanzania, where I don't see him in the audience. Professor Shabani? I don't see him here now. That's what I'm saying. Okay, we'll move to the next.
We'll move to the next. As our next presenter is Vladimir Kowalski. He will give us a presentation about surgical treatment of craniocervical fracture, motion sparing techniques for the most demanding case.
Well, so I will address the same topic as Corrado has already addressed. Even the patient, the cases will be very similar, but the approach would be slightly different, mainly anterior approach. I would say that C1, C2 complex injuries accounts to up to 1/4 of cervical spine injuries. Typically, we classify them with Anderson-D'Alonso type 1, type 2, type 3, and we sometimes do not remember that motion range of the craniocervical junction is crucial. Atlanto-occipital junction is responsible for half of our range of head and neck flexion, and the C1, C2 junction is responsible for half of the range of our head and neck rotation. So it's very crucial to spare the motion. So in every method of C0, C1, C2 fracture treatment should first ensure stability, but second should aim to preserve mobility if it is only possible. The problem is that we often achieve stability at the expense of mobility, but we should think if both goals may be achieved. So I would say my speech will be about our way in pursuit of motion preservation. So what are the problems which we have in this field? First, complexity of a fracture is sometimes an obstacle to preserve mobility. Then bone quality, very poor sometimes in osteoporotic patients. Risk of pseudoarthrosis. Oblique fracture fissure with significant shrink force, severe sagittal imbalance, and patient non-compliance, and the difficulties in reduction of fractured bone. So I will try to give some examples how to manage with these obstacles. First, non-compliance. If we have a non-compliant patient who will not wear the collar postoperatively, sometimes we have to propose him 2 screws to eliminate the micro movements to secure stability from the very first moment after the surgery. Sometimes we have very old people, and this is a case of a 97-year-old lady with severe sagittal imbalance in which these shearing forces will act very, very, very strongly. So what may be the shearing force is very prominent. So what may be the answer? The answer may be 2 screws, but posed not on a frontal plane, but on a sagittal plane to make this construct more rigid in reaction to flexion extension forces. So this is the case we have operated on like this, and this lady has been seen at last follow-up at the age of 101 year, and she was still independent. Here is the range of motion postoperatively. It should be relatively quick. So this directional way of screw placement sometimes is a solution. Next problem, extreme osteoporosis. We know from the mechanical analysis of these connections, of this osteosynthesis in C2 level, that adding a plate make it more rigid, significantly more rigid. So if we have the bone which is poor quality bone, then a part of the screw which is connecting the fracture, we may also add the plate, and the plate will secure this. And this may be the solution for osteoporotic patients. So this is the case which we operated like this. Sometimes we may also use this screw, single screw, as non-standard non-standard treatment for motion sparing procedures in some traumatic indications, some other traumatic indications, like for instance C2, C3 instability. Then we may, this is a so-called teardrop C2 fracture with instability between C2 and C3 level. And what we may do, we may again place the same screw, but on a somehow different way, going through C3 vertebral body and going back to the going up to the odontoid peg. So this may solve the problem of so-called teardrop with very short anterior approach procedure. And of course, while it is motion sparing technique, because after half a year you may remove the screw and then everything goes to normal range of motion. Well, next problem is complex fracture. Sometimes complex fracture may, at the first glance, exclude the possibility to spare the motion. This is the case in which, as you can see, the head and the C1 vertebra of this young man has been cut off from the rest of his vertebral column. Unfortunately, there is a gap between C1 and C2 lateral masses, and there is also the anterior posterior displacement of the odontoid peg. But again, we may use this screws technique with the bilateral transarticular reduction of this fracture and odontoid peg instrumentation, and again the possibility to spur movement is in the fact that after half a year or at least 1 year you may remove the transarticular screws and everything will be still in motion. Well, so this is the reduction we have achieved in this patient, the reduction in AP and sagittal correction. This is how these screws have been posed, both bilateral transarticular and odontoid peg. And another case of complex fracture may be very similar to that what Corrado has been presenting, but with different approach, with posterior but motion sparing screw approach with direct repair of this laminar arch fracture. So this is what we have done. We have done a direct short screw fixation of this direct fixation of these fractures. This may be done either in open way or open surgery, but also in minimally invasive surgery type. And this is the result. We have successful to reduct these fractures. And this patient, the advantage is that this patient may be mobilized just 1 day after surgery, and he may go home next day after surgery. And so we have achieved the fusion, and this is the result. And this is this gentleman. I don't want to bore you, but there is the range of movement of this gentleman. And so I may summarize My conclusions are that first, what is the feasibility? Motion preservation, as I tried to convince you, motion preservation is often an achievable goal, even in cases of very complex craniocervical fractures. Second, what is the current practice? Current practice is mainly posterior stabilization, which is always correct and always works, but sometimes it seems to be a kind of over-treatment. Blocking the possibility blocking motion possibilities. And third and very important question, especially in this meeting, accessibility. I would say that single or double screw, which is necessary for this kind of fixation, is the simplest and the most cheap among existing spinal implants, which is very important. And just as my last message, since several years, I'm trying to share my experience in this motion sparing techniques, and I feel like being a missionary is trying to widespread the gospel. However, it makes me a lot of joy. It gives me a lot of joy because this term, motion preservation technique, motion sparing technique, is being used more and more widely, and this is the case. This is the publication this is the work which has been published just recently, 2024. It comes from Beijing, from China, and it is anterior and plantar-axial motion preservation fixation technique for axis complex fractures, which designs very similar technique which I was presenting.
Dr. Kowalski, time is up.
With the screw and the plate. Thank you very much.
I have a question while we are changing speakers. So what's your failure rate with motion preservation technique that you are having? Like, that's an important question. You showed us the ones that really worked well, but how about the ones that didn't work well?
There are several issues which has to be addressed. First, the main risk is lack of osteosynthesis. But if you use double screw does not raise the mechanical resistance of the construct. Irrespectively, if you use one screw or two screws, the resistance is the same, but it gives you another advantage. It reduces the micro movements which are responsible for non-fusion. So you are using sometimes the double screw not for rigidity, but for reduction of this excessive micro movement, which may lead to non-fusion. And what is very rarely mentioned, that if we classify the result of such kind of fusion, normally we use the terms, only two terms. It's dichotomic division, fusion or not fusion. But in this case, in odontoid pack surgery, there is another third category which is frequently used, which is fusion, non-fusion, and intermediate stable non-fusion. So I would recommend this double screw technique because it may support this, even if it does not achieve the full fusion. It supports the stable non-fusion state, which may persist for several years, and in elderly person it gives you the advantage to be mobilized very quickly and to avoid collar neck bracing. Okay, thank you very much.
Yeah, I think I have a comment, and I would like to say, first of all, that very good presentation. Difficult area to tackle surgically, especially patients who are neurocompromised. And also that if it is, posterior approach is very difficult in patients who are already neurocompromised, and they also have a cardiovascular instability. So I think this probably would be the ideal approach for C12 fixation. Thank you very much.
Thank you.
Sorry, now we move to the next presentation. Dr. Amishi is here. Can you please come up? Challenges in establishing a comprehensive spine trauma care in low-middle income country. A case from Tanzania.
Yeah, sorry for being late. I was interrupted by...
Please try to keep to time.
Yes.
Thank you.
Yeah, my presentation is too short because it's a continuation of what I presented in the beginning, in the first presentation. I'm taking the second part, which I showed you on the graph. These are my disclosures with this project. Initially I showed you this slide, so I have to move on. And this one, this is the one I want to show you. Before we started our project, this was our status, and we made our affirmative action by ourselves that we are going to do audit and follow up, and we produced this paper, and then we had collaboration. And just to show you the collaboration, this was our 5 steps collaboration strategies with the collaborators from abroad. We made sure that we have our annual global neurotrauma course, which we invite experts to come and do training, and not only doing training, but also performing surgeries for 1 week, so that local staff can gain skills and technologies from abroad. And then a continuum consultation through weekly telemedicine conferences. And just to enhance on our database skills and analytical skills, we also emphasize fellowship exchange. And this is where we managed to request for several donations and fund appraisals and collaborative research program. And these images I've shared with you here are very important. They show that we started involving our policymakers from the start. The picture you see on the bottom left, this is the Minister for Health in our country, who was invited to inaugurate the first annual global neurosurgery neurotrauma course. And we shared with her our plights. And the second picture, this was the first, was the executive director at that time. And Roger Hatto, as you can see, our international director. So this one I've shown you the protocol, and through that we managed to get fancy equipments, not only the donations of implants. We managed also to get the Neuro Navigator. So we started with the 2D Navigator. Currently, we house both machines, the 2D and the 3D Neuro Navigator, which are connected to the 2-plane CM, and they can adapt to the CT scan. So we can do self-surgery to spine patients. This one I've shown you before. This was the effect of donation. You can see, and abruptly, when the donation of implants stopped, you can see the last the last histogram showing the number of surgeries going down. So the question that there arises: when there's no grant, what happens? Fall in surgery rate. That's one, and then fall back again to square one. Complications. So we asked ourselves, what can we do to improve that one? So this is the crux of this discussion on this topic in this presentation. So we said we have to move forward. So we expanded our international collaborations. Currently, it's not only Weill Cornell Medicine New York, which is collaborating with us. We enticed other collaborators like University of San Francisco, California, and established the African Spine Project. So the African Spine Project now is under the umbrella of the College of Surgeons of East and Central Africa. The COSEXA, where I belong as the program director, comprises of 17 nations, way up from Ethiopia to Namibia. So we intend to start that project. And then the policymakers, as I said before, everything we involve these people. So our president at one time inaugurating the conference, and the Minister for Health at another occasion. So with that and persistent involvement of our junior doctors and specialists publishing papers, and this one is the most important paper, which we usually use it as a flagship presentation every time we go, that surgery reduces the cost of spine care. And then we did some modifications. This is something you cannot find in the first world, but the use of discarded the drainage tubes and the bottles is safe for this kind of cases. And our training, even during the COVID era, we managed to do the training, and we persisted. And this is what I can show you, how many papers we have produced in the PubMed. The third category we involved was the public, and we enticed and convinced the survivors of the spine trauma to establish their own NGO and become the advocates for all the questions which we cannot address, like the implant supply and rehabilitation projects. So what I can share with you, this is my last slide. What I can share with you is that if we want to do a comprehensive spine project, it has to be a 360 involvement, where you have to create yourself as a center of excellence, involve the policymakers from the beginning, and international collaboration. And not only one university, one institution. I think if you broaden the collaboration, this is how you can achieve and become effective. Thank you very much. I'm just inviting everyone to our next next month, the Global Neurosurgery course. This is what we do with our collaborators.
Thank you, Professor Shabani. We don't have time for questions. We are already 20 minutes late. And this is the conclusion for our session for this topics. And we will go with for the next session now. So I will invite the chairman for the next session to come to the podium.
So this session is about spine/miscellaneous topics, and the chairs are Dr. Russell Andrews, Dr. Corrado Carino, and Dr. Naveed Ashraf.
Okay. So I invite next speaker, Roberto Stefini from Italy, to talk about the anterior cranial fossa middle angiomas. His choice when, how, and why transsinusal frontal approach can be a good options. Roberto, please take your time. The timer counter is 8 minutes. 8. 80 minutes more 2 minutes for questions. Up to you.
Yeah, thank you. Thank you for the invitation. Thank you, Professor Tariq, for this beautiful meeting. I want to share with you my experience regarding the midline meningioma of the anterior cranial fossa. The midline anterior cranial fossa is like a corridor, like a canyon, in which if we want to enter in the canyon, there is a door, and we should open the door. The door can be the frontal sinus, and if we open this door, we have a direct approach to the dural implant of the midline meningioma. This is our series of 74 anterior canal fossa midline meningioma, 56 olfactory groove, 15 tuberculum cell, and 3 diaphragm cell meningioma. All of these cases were approached by transfrontal sinus approach. It's a problem of the Kirus classification. It's how deep is the lateral lamella. In case of Kirus classification grade 3, the lateral lamella is very, very deep and can be difficult to remove the meningioma inside the olfactory groove using a pterygium approach, subfrontal approach. We divide this kind of approach in 3 stages. First stage is cranial stage. Second stage is extradural stage just for olfactory groove meningioma. And the third stage is intradural stage. The cranial stage, of course, we do a bicoronal skin incision with the careful preservation of the periosteum. Do osteotomy, we use the piezo, and it doesn't care how is large the frontal sinus, but we every time do the same size of the frontal of the osteotomy. With the size of 6 or 7 centimeters, it can be removed even large giant olfactory groove meningioma. After that, remember the cranalization of the frontal sinus is very, very important, and drill the posterior wall of the frontal sinus. This is the cranial stage. The extradural stage, just for olfactory groove meningioma, it's very important to preserve the dura. Don't cut the dura, but with the preservation of the dura, drill the cristagalli, detach the meningioma from the skull base, and in order to reach the cistern of the optic system. In this way, it's very important the deliquoration. Deliquoration and weight. Deliquoration and weight. After this stage, the third stage is the intradural stage. We cut the dura. There are some different anatomical experts between olfactory groove meningioma and tuberculous cell and diaphragm cell meningioma. In case of olfactory groove meningioma, the different aspect can be if there is an invasion of both olfactory fossa or just one olfactory fossa. For instance, in this case, we cut, in this case where the meningioma have only a left side invasion of the olfactory groove, detach the meningioma from the skull base and from the olfactory nerve, detach the meningioma from the brain and the front orbital artery, remove the meningioma. In this case, we remove meningioma in just one piece, and it's important for us to preserve the left olfactory nerve and the olfactory artery. in this case, when the olfactory groove meningioma is very, very large, we use the subfrontal approach and interhemispheric approach in order to detach from the skull base the meningioma and to remove the cap of the meningioma through the interhemispheric approach, like in these cases. In case of tuberculous cell or diaphragm cell meningioma, we approach this kind of meningioma just interhemispheric approach, like in this case, or in this other case where there is a vascular encasement with many, all of Willi cycle are involved in this kind of meningioma. In this case, we cut the dura, cut the fax, go just interhemispheric, not subfrontal, but interhemispheric. Look at the pituitary stalk, the carotid artery, the right optic nerve, detach the meningioma from the optic chiasm, and the basilar artery using the aspirator, ultrasonic aspirator, and remove all of the meningioma, detach the meningioma from the PCOM, right PCOM, and this is the final overview, the dorsum cell, the right carotid artery, the basilar artery and the stalk, and right carotid artery, A1, right A1, both A2, and left A1, and left carotid artery and optic nerve. This is the postoperative immediately MRI. It's possible to do a combined approach, a transsinus endonasal approach. Remember the three layers closure. We like the Gaxskill technique with the Haddad flap. The result, the Simpson grade was 49-63%, grade 1, and grade 2, 30%. We had 3 cases of grade 4 Simpson grade. That's our tuberculous cell meningioma. In 2 cases, we have a recurrence after 3 and 5 years. This is one case in which the recurrence was in ethmoidal sinus. And the smell, postoperative smell function was maintained in 14 patients, mainly tuberculous cell meningioma. The complication, we had 6 cases of CSF rhinorrhea. It was in the first series, and in 2 cases were reoperated, 2 cases for meningitis, 1 case of hydrocephalus, 2 deaths not related to the surgery. Be careful to the lateral lamella, how thick is the lateral lamella, and do before surgery, do a CT scan in order to check how is thick the lateral lamella. This is our publication. In conclusion, this kind of approach can be easy and can have an early access to the vascular supply, early identification neurovascular structure with, of course, minimally retraction of the brain and a complete removal of the dura incision. It has a good aesthetic result and a low complication. Thank you.
Thank you. Any burn questions? Just a question, if you can say a few words about the reconstruction phases. I mean, do you use only a layer of periosteal, or you use also some additional bone or fat or synthetic device?
Doing a bicoronal skin incision, the layer of periosteum is very large, so it can be used just periosteum, plugging the frontal sinus with the periosteum and the periosteum over the frontal sinus, over the basal frontal bone.
And just a quick question. What is the rate of olfactory preservation? Olfactory nerve preservation.
The rate?
What is the rate of your olfactory nerve preservation? Because it is one of the most.
I said that during we had the 14% of olfactory preservation, mainly for the tuberculous cell meningioma. For olfactory growth meningioma, we had 3 cases in which the monolateral invasion, and we can preserve just one olfactory nerve, and the olfactory can be preserved.
All right, thank you. Well, if there are no further questions, then we can move to the next presentation. It's Dr. Ruha Nasser, who's going to talk about the comparison redo surgery versus radiosurgery in recurrent pituitary adenomas. We all know there are really a number of challenges in recurrent pituitary adenomas with various treatment options. Dr. Nasser, please.
Thank you, team. Hello and good early afternoon. I'm Ruha Nasser, and today I will be talking about the outcomes for redo surgery and stereotactic radiosurgery for recurrent, residual, and/or tumors that show progression in non-functioning pituitary adenomas, a systematic review and a meta-analysis. I disclose that I have no conflict of interest. There's a bit of a background to non-functioning pituitary adenomas, as we are well aware. They present incidentally, most likely after resulting from effects of mass effect, and they're well-differentiated benign tumors that range from 22% to 54% of all pituitary adenomas. They're highly variable in their clinical presentation, diagnosed incidentally, but also with visual deficits and endocrinopathies. Treatment involves either serial neuroimaging, repeat surgery, revision surgeries, or radiotherapy or stereotactic radiosurgery. Non-functioning pituitary adenomas can recur, they can progress, or they can present as residual tumors after incomplete resection, which is actually 60% in the cases of subtotal and 30% in cases of gross total. Our objectives of the systematic review and meta-analysis were to compare the effect of reduced surgery and stereotactic surgery, primarily under the domain of tumor size, visual deterioration in existing hypopituitarism, and any development of any new endocrinopathy or any other complication. Our methodology involved following the PRISMA templates. There were no randomized controlled trials that were available, so we included only single-arm studies with observational cohort studies and cross-sectional studies. All studies were in English language. Our inclusion criteria had both endoscopic and microscopic under transsphenoidal surgeries, and we also expanded the transcranial surgeries. The non-functioning pituitary adenomas were involved, which had either undergone progression, they recurred, or they were residual in nature. Our primary outcomes, as elucidated earlier, were either reduction in tumor size, deterioration in hypopituitarism, or worsening of vision. This is the methodology. This is the PRISMA chart that can be seen here. We identified records from 1970 till June 2020. And we followed the PRISMA guidelines as the template. 13 records were identified with a total sample size of 1209 patients. We pooled the risk ratios and 95% confidence intervals using the random effects meta-analysis model. These were the included records. Majority of them had fair quality, save one by Swords in 2009. These were the records with redo surgery. So our primary outcome was with tumor size. What we saw that, so we studied both the pre-intervention and the post-intervention changes in the tumor size. The pre-intervention prevalence was such that non-functioning pituitary adenomas presented with larger tumor sizes if they were going for redo surgery, which is in line with literature as well as compared to SRS. And post-intervention, all cases, 100% cases in redo surgery experienced 100% reduction in tumor size. SRS group displayed a lower reduction in tumor size. This is the prevalence in tumor size. As we can see that majority of the tumors that had larger tumor sizes were in the redo surgery group. Under visual loss, we saw that the prevalence was higher in the group that was presenting with revision surgery as compared to SRS. And post-intervention, there was more visual loss with redo surgery as well. This is the prevalence for the visual loss. Moving forward to endocrinopathies, this was the prevalence should have been higher for the cohort of patients presenting for redo surgery. However, in our group, the prevalence was higher in the SRS group, which is contradictory to the existing literature. Post-intervention, we saw that redo surgery was strongly associated with panhypopituitarism as compared to SRS. SRS had fewer cases of diabetes insipidus. Our surgery could not go into the details of the subtypes, but they were part of the systematic review, not part of the meta-analysis. Some of the notable limitations that we saw were that there were no prospective studies, no randomized controlled trials, no class 1 evidence available to carry out direct comparison, but this was a study which ended in 2020. So perhaps there are more studies in the literature that we're also looking for, perhaps in the future. SRS studies, SRS requires time to generate effect. And since tumors that are progressing, so primarily to just conclude after limitations, so SRS studies were constrained by a follow-up period of less than 5 years. They require at least 5 to 10 years to demonstrate their effects. Comparison on histopathological subtypes or immunohistochemical analysis was not included at all. Long-term data was not available. We could not ascertain the effects of neoplasms or tumor recurrence or development of other endocrinopathies. Conclusion at the end of is redo surgery is the superior choice of treatment in the treatment of recurrent residual tumors that show progression in non-functioning pituitary adenomas. It is highly effective in debulking immediately as compared to SRS. And it is also the the preferred choice if tumors are presenting with a larger tumor size. Redo surgery is associated with a higher risk of visual loss, new endocrinopathies, and other complications in contrast to SRS. SRS with a conformal regimen that spares the pituitary gland and optic apparatus can be a viable alternative in tumors of small size, frail or elderly populations, and can also achieve a satisfactory tumor control. These are my acknowledgements. Thank you very much.
Thank you very much, Dr. Nasser. And the house is open for discussion if there are any questions. So, is there any experience with the aggressive variety of recurrent tumors, pituitary tumors? What would you suggest for them?
My personal experience was part of the systematic review.
Yes.
Doc, we did not include the aggressive nature of the pituitary, non-functioning pituitary adenomas. And as much as I'm aware, this was not a modality that we discussed so far.
And what would you suggest to the house in case of recurrent pituitary tumors, which are aggressive in nature?
Oh, you're talking about the subtypes as well. So
would it be a redo surgery repeatedly, or at some stage would you like to do or go for radiosurgery?
cannot say unless there's data that's available. Perhaps in the near future, we can look into more data and actually generate a meta-analysis. Our meta-analysis is restricted by the time frame and chronology as well. It ended in 2020, so perhaps there are more studies that look into that. I did not come across any.
Up till now, it is the repeated redo surgeries for these patients because
The
that is
yeah.
yes, for the aggressive tumors.
Okay.
Right.
Thank you so much.
Please. So we move on to the next speaker.
So our next speaker will be Igor Trifonov. He's talking about VNS, vagus nerve stimulation. Definitely a interesting topic.
Thanks. Hello to everybody. Thank you for the opportunity to present our work. Yesterday, I talked about the epilepsy surgery, resective epilepsy surgery. In this case, when you resect the typical case with temporal lobe epilepsy, unfortunately, not all the patients, 1/3 of the patients will not receive seizure-free. So that's why it's happened after the 1 year, it could happen after the 5 years. For last works, it could happen in 10 or 20 years. And we have a question, what to do? First of all, we should do MRI to look, is it fully resective surgery, for example, amygdala and hippocampus. But for example, from our colleagues from Italy, last year, it was the work that if you leave the hippocampus for example, posterior, it will not change the seizure-free. So about non-epileptic seizures, it's very hard theme. You know that 1/3 of the patients with the average year of the epilepsy treatment for more than 10 years, they have 1/3 of non-epileptic seizures, which are very hard to therapy. Is the next question, is the patient use anti-epileptic drugs? Sometimes they doesn't want to use it after the epileptic surgery. And also you need video EEG seizure registration to look what the onset zone is now. MRI, sometimes it's our clinical cases for the first years. We on this MRI, you can look that we not just fully resected the amygdala and hippocampus. For that patient, we made gamma knife for residual part, and you will look only 12% of the patients become seizure-free after this procedure. And the satisfactory results are near the 60%. The next non-epileptic seizure is a typical seizure. You look AG, our young doctor speak with the patient. It takes near the 10 or 20 minutes. When the patient come to me and tell the seizure is near 10 or 20 minutes, it's not the seizure, it's non-epileptic seizure, really, because the typical seizure couldn't be more than 2 minutes. If the real seizure is more than, in different definitions, 2 or 5 minutes, it's the status epilepticus, and you need to treat it immediately. For example, I love video from that from the mobile phone, when we always ask the patient and tell the patient to video the seizures at home, because unfortunately it's not working, but it's here, it's a non-epileptic seizure. What about INTD treatment? What kind of doses the patient use? Maybe he used not proper doses or not proper schemes of therapy. So what to do? The VNS or stereotaxic brain stimulation is the palliative methodic to do with the patient. Mechanism of VNS is release of neurotransmitters, blood flow, EEG changes, and after the different publications, after the 1 or 2 years, it's become anti-epileptic effect on the brain. Because of negative electrode generates an action potential, and the positive is blocking, so that's why it's became the some effect to thalamus. It looks like this. In our clinic, we have near 100 patients with VNS stimulator. How it's look like the patient position, conducting the electrode, fixing. We put it VNS implanted. For last, I think, 5 years, it takes near the not more than 20 minutes for the surgery for hands. It's our outcomes. It changes every year to Mach-Hug scale. We have that after the 4 years, 74 patients have the seizure reduction and no improvement. You look at near the 2 or 5% patients just for after the surgery. And also we made VNS therapy for children because sometimes you couldn't do anything for children, but you will have effect from VNS therapy. What the most side effects? The most side effect when VNS is working is cough. Unfortunately, cough. We have 2 patients who couldn't live with this side effect, so we just stop the using the VNS for that patients. We also began this program in regions of all the part of the Russia. We come with our colleagues to put this VNS for adults and for children all the part of our country. Thank you for your attention. I'm in time.
Thank you. Very nice overview. The questions? I'd like to make a couple comments. One, I think there's evidence that the sooner this is implanted, the higher the success rate, especially after the seizures are diagnosed and they've gone through medications or surgery, have not had a complete treatment effect. That the sooner you put this in, the higher the success rate, especially in children. And the other point I'd make, and I saw in some people in Silicon Valley, computer programmers, they got used to having seizures. They couldn't drive. And so their goal was not so much, they'd like to be seizure free, but they'd like to be able to think a little clearer. And if you can reduce the number of medications or the dose to some degree, that can be a big difference in your quality of life. So it's nice if you get a complete control, but there's lots of other benefits as well.
Yes, really, it changes the quality of life of the patients because the one of the side effect is that changes the mood. The mood is become better. Thank you.
And an additional question is, there is some limit about the frailty of the patient, the age, the skin condition. I mean, there is some limit for this technique?
Yes. For children, we can do it. In Italy, I know they do it from the 1 year. In Russia, we can do it only for 4 years, from beginning the 4 years. In the VNS therapy, it's in the instruction, it's from 4 years. The skin, yes, if you had any wound infection, you couldn't do it.
Just for the sake of information, and for my knowledge, how much does it cost in Russia? And because we can make comparisons, we are talking about global neurosurgery accessible to everybody.
In Russia, now it costs, I will say you in US dollars, I think 12,000. But it's really different because in Italy, one price, in Germany, other price, in the United States, other price, in the low-income countries, other price. But now we use only VNS therapy, which is made in the United States. But also there are from the Turkey, from the China. I know a lot of companies now in China who make this.
just ask this question because you see, epileptic patients in our countries, they cannot afford even a 1 month drug price. So it's really very difficult, although they are the right candidates to be chosen for this particular form of surgery. So this is a huge gap between the two.
And I'd just like to add that the device actually, I'm not sure what the price in China or Turkey, but it should be much lower. It's not a very complicated device. And so the cost of manufacturing it should be 1/10 of $12,000.
Yes, it's same device like for cardiac stimulation.
Yes.
Can I make a comment?
Sure.
Igor, this is pretty much the same I said when I moderated your session at the Russia Neurosurgery Grand Round. From my point of view, your experience really tells how much you are contributing to the treatment of patients all over Russia with your initiative across the country. The issue from my point of view will be from an ethical perspective, and basically goes to what we said this morning about neurotechnologies regarding the follow-up of those patients who might require to travel for resetting of the VNS or change the battery over time.
If I understood your question, how in what time you need to change the battery?
Yes, basically those patients, even if you travel across the country and help setting up centers, then most likely you will need to follow them up. And at some point they will require resetting, and certainly at some point they will require battery changes. So which kind of pathways are you implementing to make sure these happen seamlessly?
The battery is working near 5 years. You don't need to, if it's set off, you need to to change it. It's very fast because we put it into axillary area. We have, I think, 10 or 20 different centers in Russia who could change the parameters of VNS.
Yeah, that's what I was asking. Thank you. Thank you for what you're doing.
Well, it's not difficult surgery, and so almost any neurosurgeon or vascular surgeon could do that.
For a surgeon, it's like a song, just 20 minutes.
Okay. I think the last, just burning because we have to move.
2 minutes, one sec. To answer the Naveed's questions, we have put 6 in the last 3 years at our Khan University Hospital. The last cost was around 45 to 52 lakh rupees. The battery is very, very costly. It's Medtronic one we use, and they charge a lot of money.
What you are suggesting right now is, or what I can infer is, until when we do the reverse engineering and tell them that there is no proprietary, but probably it is a far-off situation.
Cost is
really prohibitive.
The one we were able to do was because of Dr. Fawzia Siddiqui. Fawzia Siddiqui had a foundation where people donated the money, and all those people were poor people. We put it in, and all of them was funded money. Thank you.
And it's a pleasure for me to call the next speaker, that Lynn Lucen from Philippines. And I hope that there was always an increasing participation from the country. Lynn will talk about the establishing in neurosurgery society in the Philippines and holding neurotrauma boot camps. Thanks, Lynn, to be here.
Again, it's a pleasure to come to Pakistan, and I would like to thank the organizers, especially Professor Tariq Khan, finally, to be able to come here. So let me just go to my other talk. Okay, so actually the talk is more of establishing a neurotrauma society in the Philippines. We have already a neurosurgical society, and it is the Academy of Filipino Neurosurgeons. So since neurotrauma, as I have said, and we have been discussing actually that neurotrauma is of utmost important. It's a public health burden. And we all know, despite all the advances that we are discussing around the world in neurosurgery, we still have neurotrauma lagging behind. So especially in the LMICs and the LICs. So let me just reiterate, it's a global health problem, and the burden of disease has been discussed enough, with 11.8% of total global disability in adjusted years. And again, it's a leading cause of global death and disability, especially in young patients, children, and young adults. So the monetary cost is actually increasing. And as you can see here, the highest highest and lowest proportion of road traffic accidents and traumatic brain injuries. It's highest in the African region and Southeast Asian region, and also lowest in the Americas and United States and Canada. So in the Philippines, 117 million people estimated in 2023, which is 13th most populated archipelago of more than 7,000 islands. Traffic accidents are on the rise from 2006 to 2015. As you notice, we don't have that much recent data because that's what we lack, the neurotrauma registry. So it's a leading cause of less than 24 years of age. Even 14 years of age, they take the motorcycle without the parents' notice and they have an accident. So what is to be done? Okay, so we have not the data, we have the patients, we have the cases, but what can we do? So it has been, we have attended a lot of conventions, like Think First, Retrain Your Mind, so brain injury awareness, but in our own country, we don't have it yet. For example, the effects of traumatic brain injury. A lot of people only see the physical, the motor, the sensory. Spinal cord injury, you have paraplegia or quadriplegia. But what about later on when they follow up? Seemingly, they're okay, they're Glasgow 15, but there's cognitive problems. For example, they become childlike. Their description is, what happened to my husband? He's behaving now like a child. So that's cognitive and also behavioral. My husband has become, he used to be meek as a lamb. Now he's like a tiger, something like that. Like all these things, they don't see it. And people just attribute it and say, oh, because he met an accident, something like that. So there's nothing more that we can do. So physical complications, of course, we address it by occupational therapy, neuro rehab, and even pharmacologic agents. And the behavioral sequelae. So there's cognitive sequelae and there's cognitive behavioral therapy, but not a lot. I mean, only less than 10% of people, mainly in the National Capital Region, which is Manila, may know that there's cognitive therapy for post-traumatic victim patients. Okay, so the ones, most of the population do not know that you can do cognitive therapy. You can do neuropsychiatric assessment. So the recognition is very much at one. So not a lot of people will seek help because there's monetary problems, but so they do self-help sometimes, and also group therapy. Maybe they ask a lot of people if they can, but mainly they go back home and then they become a burden. So sometimes me as a neurosurgeon, I would like, I usually do it myself. Like I recognize, of course I know, and then I tell them to accept, but what happens? So they do physical therapy and at home they do home exercises, and then behavior, cognitive, there's family support or therapy, even in children, play therapy, voice therapy, and neurocognitive rehabilitation. So all these things, the awareness is very much lacking. Number two, there is not much support, meaning the recognition of a multidisciplinary treatment right from the start, from injury, is not there. People just know that, oh, if you have an accident, you get a neurosurgeon or maybe a neurologist, then that's it. What if there's no neurosurgeon or neurologist? So they do not know. So what happened was, when I was assigned to become the chair of the Neurotrauma Committee of the Asian Australasian Society of Neurosurgery, this sort of dream came true because I wanted neurotrauma to be like an advocacy. I wanted to share the knowledge to the people in my country because there's a need. So I was sort of empowered to do the first Philippine neurotrauma bootcamp. So with that, we did it actually. The neurosurgeon who accepted my challenge was down south in Mindanao. If you Google it, it's like the conflict area in the Philippines. But again, people were very brave. So we had the module. This is a sample of the module that we did. We have plenary topics from injury to recovery. So I had internal medicine, I had EMS, then the nurses, nursing care, everybody who's involved in neurotrauma. So with these topics, we even had breakout topics and focus group discussions. It was for a 3-day affair. So there was combat and mass casualty because that area had combat and mass casualty, meaning that area Zamboanga is a conflict area. So we got a lot of gunshot wounds and mass casualty at some point. So this was all included in the discussion and in the neurotrauma bootcamp. Okay. So after that, we were able to achieve it. And I wrote about it in the World Federation newsletter because these are some pictures. Okay. Professor Sinha, who's the secretary of the AASNS, went there together with Dr. Punya. So here he is demonstrating how without a helmet, your skull can crack like a shell of an egg, something like that. So this is the report that I had. We had it on hybrid. So the virtual attendees reached 1,052 unique viewers from day 1 to 3, with most of them coming from Vietnam and the Philippines. The top 6 specialties who attended virtually were general practitioners, nursing, pediatrics, neurosurgery, general surgery, and neurology. Speakers included, again, Dr. Virendra Sinha and Dr. Punya, and also there was a welcome address from Dr. Kate Drummond, and there was also a lecture from Dr. Igal Shushan, the chair of the Education Committee of the AASNS. And the fellows of neurosurgery were all lecturers. Okay, so with that, what's next? There will be more boot camps, cooperation and collaboration. I'm holding another boot camp in May 1 and 2 up north. That's already in the mountains of Baguio. So, and May 3, we will launch the Neurotrauma Society of the Philippines, which is an advocacy society. The members will not be just neurosurgeons, it will be everybody who's concerned with neurotrauma. Education, advocacy, learning, services. So we will tie up with other neurotrauma societies. The Neurotrauma Society of India has, and also other neurotrauma societies, even from Europe. The Academy of Multidisciplinary Neurotraumatology is interested to help us out. So participation in conventions. Maybe later on we will hold conventions also and invite you guys there. Advocacy videos on road safety, that is very important. And policies on neurotrauma and guidelines for local, government, and other sectoral involvement. Again, the emphasis, yes, the team approach.
Pass to the conclusion.
Sorry?
You should pass to the
Yeah,
conclusion.
I'm just last slide. Cooperation embodies the means to solving any problem we have, the resolute endurance to resolve. So thank you so much. I'll invite you to the 2026 18th Asian Australasian Conference in Manila. Thank you for your kind attention.
So we have a time for just burning questions. Okay.
Thank you.
Thank you, Dr. Lim, for your presentation. I have a question for you before I come down. I was always wonder, because I have a lot of Filipino patients. I practice in Qatar. And I know that you guys have a huge population, more than 100 million, and there's a lot of islands. So how, in the case if there is an accident or somebody with subarachnoid hemorrhage, how they get transferred to where they get treated, or what happened to those patients?
So that was the one issue of my talk on the other side. I started task sharing, which is actually a published paper also. So some of the residents that I trained in an island province, we communicate by internet and Viber. So after I let them go, they can perform the basic, very basic, life-threatening conditions, and then they transfer to me after with the tertiary hospital with the ICU. But again, with the establishment of the Neurotrauma Society, looking forward, this should influence the politicians. I mean, like the government hospitals, that we need a better EMS, maybe a helicopter transport or something like that. So that's a goal. Thank you so much.
Okay, thank you. So we invite everybody to participate in Manila next Australasian meeting, so we can force the politicians to convince that your job is a good job. Okay, let's go to the lunch. I remember that lunch meeting, it's 30 minutes. We have 30 minutes to have a lunch, and after come back in the conference halls.
We'll be meeting sharp at 1:45, please.
question mark trauma surgery. Saves you, you don't need rainy clips. Again, it's small financial saving, but it saves time much quicker. And you can secure your bone flaps with non-absorbable sutures, much cheaper than titanium plates, and quicker once you get the habit. And it's really just what's mentioned here. Next thing is the use of catheters. If you can get away from a urinary catheter, this is just evidence from general surgery, saves time in the OR, and it saves time afterwards. You can say they had a 2-day shorter stay post-operatively. So little things like this can add up to making a huge difference in our productivity. There's Hassan Ishmael from Glasgow University, spent a month with at Stanford last summer. And I operated on one of those guys in this Beatles knockoff group, and he wanted to go back to singing quickly. So we just needed a 1-level ACDF. He was out. So we did under LMA, laryngeal mask anesthesia. And if I was starting again, I'd be doing a vast majority of my cases under those that I can convince the anesthesiologist to do it. Much less trauma, and it's much faster. Did I miss one here? No, okay. And here you can do this for things like lumboperitoneal shunts, and the other is high flow nasal cannula anesthesia. So avoiding intubations can save quite a bit of time. The thoracic surgeons, this ARIS, enhanced recovery after surgery with LMA and no urinary catheter. You can see the data there. Much shorter post-operative stay and shorter operative time. So these little things can add up. Instead of doing 10 cases a week, you might be able to do 12 or 14, and that can make a big difference. Local anesthesia, I think we've had in this meeting some discussions of that. Huge saving. You can do a burr hole in 15 minutes under local anesthesia. If you got to put the patient to sleep and take the tube out, it's going to take a lot longer. And Walland, probably some of you familiar with the carpal tunnel syndrome, for example, wide awake, local anesthesia, no tourniquet. Just inject some local anesthesia, and you can see the data there. Much shorter post-operative anesthesia need, or pain medication need, and much quicker out of the hospital. Epidural hematomas, evidence from over, 10 years, almost 15 years ago. You don't need, you can do a burr hole for most epidural hematomas, and I don't think that's very commonly known. But again, you can do a burr hole in 15 minutes. People, I think all our Pakistani colleagues know about this, the horrible earthquake in 2005, and this wasn't reported until about a decade later, but look at that. 34 of those patients, they were doing 12 cases of epidural hematomas a day. There's no way you can do 12 craniotomies, but you can do 12 burr holes, no problem. And the vast majority of those people, that was all it was needed to have a good result. And also with pediatric, again, this is a group in Lahore from a few years ago. You can treat pediatric epidural hematoma with a burr hole. These are huge savings in time and resources. ETV, I think you all know that's definitely the way to go for the vast majority of obstructive hydrocephalus. And here you see that this is out of Ben Wharf. The need for additional surgery, half of the people didn't need it with ETV. If you put a shunt in, you only get about 1/3 of the people to escape an additional surgery. And the money, it looks a little more expensive at the beginning. This is out of Brazil, but if you follow these people for a couple of years, the cost is double with a VP shunt. Lots of motivations for doing this. I'll just really quickly go over this. I think Tariq, I wish he would give a talk sometime on just what he's done over the last 25 years or so here. It's just amazing. But you can read about this in a paper. But what Ika Wajapramono did in the Indonesia is somewhat similar. Went from 1 hospital to 31 hospitals throughout there, but just by building public awareness, just as Tariq has done here in the 90s when he first came. Get the public on your side, recruit stakeholders, and either with hospital systems or, in your case, I guess money from a bank, and then get your resources together, your colleagues. You can start a foundation or a nonprofit hospital for indigent care. And to reduce the brain drain, you get people from the regional areas, train them, and they'll want to go back to the regional areas and support them afterwards. This is a photo from 2009 when Northwest General just opened. And same thing, he recruited the office, the populace, and the trauma prevention has been a crucial part of that. And so same thing with the indigent care and starting medical school, nursing schools, training 150 doctors starting from scratch. I mean, that's quite an amazing event. And I think one of the big points here is don't just think about neurosurgery, think about the healthcare for the system. And that's what Tariq's done here. Really impressive. And well, it's pretty obvious the progress it's been made. And you just got that grant again, a year or two ago, another $11 million because of the success you've had. Just a comparison, very similarities between those two system contributions in Indonesia and Pakistan. And it's all in the private sector. This isn't depending on the government or international organizations. These are just innovative individual neurosurgeons in two different countries. So there's a summary of that. I'm just going to mention, if anybody's interested, hopefully you are, of what's going on now in Ukraine. I met Alexander Wozniak in 2016, and we, if you're not familiar with this, one reason this is such a crucial situation for them, this Holodomor is basically genocide by starvation in the 30s, and this guy Raphael Lemkin made up the term genocide and developed the Genocide Convention for the United Nations.
We'll need to
This is the
conclude, please.
Yeah. I'll just say, if anybody wants to go in 2 weeks to their next neurosurgery meeting, Bukovel in Western Ukraine, try to support these people. They're fighting for not only themselves, but for certainly the people in Europe and probably for the people in the world, the way things are going. So with that, thank you.
Thank you.
Thank you very much, Dr. Andrews. We have a little change in the program now. Is Graham Fegan here? The next paper will be delivered by Dr. Fegan, and he'll be speaking to us about pediatric functional neurosurgery. Welcome to the podium again, Graham. While Dr. Fegan is setting up, are there any questions or comments on the Dr. Andrews' presentation? Thank you.
Yes, this one. Great. Thank you, Gail. And good afternoon, everybody. I apologize for the change in the program, not being here yesterday, but so it's a little bit out of step with the theme of the session, which is capacity building. But hopefully I'll demonstrate that the procedure I'm going to talk about primarily is applicable in low and middle income countries and actually can build surgical capacity. So functional neurosurgery is obviously a massive area of practice, but one that is repeatedly referred to in discussions around global neurosurgery as an area that needs development. And I think part of the issue there is the sense that this is esoteric kind of, surgery that doesn't really save lives, and actually it's not really relevant to the burden of disease. But I think when you look particularly at epilepsy, which has come up repeatedly in this meeting, and I'm going to have a chance to talk about it a bit later, and other movement disorders, the burden of disability that they represent is substantial. And the interventions that we can offer are not always that complex and sophisticated and expensive. So there's definitely a role for it to play. So once again, thank you to Tariq for this invitation. Just a quick shout out for one of my favorite organizations, the ISPN. So for those of you who have any sort of pediatric component to your practice, the ISPN has got this really fantastic sort of teaching aid that Rick Abbott has really sort of dedicated himself to developing over the last 15 years, called the Guide to Pediatric Neurosurgery. It's available free. You just need to register online. The functional section isn't that comprehensive, but there are lots of other things that are very well developed on the guide. So if you're going to talk about functional neurosurgery in children, I'm going to talk about epilepsy later. I've only got 10 minutes, so I'm going to focus specifically on spasticity. Psychiatric disorders are obviously very seldom an issue for surgery in children. So in terms of spasticity, you've got to distinguish spasticity from other causes of hypertonia. Classically in clinical finding, as you all remember, you have a kind of clasp knife sense to the spasticity with the sort of catch, which is different from the lead pipe stiffness of rigidity. And then dystonia, which is increasingly sort of recognized as often being present in a mixed form, a combination of spasticity and dystonia. And dystonia is a bit of a red flag, and you need to identify that, because that will definitely impact on your treatment pathway. So we've heard about these guys repeatedly today: cerebral palsy, trauma, and stroke. This is a sort of, I guess, the triumvirate that causes upper neuron pathology for us as neurosurgeons. Very common conditions, and spasticity is a very common concomitant of these clinical conditions. And the important thing is that you not only get muscle weakness, the only way the brain can have any impact on the world is through moving a muscle. So if you're not able to move muscles, you're pretty disabled. And the two primary things are muscle weakness, which we can't really do much about as neurosurgeons, or not yet anyway, and then abnormal muscle contraction, which in this context is spasticity. So why do we need to treat it? As I said, it's seldom life-threatening, but it can cause considerable pain for the patient, particularly at night. Little kids with severe cerebral palsy can have really quite incapacitating sort of nocturnal muscle spasms, can lead to spinal deformity, and often makes nursing care very, very difficult for children with severe spasticity. It leads to complications, orthopedic deformities, spinal deformities, gait problems. But the critical thing is, don't just treat spasticity because it's there, because sometimes you may have a situation where, to use a kind of a much overused phrase, the child walks on their spasticity. They have significant underlying weakness, but they're dependent on the spasticity in order to kind of keep them upright. And if you don't recognize that and you reduce the child's muscle tone, you may actually render them non-ambulant, which is obviously not doing them a big favor. So be very, very careful about what your functional goals are in terms of treating spasticity. And what you want to do is treat spasticity only if it's interfering in the patient's quality of life. So the different management options, the absolute foundation is physiotherapy and occupational therapy. I think all these interventions are non-starter unless you have that available. And that doesn't need to be done necessarily in a tertiary hospital setting, often empowering families, teaching family members how to deliver sort of the exercises and the other sort of care that is required for physiotherapy, occupational therapy as possible in a resource-limited setting. Different drugs such as diazepam, baclofen, and then Botox injections are important. There are a number of orthopedic interventions I'm not going to really talk about. Tendon lengthening is pretty common in these kids. And then neurosurgical interventions. And I'm going to focus particularly on selective dorsal rhizotomy. But just to mention, there are a range of other options here. And you can either do a peripheral neurectomy at the site of the peripheral motor nerve. You can operate on the afferent nerve either as a dorsal rhizotomy or at the dorsal root entry zone. You can inject Botox into muscle, as I mentioned, or you can actually use a CNS delivery of baclofen through an intrathecal pump, which is obviously incredibly expensive and is seldom an option in low-income countries. So I really like this concept that Kerr Graham, a pediatric orthopedic surgeon in Melbourne, has popularized, what he calls the spasticity compass. So interventions are either general or focal, permanent or reversible. And those can either be oral meds. Botox is reversible. Intrathecal baclofen is reversible, but it's really expensive. Rhizotomy is not reversible, but it's really inexpensive. And I'll tell you about that now. And then there's selective peripheral neurectomy. So we love dorsal rhizotomy in Cape Town. Warwick Peacock, who was the person who really established pediatric neurosurgery in Cape Town, really established his global reputation by reintroducing rhizotomy. But this came on the back of nearly a century of work that started with clinical observation. Most of the really amazing things in medicine starts with a simple clinical observation. Dr. Bennett in the UK and Dr. Abe in the US recognized that cutting the dorsal nerves running into the spinal cord reduced spasticity in individuals that had spinal cord injuries, usually in the setting of war. That was translated into laboratory experiments by Sherrington. He got a Nobel Prize for it. which we'd forced to apply this clinically, but then after doing 150 patients, decided the complications outweighed the benefits. It was resuscitated by initially Gross and Montpellier Fossano in Italy, and then Warwick Peacock took up the procedure in the early 1980s. And essentially what Warwick did was he made a very simple modification to this procedure where he exposed the entire chorda equina by doing a laminectomy from L2 down to S1. Lila Ahrens, who I've got a picture of there, was the neurologist who worked with Warwick. And that simple intervention, just exposing the entire chorda equina, enabled this operation to be done very, very safely. And what the picture there shows from Nico Enslin, one of my colleagues in Cape Town, is, and of course, we don't no longer do laminectomies, you do a laminotomy and put the bone back. But if you identify the nerve root as it exits, you can't go wrong. It's really not possible to prang the motor nerve, and you identify the dorsal nerve. The motor nerve is usually pink. For those who operate in the chorda equina often will recognize this. The ventral root is pinker than the dorsal nerve, and you can actually see the anatomical relations as they run out the foramen. We've had the privilege of doing long-term follow-up studies now of these patients. The benefit is sustained, and it lasts for decades. We've followed these kids now for 30 years, and they have long-term benefit. There are a number of modifications. This Taesung Park has described a modification operating just at the conus level. There's a really nice paper from Toronto in Journal of Neurosurgery a couple of years ago comparing these different techniques. The most important thing is that you operate on the right patient, so that your surgical technique is perhaps secondary to patient selection, which I guess is probably true of just about everything in neurosurgery. So operate on the right patient. Make sure you're not going to operate on somebody with dystonia or somebody who's walking on their spasticity. My junior colleague, Nico Enslin, who's in the photograph there, Nico is actually a physiotherapist who's taken up this functional neurosurgery practice in our program. And it's really amazing to see kind of how one can really improve the function of these children if you operate on them correctly. So in summary, this is a procedure that works. We followed them for more than 20 years. Need to select the right patients and then manage them into adulthood. Multidisciplinary care is really important. As neurosurgeons, we've got a really important role to play. The orthopods don't often say nice things about us, but I really like this quote from Jim Gage, pediatric orthopedic surgeon in Minnesota, who said spasticity reduction, when combined with secondary orthopedic procedure a few years later to correct the deformed skeletal levers, has provided these children with huge functional improvements, which were never possible before. Okay, so on that note, thank you very much, and take any questions. Thank you.
Thank you, Graham. I don't think we have time for questions. We'll move on with Dr. Saman Shahid, writing research proposal for funding opportunities for neurosurgeons.
Hello, everyone, and good afternoon. I am extremely thankful to Dr. Tariq Khan, who invited me for this presentation. Today, I'm focusing for young neurosurgeons that there is a need for a good drafting and writing of research proposal in order to secure funding opportunities or grants. So I'm working as professor in a national university and a director of EHDS lab. So if anyone wants to have collaboration with me, you can contact me. A grant gained for undertaking scientific research usually through a competitive process. It is defined as research funding. A research endeavor requires manpower and materials, and therefore there is a strong need that developing country neuroscientists, neurosurgeons, and other medical doctors should be able to take a well-draft project layout, its objective, and to secure grants, because some of the studies requires a lot of grants and funding. We cannot have some multi-center research, for example. So there is a need that we focus on this, and we will let you know today What are the 3 or 4 major concerns to secure a grant? And there are some possibilities in Pakistan as well. Most of the time it is being thought that they are research funding for natural or basic sciences. But if we look at the closer look, that there are funding opportunities and grants for the project, especially for drug trials, interventions, and neurosurgical instruments in pharmacy as well. So this is the basic motivation to meet the demand for excellent research in developing nations. There is a great need to encourage physician and surgeon to apply for research funding grants. Writing a research funding proposal is also an art. And researchers should be trained in this skill. There should be training workshops, how to draft a grant, objectives, and documentation. There are lots of documentation involved. There are lots of charts involved. There are lots of training and skills required for budgeting and funding. The most important thing, we should address the research question. We should have a very critical idea, the need of hour and the skill, and we should address those concerns which are hard to develop or maintain in developing countries and for resulting in a beneficial outcomes. So these are the basic components that we must have: title, abstract, introduction, we all know. The most important thing is this is the timeline and the expected outcomes. These are the more focused components. We must have some ethical consideration from the collaborative hospitals or the institutions. You should seek feedback from senior colleagues. We should have a very good proposal query. So I'm just drafting that in Pakistan, Higher Education Commission has a great initiative. There are NPRU, Grand Challenge Fund, local challenge funds. You will be surprised to know that most of the universities are also enclosing medical colleges and their local hospitals or collaborative hospitals. University faculty members, especially from the medicine and surgeon, also welcome. They need not to be PhD. There is a requirement. They could be FCPS, they could be MCPS and FRCS and other things. So for research initiative, I strongly recommend surgeons and doctors to take interest and explore those HEC ideas for the grant. So this is just a brief about this is all the all stuff is available on the HEC website as well. And you can say, for example, there is a rapid technology transfer fund. Technology does not mean that it is related to computer science or IT. It could involve novel ideas in medicine as well. For example, there are short-term projects as well, up to 20 million of the 6 months. So co-financing also possible. Some of the parent institute along with the HEC funds, it is possible to secure the grants. For example, I have just copied from the HEC website. Health and Pharma has a special component over there. So you can explore these things from the website. Same is the case for Local Challenge Fund. And there are also technology transfer support from GGSF. For example, it has up to 2 years and 15 million grants. So this is most beneficial and very impressive HEC NRPU program for universities. And this is also, this also covers the medical colleges and the hospitals as well. You can have this on the website. So for example, our government also giving opportunities from sandwich programs and some collaborative. For example, this is Peridot Research Program. We can have some HEC and Ministry of Foreign Affairs and International Development and Ministry of Higher Education and Research. So it is also possible that we can plan such research that may be planned in Pakistan and the things are implemented in Pakistan, but we can explore the ideas and funds from the foreign land as well. For example, Health Research Institute as well, HRI also offering very best funding opportunities, especially mental health. So some of the themes are now becoming very much familiar in the research funding. They are funding the psychological issues, mental issues, and the related issues as well. So this is also a Pakistan Innovative Fund. And you will be surprised that last year or maybe some months back, they were giving opportunities for the mental health as well. PICE's small grant, they are very impressive. They can give up to £500 for 6 months, and there are 2 grants up to £2,500 £6 months. So they also focus on the brain-related issues, PICE's. And there are lots of foreign grants as well. These two are just an example. So you can explore more. And I would like to request the foreign neurosurgeons which are available here. If they can share some grant opportunities for our neurosurgeons. So this is another example, European Association of Neurological Societies. So I can give you a brief because I have limited time. You should start planning very early, develop a very good idea, prepare a very good presentation, and that should be aligned with the review criteria, must deal with the review criteria. Identify the collaborators and seek advice and feedback from your senior colleagues. And that's a basic component. So you should understand the flow. Agency mission, the agency which is being funding, secure collaborators, you should have mentors. And this is just typical example of how we prepare the NATS drafts or the charts, and we pay attention to every module or the task related to cost. This is another example because I have prepared a budget funding for some of the grant. This is typical example of preparing a budget. So it needs a skill. And the things are, the tutorials are also available. I can also produce some skill by giving some training. So this is all my side. Thank you. And any question, please?
Thank you very much, Professor Shahid. Are there any questions? This is very helpful for you to provide us with some practical points. Anything special about budgets? That's always, for me, that's always the hardest part of when you have new science, a new project, how to estimate budgets.
Because we have to confine within the prescribed budget. And we have to allocate the budget and the salaries for the personals and the doctors we will hire. So it's a very critical step indeed. And I think it's a very important step as well, because we have to manage that what amount of funds will be given to the neurosurgical instrument, for example, and what about the researcher they will be working on for a certain duration of time.
Thank you very much.
Thank you very much.
Thank you all. I think we'll move on then to the final paper of this session. Dr. Ahmed Fawad could please join us. He's not here? Oh, what a shame. It would be so nice to hear more about the current state of neurosurgery in Afghanistan. Mr. Chairman, would you like us to entertain discussion, or do you want to move on to the next session? Okay, thank you very much. Thanks to all the presenters.
We're going to start the next session, scientific session number 5. Can I ask Dr. Nadeem Akhtar, Dr. Abdul Hamid, and Dr. Bulent to please occupy the seats? The session is about pediatrics and congenital anomalies. So again, each speaker has 10 minutes, 8 minutes for the talk and 2 minutes for the questions. Thank you.
Okay, should we start with the 5th session? It's the pediatric and congenital abnormalities. The first paper is by Igor Trifonov, Surgical Outcomes in Patient with Drug-Resistant Bitemporal Lobe Epilepsy Confirmed by Magnetic Resonance Imaging.
Yes.
He's not here?
He's no. Let's start with this one.
Start with that? Okay. So we start with the next speaker, Mr. Bulent Duff's cerebral endoscopy with ventricular port technique. How to assess the lateral and the third ventricles.
thank especially Dr. Tariq Khan and the World WFNS group and Tariq Khan's team for inviting me that great conference. I will present my experience on cerebral endoscopy. I will describe how to access lateral and third ventricles without sophisticated instruments. I have 18 years experience with ventricular port technique. I have started this technique in 2006. I have done more than 200 endoscopic third ventriculostomies and some tumors, cysts, and others. The logic behind this ventricular port technique is trying to do more with less. Regular endoscopic approaches need obturators, endoscopic working channels, and dedicated special instruments which are suitable for working in the channel. Instead, ventricular port technique, you can use your microscopic instruments inside the channel together with telescope. In addition to that, you can adjust the length of the channel according to the cortical thickness. In literature, there are different terms used to describe the port technique. Ventricular port, endoport, endoscopic port, they are all the same. And I'm using now, in the last 5 years, a renal dilatator as a port in order to access the lateral ventricles. Yesterday, we went to a museum, Gorkhari Museum in Peshawar, and I have seen some broken old pipelines. They reminded me the working channel that I'm using. When you look at the renal dilatator, we are able to shape them, and we can use 6 to 11 millimeters channel from them. You can select the diameter of working channel as you wish. In endoscopic skull-based surgery, in order to make endoscopic operation, you need only a camera, a fiber optic light source, 0 degree, 4 millimeter diameter, and 180 millimeter long telescope. If you are familiar with that endoscopic skull-based surgery, if you have a channel to access to the lateral ventricle, you can make a lateral ventricle approach also. In that operation, I advise bipolar suction coagulator. It should be malleable. Other than that instrument, you can use your own instruments, microsurgical hand instruments, or if you have some sophisticated endoscopic instruments, you can use them. According to the location of the lesion, I use coher or Frazier points to access the lateral ventricles. This video represents how I am doing that operation. You can use a neuronavigation or not. If you have a neuronavigation, it's good. Otherwise, without a neuronavigation, also you can access the lateral ventricles. I use the narrow dilatator first, then I use the larger ones. Now I am inserting the last dilatator together with the conduit. I'm removing the dilatator, and now I am inside the lateral ventricle. I take my suction in my right hand, the telescope in the left hand. And now I see the lateral ventricle. And now I will present some examples for that. This is a 1-month-old baby with choroid plexus bleeding. When I insert into the lateral ventricle, I see that the bleeding was from choroid plexus. You can see that this is the tubercinarium, mammillary bodies, and now we can see the posterior part of the ventricle. I'm sorry. I wanted to go quickly, but it didn't let me. Now we are seeing the aqueduct, and I am using a microsurgical instrument. It's a micro dissector. I'm trying to enter the fourth ventricle, open the aqueduct. Now I'm approaching to the aqueduct. It's quite open. With using the micro instrument, I'm able to make third ventriculostomy also. The Lacus membrane is also opened. The basilar artery is seen here. I'm trying to a little bit more dilatate the Lacus membrane. The most important step in that operations are removing the debris, I think, because if you not remove the debris produce membrane on the aqueduct. So if you remove the debris, it means that it can enhance your success. And now I am entering the fourth ventricle, and now you can see here a small membrane which has been also occurred from the debris. And this is the result in the fourth year. This is the before operation. This is the fourth year follow-up. And now the patient is at 8 years and without continuing without shunt and doing well. This is another example for ventricular port approach. This is the cyst, and I decided to make at first third ventriculostomy again. Basilar artery and perforators are seen over there. Then with a blunt instrument, you can use any instrument in order to penetrate the interventricular septum. Then I am using the regular bipolar to open the cyst wall. Now the cyst wall is opened. And we can also make operations on the colloid cyst.
Time is over. You can quick and finish your.
We have 3 minutes more.
No.
7 minutes past. I wish to present another example for that approach. You can take biopsy from the deep-seated lesions, and you are seeing that how I am preparing the port here. At first, using the renal dilatators, I am inserting the renal dilatators first, then I am inserting the sheet again. It is a conduit to access the lateral ventricle. Then I am going into the lateral ventricle directly. Now I am inside the lateral ventricle and inside the third ventricle. Then I will get some biopsy here. You can also remove large, big meningiomas from the lateral ventricle. And if you need, you can remove the port and you can continue the operation with microscope also. In that operation, this tumor was very strong. I have started the operation at first with endoscope. I have coagulated every part of the tumor, but it was so strong, it was not possible to remove it. Then eventually, at the end of the operation, I have this is the endoscopy part. I am checking the every part of the lesion. Then I have removed it, and I have removed all the tumor. This approach has some superiorities than other endoscopic approaches. I'm using a small craniotomy in that approach. It's time saving, it's quick, it's wider, it provides wider trajectory. It provides more maneuverability, provides better visualization. The surface of the ventricular port is hydrophobic and do not adhere to the brain. It allows the use of standard bipolar coagulation. If you need in the operation, you can remove the port and continue the operation with microscope. And as a retractor, this port provides a circumferential retraction of brain tissue. For example, if you use Leila retractors, retractors makes damage to the brain tissue. Thank you very much for giving me that opportunity.
Any short question? So we move on to the shortage of time. Chairman is saying that we have to continue with the session. So the next speaker is Mr. Yan Yun. He will be talking on neural tube defects and folic acid fortification in sub-Saharan Africa.
Thank you. I replace Professor Espérance Boale, President of the Ivorian Society of Neurosurgery. She couldn't have her visa. Ambassador Josefa told in June 2023 about food fortification is necessary in our area. Neural tube malformation seems to be underevaluated in Côte d'Ivoire. We not a rise sense of initiation of information and awareness campaign by Esperance Hope Association and the National Society of Neurosurgery. We note also a lack of knowledge of risk factor by health personnel and mothers who have already had a child with spina bifida. And the fortification of food is even less well known in our countries. Our goal is to take stock of the fortification of foods with folic acid in Côte d'Ivoire and other West African countries. We use a literature review database until February the 9th of this year. This is the 16th country of West Africa. Meta-analysis of Mohamed Omer in 2020 shows that only 2 countries in West Africa, Nigeria, has calculated the prevalence of spina bifida. Nigeria, it's 0.06, and Ghana, 0.05. For all those countries, it was hospital studies in Department of Neurosurgery, like you can see in this slide. Folic acid deficiency was common in Africa. Is not micronutrient fortification was well developed, but more than 100 publications identified it. But if plan exists, a strategic plan exists in several countries, a text was adopted in the practice. It was very difficult in West African Economic Monetary Union, 7 countries who share the same currency. This is the decree in Republics of Togo, Ghana, and Republic of Senegal. The fortification concern, in addition to wet floors and foods of large local consumption. In Côte d'Ivoire, the first ministerial decrees for enrichment was in 2007 and adopted in 2018. Already in 1981, an interministerial decree created the National Alliance for Food Fortification. It was for folic acid, but for another vitamin. This is the decree, and this is the rule of application. The review of the literature and the evaluation of these programs and this impact of neural tube defect, when we regard it, there is gap in the implementation of these programs. The incidence of malformation was unknown. The data was generally hospital data, and they didn't reflect the reality, making assessment difficult. But in 2019, there was a paper who explained that a reduction in the risk of malformation for 41% in sub-Saharan Africa was possible. In those studies, they note the mass fortification program was implemented by the government, but not always make it possible to fully cover the nutritional need of women. And insufficient fortification rate of folic acid in fortified food, including wet flours in Côte d'Ivoire. In conclusion, we can say that the fortification food with folic acid is effective, but not yet efficient in our countries. The creation of register of malformation in the different countries would allow epidemiological studies and, above all, better monitoring and evaluation of the different programs, particularly when we regard the impact on the reduction of neural tube defect. Thank you. You can see our president and our trainee star of this Congress, Harmony. Thank you.
Any quick question? So we move on to the next presenter, Mr. Igor Trifoni is back. Surgical outcomes in patients with drug-resistant bitemporal epilepsy confirmed with MRI, magnetic resonance imaging.
Thank you, dear colleagues. It's a presentation about epilepsy surgery in bitemporal epilepsy. When you see just clinically MRI, for example, focal cortical dysplasia of left amygdala or right temporal lobe, you understand everything. Just make scalp EEG. The onset zone is the left on the right, and you should do the typically anterior middle temporal lobe resection. Or you can see it on the hippocampal sclerosis, like from the book. It is typical sclerosis of the, for example, on the left slide, on the left picture of left hippocampus and the left amygdala, and also the in the corona you can see how it's decrease the volume and the application of the signal from the hippocampus. And what to do when the patient with two bitemporal, for example, hippocampal sclerosis, like on the right picture, what to do? Because you couldn't resect both hippocampus, the patient will have not good memory and also have the Cluver BC, the symptom. And also you began to think what to do, for example, with patient on the right side with cavernoma, on the left side with the focal cortical dysplasia. I think that the most not easy patient with epilepsy surgery is the patient with cavernoma or with the patient with the lead, because you can see on an MRI and you think, oh, it's cavernoma, it's the onset zone, but it's not all the time, because sometimes focal cortical dysplasia is combined with the AVM or cavernomas and with the long epilepsy-associated tumors. So that's why here on the first step, we resected cavernoma because we need to put the electrodes for the patient. It's how it's look like, the bitemporal onset zone for the patient, and also you couldn't understand where the onset zone on this patient, right or left. So that's why you need to use, excuse me, invasive AG monitoring. I prefer stereo AG in patients because it's easier to make invasive monitoring and to stimulate also the patient and stimulate the onset zone to verify the onset zone for the patient. Also, the next step is maybe the passive cortical mapping, for example, in patient with the focal cortical dysplasia on the both sides of the frontal lobe. The next step, you can use MEC for looking where the interictal activity for the patient, for example, on the both sides, but mostly, for example, on this patient on the right side, on the posterior temporal lobe. You can do fMRI with EEG to verify what hippocampus is involved. What the etiology? Mostly it's the sometimes the it could be bilateral damage because of encephalitis or during the infection in the children during 2, 6 or 7 years. It's, for example, patient with bitemporal lesions. It's 4 years old. It's typically anterior medial temporal lobe resection, first the neocortical part, and then we resect the hippocampus. It's our experience of bitemporal lobe resection. Also, we resect only one hippocampus, and you can see that near the 40%, like in all literature, 40% of the patients have improvement in the seizures. And also, when we think do surgery or not, if the patient, for example, with no surgery is against the patient after the 2 years, only Angel 1 is 2%. In patients with MRI positive bilateral lesions, it's Angel 1 is 33 patients, and in the unilateral lesions, it's better outcomes. It's near the 76% of the patients. So that's why, thank you for your attention. Don't be shy to do the epilepsy surgery, because now you can do it mostly to patients to improve their quality of life and to be seizure-free. Thanks. This is a picture of Salvador Dali, Alice in Wonderland, and she had seizures in the book. And in this picture, he described how could be different type of seizures. Thanks.
Thank you very much. Anything you want to, any question? Quick question? Okay.
Thanks.
Thank you. Thank you very much. So we move on to the next last speaker, Mr. Graham Payne. He will be talking on building in an epilepsy surgery service. He's coming. Is he coming? Okay. With water. Hmm.
Thank you. Salam alaikum for the last time. You'd be very happy to know it's the last time I'm talking to. So Professor Khan is punishing me for arriving late and doing all my talks. I thought I was off the hook. I could sort of sit quietly this afternoon. Okay, so I promise you I'll do this in less than 10 minutes. It's building an epilepsy surgery program. So as I said earlier, different conditions that fall under the rubric of functional neurosurgery today or this afternoon now is going to be epilepsy. So epilepsy surgery is obviously not operating on kids who present with different pathologies that have seizures, but operating on very specific conditions like hemimegalencephaly, low-grade astrocytomas, mesial temporal sclerosis. It's not new. Probably the first ever operation done in neurosurgery was for epilepsy in the 1880s. Wilder Penfield was the guy who really sort of put this on the map. So the key question is, why is it done so seldom? And Peter Engel, who worked in California for many years, made the statement, which I think is true, that surgical treatment for epilepsy is arguably the most underutilized of all proven effective therapeutic interventions in the field of medicine. And we know it's proven. Sam Weeb and colleagues at the University of Western Ontario did an amazing study, prospective randomized study published in the venerable New England Journal about 20 years ago, clearly demonstrating that patients underwent temporal lobectomy for complex partial seizures, as they were known in those days, did much better than patients on medical treatment. So this is proven. And there are very, 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 very few things in neurosurgery that we can say that about. And my colleague in Cape Town, Roger Melville, who's done over 1,000 epilepsy cases in the private sector, tells me it's getting worse, that the patient's getting referred later and later and later. And there are various reasons for this. Neurologists, lots of fancy new anticonvulsants. Neurologists often want to try every single anticonvulsant, and as the list of anticonvulsants gets longer, that takes longer. In many situations, there's tremendous fear about epilepsy surgery among patients, and there may be very limited resources and expertise. The notion of intractable epilepsy is largely sort of historical these days. I think really it's a question of trying medical drugs the appropriate drugs at the appropriate doses. And if you're not getting an adequate seizure response, you've then got to start going down the line of investing in a patient for possibility of surgery. And there are many reasons that you may want to do this, one of which is that the drugs themselves have a whole bunch of adverse effects on learning and behavior. Epilepsy obviously has tremendous stigma. There's this very real condition of SUDEP, which is absolutely tragic and devastating when you have sudden death in epilepsy. And really you can offer patients a much better long-term outlook if you can control their seizures. So the conventional approach is the semiology, making clinical diagnosis, e.g. localization with the appropriate imaging. If you're in a privileged situation, you can have neuropsychological assessment done with the patient that leads to appropriate surgery. But for the majority of the world's population, this is not an option. So I think there are three steps to developing a service. One is to have the correct infrastructure. Secondly, to demystify the surgery. And three, to find some friends to help you with it. In terms of developing infrastructure, so Radhakrishnan, who worked in the south of India, Trivandrum, I seem to recall, has published about 10 years ago, an incredibly systematic approach to how I went about building epilepsy surgery services in India. I'm going to skip over this in the interest of time, but it's a very logical, straightforward, stepwise approach to building an awareness of the importance of epilepsy surgery, and then systematically across the country, So building the facilities that made it possible for patients to be identified and referred appropriately into the correct level of care to be worked up. Brazil is a great example of a country that built really world-leading expertise in epilepsy surgery off a very low base, also very systematically. So it can be done. There's good evidence of it being done in a number of developing countries. So demystifying the surgery is important. You're either doing a resection, you're doing a disconnection. For purposes of a global surgery meeting, I think neuromodulation is not really on the table. Callosotomy is a lovely operation. I think just about all of you in the room, I'm sure, have done a callosotomy. It's not a difficult operation. And it's a very, very effective but palliative operation. It's not a curative operation for epilepsy. The important thing, though, with epilepsy surgery, like all functional surgery, because you're not doing it to save somebody's life, you really, 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 really do not want to have complications. I think we have to be very well aware of what can go wrong in order to offer the patient the safest possible operation. Another beautiful operation is temporal lobectomy. When Dr. Caldwell spoke this morning about the complexity of skull-based tumors and everyone being different, temporal lobectomy is one of those beautiful operations where it's pretty much the same every time. Once you're in the groove of how to do this, it's a really lovely operation to do. I'm going to skip over the anatomy because I don't want to get in trouble with the chairs again. So, but the anatomy of this procedure is really very, very straightforward. And when you do the operation, as I said in the slide, don't go too far back. Don't go too far up because you'll end up in the basal ganglia and the visual pathway. Beware of the midbrain, and the peel bank on the uncus really is what protects you from going into that cistern. But probably the most important thing is inadequate preoperative workup. Can this be done in low middle countries? So we've analyzed our data. This is children where results tend to be not as good as in adults, but 3/4 of patients in our setting were Engel grade 1 or 2, which I think is quite acceptable. In Mbali in Uganda, Ben Wolf published a small series of 10 patients who had temporal lobectomies, of whom 6 were Engel class 1 and 2 Engel class 2, so 80% good control. But that program stopped when he went away. Tunisia developed a program in collaboration with colleagues in France and here in Pakistan. Many of you will know Zubair, who did great work in Karachi, probably with people in the room, developing a program. I'd love to hear what happened with that. What is beautiful and probably the single best thing I'm going to tell you today is that program that Ben Wolf started in Uganda has been picked up now by Ugandan neurosurgeons. So Peter Senyonga and Emma Wigoy trained with us in Cape Town, have gone back to Uganda together with Robert Sabunya, who's a neurologist who trained in Cape Town, worked with colleagues in Uganda to kind of re-establish a national epilepsy surgery program, which they launched last week in Kampala. So really cool. And I'm sure there are many other countries in the world where epilepsy surgery programs are taking shape. Partner organizations. So it's really, really important for us to proselytize, get the word out, get the neurologist to understand epilepsy is a surgical condition. It's really important we work with organizations. In Africa, we've had these amazing African epilepsy congresses, which have been coming together of neurosurgeons and neurologists, which unfortunately got stopped by COVID, but we're hoping to get that going again together with all these international organizations. The take-home message, I think the single most important point I want to make is epilepsy has had a huge impact because there's very close relationship between ILE, the International League Against Epilepsy, which is a professional doctors organization, and IBE, the International Bureau for Epilepsy, which is a patient advocacy organization. And that partnership has led to this intersectoral global action plan adopted by WHO. I think there's a lot that we can learn from the epilepsy community and the way in which they've managed to get epilepsy recognized as a global priority. So in summary, you can't do it alone. You need to find partners and find a friend to help you establish a service, learn the basic surgical techniques. They're not difficult. Have the right technology. It doesn't need to be complex. And then start with straightforward cases, then start to build. So on that note, thank you very much.
Thank you very much, Graham, for the nice presentation. Any question? Quick question for him?
Is there epilepsy surgery happening in Karachi now? Please tell me there is. Yes, fantastic. Yeah, good.
Expect given the population of the city.
Yeah. Yeah.
In fact, for the first 5 years, we only had 3 cases.
Yeah, yeah. No, that's fascinating. And you think that's a neurology referral issue? Yes. Yeah.
We're lucky to go for medicines, which is potentially curable.
Yeah, absolutely. Yeah.
Yes, Masco, I follow you. I understand that you give the message, go more for surgery for the epilepsy, considering the chronic use of medicines and their complication. What about the vagus nerve stimulation? What's your idea about?
Yeah, we've put in a few, literally 3 or 4, and it does seem to work. I mean, I've got colleagues in private practice who do it quite a lot. It's expensive. So in the public sector, teaching hospital where I work, you know, you've really got to justify the cost, and it's a palliative intervention. It doesn't really cure the epilepsy as many other surgical interventions can do. So I'm a bit skeptical. I mean, trying to figure out why it works is fascinating, but I think it's not effective enough to justify its use in a resource limited setting. Does anybody here have a different experience with VNS? Yeah, Alistair.
Thank you, Graham. We go abroad. We went abroad for training about this type of surgery, but when we return, we have problem with neurologists. I saw in many countries, neurologists don't refer patient for intractable epilepsy. How is somebody has the experience to convince them? It's a great problem for us. No reference from neurologists is there. They see the maximum of patients.
Yeah. Yeah. Ivan, it's a big problem because it's not a condition that neurosurgeons can say, oh, we don't need neurologists. We're going to just do it anyway. You have to have a neurologist involved in selecting the patients, working them up. But so we're very fortunate. The reason our children's epilepsy program took off is we recruited a pediatric neurologist who loved epilepsy surgery, and her main goal was to find patients we could operate on. That's amazing. That's what you want. On the adult side, the neurologists were not interested, and it's taken a long time. There's now a change, and they're now interested. But we worked in a situation where on one side we had very enthusiastic neurologists, lots of patients, on the adult side not. But it's fundamental. You can't go it alone. This is not a situation where neurosurgeons can try and do it without neurology.
Thank you very much. I think that's we are short of time, so this concludes the 5th session, and we can proceed for the tea.
The tea break is 15 minutes. We'll be back at 3:30, please. Thank you. Welcome back. We will be starting our second last session of the day, plenary session on neurotrauma and peripheral nerves. The chairs for the session are Dr. Deborah Gorodza, Dr. Lucas Rasulich, and Dr. Damien Kofler.
Good afternoon, everybody. It's my pleasure on behalf of my co-chairman to start this afternoon plenary session about peripheral neurosurgery. And this is more important even in because of the fact that organizers, especially Professor Tariq Khan, recognize importance of peripheral neurosurgery, giving this plenary session to this important field of neurosurgery. So well-known fact is cutting your nerve changes your brain. Let's hear what Deborah Garozzo will tell us about nerve injuries and general principles.
Assalamu alaikum. Good afternoon, everyone. First of all, I would like to say a big thank you to Tariq Khan. Is a good friend, is an excellent host, and especially I have to say thank you for giving such highlight to peripheral nerve surgery. Thank you from the deepest of my heart. So we are starting to talk about the basics of nerve injuries. And the first thing I would like to mention is that we have to start from epidemiological data. Now, the current medical literature certainly underestimate nerve injuries because nerve injuries usually occur in multi-trauma victims when neurological evaluation may be quite extremely difficult. It might be challenging to detect them because life-threatening injuries captivate the attention of the treating physicians. Patients are probably not even physically examined trying to detect the presence of these injuries, as this paper published by a Pakistani group actually emphasized. The truth is that we are observing an escalation of nerve injuries, especially in LMIC, due to the spread in two-wheeler motorization, which unfortunately is usually not associated with security measures. And there's another cause that sadly contributes relevantly, the ongoing warfare that currently plagues many areas of the planet. So some wars are very well highlighted in the press, but some are not, and they are, I would say, children of a lesser god. And that's the case of the genocide that occurred for 3 years in Tigray. A war that has contributed with 3,000 patients on a waiting list for peripheral nerve injuries in Makalle, as we were told in Addis Ababa last year in April. So statistically, we certainly only see the tip of the iceberg. However, the importance is not only statistical, it's also related to the social impact of nerve injuries, especially when you consider that the setting of the trauma might be the upper extremity, that the patients affected are usually young patients at the peak of their productive years. And I don't want to just establish a competition between invalidities, but if you want to understand how devastating may be to have a brachial plexus injury that results in a flail arm, I would like you to make an experiment. Just try to live one day only using one arm, especially if it's not the non-dominant hand. So this is why actually I have a little dream that I think that I might express here, that when we start talking about global neurosurgery and we mention neurotrauma, we are not talking only about brain and spinal cord injuries, but we are going to also include nerve injuries, because when it comes to complex injuries, they have to be considered in this group. So now let's become a little bit more technical. When we have a patient with a nerve injury, the main thing is to have to establish the prognosis and to understand when we have to select the patient for surgery. Now, in open injuries, the chances that you have a transection of the nerve are extremely high, and you always have to go for surgery.
If you just have a transection of the nerve, then you can schedule your surgery within 3-4 days after the traumatic event. But if the nerve injury is part of a more complex injury with vascular, tendon, and bone injuries, then this requires an urgent procedure. In close injuries, the damage on the nerve may be reversible, so we have possibilities for spontaneous recovery. And this is the reason why at the beginning we have a wait-and-see approach that may just mean that we clinically monitor the patient for a few months. And then if we do not see any signs of renervation, we go for surgery. Besides electrodiagnostic investigations that help us, imaging is crucial, and it has a pivotal role nowadays. And I would like to mention that ultrasound is something that can actually be quite available also in LMISC. Surgically, which are the key points? Never go without intraoperative electric stimulation. Do not use the commercial disposable devices. Much better to use the device used by the anesthetics. Magnifying tools are essentials. And the nerve suture should be always done, or preferably done, under the microscope with nylon 90 and fibrin glue. So the spectrum of techniques that we have may be customized depending on the kind of injury that you have. So neurolysis, which means that we try to identify and isolate the nerve from the surrounding tissues, is actually the basic of our techniques. And then based on surgical findings, we decide the repair strategy. So if you have a sharp injury that is referred to you immediately after the trauma, you may have just a discontinuation of the anatomical continuity of the nerve with no loss of substance. But if it's a late referral, then you are going to have a gap in between the two stumps because of the stump's retraction. And you may also have situation when apparently there is an anatomical continuity, but you have to understand whether that's related to function. So direct suture and graft repair. Direct suture, obviously, when you have no loss of substance. And it's very important that when you suture the two stumps of the nerve, you pay attention to the opposition of the fascicles. This is increasingly important the more distal the lesion is. Direct suture have two prerequisites to be successful: no tension on the suture and good fascicular architecture on both interfacing surfaces. And in this regard, it's essential to trim the nerve stumps even in early repair, because otherwise you might have occurrence of fibrosis at the site of the suture with development of a neuroma. This is certainly what is really useful to provide a shortcut. There are some tips on how to reduce the distance between the stumps. The Tsuga is probably the one that I use more often. But then sometimes the distance in between the stumps actually requires the interposition of a graft. We usually take the graft from a sensory nerve, more frequently the sural nerve, because it's easily accessible, it's long, it's quite thick, and the comorbidity which is associated is actually quite minimal. And then we measure the gap in between the two stumps, and then we proceed to doing the graft with as many cables as we can to match the caliber of the nerve. And this is the final reconstruction. Keep in mind that it's always good to add a bit, like between 10 and 20% to the actual gap in order to prevent tension during the movements. But this kind of techniques may not be applied if the nerve has lost the continuity with the spinal cord, which is to say if there was a root avulsion. And in this case, we have to resort to different techniques, which are the so-called nerve transfers. I'm not going into the details of these techniques. I just wanted to mention that nowadays nerve transfers are applied. We are starting also in case of tetraplegic patients. So this is a new frontier. We consider the nerve transfer a revolution nerve surgery because they can provide faster and better recovery in comparison to graft repair. We may use them also in late referral cases, and we know the low rate of failure is on our side. But we shouldn't abandon nerve graft because there is an anatomical reconstruction that can provide restoration of both motor and sensory function. The mainstay of post-op care is immobilization for a couple of weeks and physiotherapy, which is essential to maximize the results. If you do nerve surgery, you have to be a patient person because you have to wait for axonal growth to occur, which means that sometimes we see the final functional result of our procedure even 2 years after the procedure, or even longer in case of complex injuries. There are several factors influencing surgical renervation, concerning the patient's better results related to age. So children do wonderfully. People older than 40 may have progressively decreasing chances of favorable outcome. The type of injury, sharp injuries do better than gunshots. The complex injuries may have a worse prognosis. It's important also to consider the type of the nerve which has been damaged. The more refined the function of the nerve, the less chances of favorable outcome and also in correlation with the site of the injury. The type of surgical repair. We usually consider direct suture gives better results than graft reconstruction, at least if the graft is longer than 3 centimeters, and they shouldn't be particularly long. But the most important thing is timing. Please refer patients to the nerve surgeon within 6-8 months from the injury because this is when we can get the best results. Sometimes we cannot just use nerve repair and we resort to another group of technique, which are tendon transfers. If the nerve injury was irreparable, if it's a long-dating injury, and in cases of nerve repair, which is burdened by failure. And in this regard, sometimes we associate the nerve graft and the tendon transfer in the so-called hybrid techniques. So I think I've been able to give you a brief overview of these lesions, and I thank you for your attention.
Thank you, Deborah, for this great presentation. We have time for some question because there's
any questions?
2 minutes more, yeah.
Ross.
Take a microphone, please. Take a microphone.
Lost to society of somebody, in their 20s and 30s not being able to work because of that sort of injury. But I think there's another point that this really feeds into. One of the aspects, I think, of neurosurgical training in the development, the HICs is, at least I think in where I am, they see very few of these type of injuries. And that's an argument to have people go for 6 months or so to a center where they do see a lot in an LMIC and get the experience that they wouldn't otherwise get. So I think you've got a real good point there to encourage this interchange between the LMICs and HIC training centers.
Yeah, well, I mean, I think we are starting to talk about that. Just to mention, recently we had a few conversations with Moody Qureshi about the importance of trying to implement peripheral nerve surgery, especially in Africa. We have been talking about doing courses also in Southeast Asia. There is a need for surgeons trained in peripheral nerve surgery, and I think we will try to develop as many programs for that as we can, also in terms of exchange between countries where this is a well-established subspecialty.
Another question.
We come across patients occasionally when post-injection, for example, foot drop or the wrist drop. Do you have any experience with that?
Take a microphone. Take a microphone.
Yes, this is actually something that I'm not going to reply now because there are going to be a couple of slides in the next presentation.
Very good. We can move on. My great honor is to invite Professor Damian Kufler to present us his talk about a novel technique for restoring peripheral nerve function following trauma and eliminating chronic neuropathic pain.
Salam alaikum. I want to thank Deborah for her excellent presentation for two things. First, it was an excellent presentation, but it also is an excellent introduction to my presentation. That is talking about how the success and failures of peripheral nerve current techniques for restoring function. Now, as Deborah mentioned, There are three limitations to good recovery following peripheral nerve trauma. One is the delay in the repair. The second is the gap length. And the third is the subject age. What I would like to present today is a novel technique that we've developed, which seems to override all three or reduce the limitations of all three of these restrictive parameters. And in fact, in the typical autograft repair, your extent of recovery decreases considerably with increasing values of the three variations. However, what I'd like to show you is this novel technique allows you to get good meaningful recovery in spite of 70% of the subjects having the values of all three variables simultaneously large. This is just an example, a schematic of, here's the autograft repair. A second type of repair is to add a collagen tube around the graft. It's not clear whether that is very effective. The technique I'll talk about today is using an autograft, the standard of care, surrounding it by a collagen tube, and then filling the tube with platelet-rich plasma. Now, many of you are familiar with the use of platelet-rich plasma, PRP. There's many controversies about it, but that's not surprising. For example, people will say, but it works 50% of the time. That means it's not reliable. But that's actually the wrong interpretation. 50% may be depending on combining failures and successes. If you use one technique, you may get bountiful failures. You use another technique of preparing the PRT, you may get great success. That is, there are 30 different types of commercially available devices for preparing PRP. And if you do it the cheapest way, which is just in a little centrifuge tube, you actually really don't know very much about what PRP you're using. So this is kind of apples and orange comparisons, so one has to be very careful about the results. We use a unique device from Zimmer Biomet. I have no connection with them. I buy all the stuff myself out of pocket. It's actually FDA approved for use with holding bone chips for spinal repair, vertebral repair. The final technique, which I'll just mention, is forget the autograft, just surround the gap with a collagen tube and fill it with PRP. In this study, we had 17 subjects, 28 nerves. The gap lengths were 6 to 16 centimeters, obviously with a mean of over 7 centimeters, far beyond what Deborah mentioned would be likely to get success. Ages was up to 71 years, a mean of over 50 years, still success. And the delays, a mean of 1.6 years. So in none of these cases, or in most of the cases, would you expect to get any recovery. Here's an example of what Deborah showed you, where here you have a gap between a nerve, which is only 3 centimeters, but you've got a huge amount of scarring tissue here. By the time you cut away all the scar tissue, the gap was 8 centimeters long. Here's an example of a repair of an 8 centimeter gap. This was done with 1.5 years delay, 35-year-old patient. The recovery was meaningful, S3, M3. Now, one thing Deborah did not mention is a secondary problem of peripheral nerve trauma is a high incidence of chronic neuropathic pain. And this pain classically goes away when you get target reinnervation. But if reinnervation is limited, you often have this chronic persistent neuropathic pain. In this case, the patient had a chronic pain of 10 and it was eliminated. Here's another repair of a 12 centimeter gap. In this case, what we used, this is just before commercially available collagen tubes were available. We would take a collagen sheet, sew it into a tube around the nerve, and first actually put the autograft, sew the collagen tube, and then fill it with PRP. Again, M3, S3, and 10 pain was eliminated. When I say eliminated, it was truly eliminated and never came back for the follow-ups, which were from 1 to 15 years. Here's a more complex case. We have a peripheral central stump here, 3 distal stumps, 1 motor, 2 sensory. Scarring, once we cut the scar tissue off, we had three 10 centimeter gaps, 5-year plus delay, 26 years, no likelihood of any success. We used 1 sural nerve graft, and at this end, we did not have a graft. We just put 2 collagen tubes. These are the pre-commercial tubes we use. And again, we had S3, M3, and chronic pain of 10 that was eliminated. Another final case, I think this is, we have a patient, automobile rollover accident, there was no way we could actually restore much of the function, but we decided to try and see if we could restore protective function. So we tried to innervate the middle finger, and this was a 16-centimeter gap. Obviously, it would never recover. With a 16-month delay, the patient was youngish at 24. Nevertheless, she had recovery of S4, and again, the elimination of chronic neuropathic pain. You might wonder, what does this look like after the surgery? Well, in this case, one of the hand surgeon I was working with was doing working on the wrist of the subject, and he said, oh, this is one of my patients. So he decided to explore it. And here's the central stump. There's a little bit of accumulation of scar tissue, but this is the nerve that regenerated inside the collagen tube. The collagen tube gets integrated into the surrounding tissue, and this is a perfectly normal looking and conducting nerve. So these are the conclusions. The technique is good at least up to 16 centimeters. That's the longest gap we've worked with. The longest delay was 3¼ years. The oldest patient was 71. And it says, yeah, 84% had 2 or 3 of the variables that either reduce or prevent regeneration were large. I won't go into the further details of that, but the other important thing is that the pain was reduced in these patients in 8%, but there was about a 60% reduction. However, in 92% of the patients, the pain was eliminated, as I said, for long term, from 1 year for the shortest patient, 15 years for the longest patient. These are quite remarkable results, and we can understand skepticism. We can understand people saying, but PRP cannot do that. But there are many different ways of looking at that skepticism. We're using a very different type of PRP than anybody else. This has a 9.3% increase in platelet concentration, at least twice as high as virtually anybody uses. Much higher concentration of bioactive factors. When it comes to pain, people say there's no way it could work. However, platelets are the universal toolkit of the body. The platelets go to where there's trauma. They release all these factors, but they also release them in sequential sequential manner. For example, they first release pro-inflammatory factors. Obviously, that's counterproductive, but no, it's a physiological mechanism for triggering the physiological anti-inflammatory response. So the platelets trigger an anti-inflammatory response while simultaneously releasing anti-inflammatory factors. In terms of pain, one could think about the factors IL-10, for example, which changes the expression of certain sodium channels, which make neurons hyperactive. And if you can reverse those, which has been shown to happen with these factors, then why shouldn't it be long-term? If you can injure a nerve and create a chronically active nociceptive nerve activity, why isn't it equally possible to reverse it in the long term? So we're happy to collaborate or find if there's anybody who is interested in this or knows anybody who would like to try the technique, we'd be very happy to collaborate, provide the materials and the instruction on how to do this. Thank you very much for your attention.
Congratulations for this outstanding presentation, especially in terms of pushing the boundaries in terms of late nerve repair and nerve reinnervation, late reinnervation, and the older age of the patients in these circumstances. Any questions, comments? We have time. Yeah.
My question is regarding the use of this collagen tube. The availability is not here, at least in KPK in Pakistan. So can we take the fascia lata and make a sling from that? And can we use the fascia lata to make a tube from the fascia lata and to put it instead of using the collagen tube? So what do you think about that?
I think the answer is yes. I think you could possibly use fascia. First of all, somebody did a very nice experiment in the rat where they applied PRP to the surface of a peripheral nerve. And then they said, what happens when we put a collagen tube around it? Recovery was greater. The hypothesis is that there's less diffusion of the factors away, so you maintain a higher concentration. But you could use perhaps fascia or other materials as a substitute. But the nice thing about these results is it shows if you need to delay, in this case, we've seen success out to more than 3 years. So there's no anxiety in terms of what Deborah is saying. You've got to do this experiment. If you have to wait, such as in complex traumas, then you wait. Deborah also said, which is the currently accepted belief, that following traumatic injuries, such as gunshot wounds, the recovery rate is less successful. In our hands, no, that's not the case. But I think we know why, and that's because very few people, most of us do not have the opportunity of having a pathology lab to do a section, we don't either, where you could see, do you really have clean axons or do you still have scar tissue? So most people, because they're anxious about making the gap bigger, they do not cut away the proximal and distal stumps. We say, what is the difference if we make the gap bigger? If it's going to go, it's going to go. So let's go until we're really happy. And I have my colleagues, they're a bit conservative, but they're courageous enough to do it. And I said, no, keep going. But I said, we could do it over 16 centimeters. You're concerned about making it 6 instead of 5 centimeters, and boom, they cut it. So I think, yes, there are solutions.
Second question is, when you consider the patient for the tendon graft, if you operate on the nerves, particularly we see a lot of cases of sciatic nerve and radial palsy. So when you consider them for the tendon graft, tendon transfer?
Well, we have been not doing that in the sense we are just trying to focus on these patients for whom we believe that this technique is better. If we have a situation where my colleague would say a tendon graft is better, then we do that. But we take any patient. The reason we have patients who are 21 to 71 years old is because we don't select them. That's the good news. And nobody would choose to test a novel technique on a 16 centimeter gap because you know it's guaranteed to fail. We said, this is the patient, let's test it. If it doesn't work, we've at least tried the standard of care, which is an autograft.
Thank you. We have to move on. Great talk, a great discussion. I'm now inviting Dr. Deborah Grosso for her second talk, an overview of nerve injuries of the lower limb.
So in the meantime that we start uploading my presentation, I'm actually going to say that in this presentation, we are going to talk exactly about the cases that you mentioned, when to give indication for nerve repair and tendon transfer, and also the issues related to the intramuscular injections. So I do hope that this is going to be an overview that provides some answers to what you wanted to know. This one, the one in the middle. Yeah. So we are now going to talk about nerve injuries in the lower limb. And the first thing is that we have to consider statistically, they seem to be less relevant than the upper limb counterpart. They may occur at the level of the lumbosacral plexus or the terminal branches of the lumbosacral plexus along the limb. Lumbosacral plexus injury seems to be quite uncommon. They are complex injuries very often associated with fractures, vascular injuries, laceration of the internal organs, because they normally occur in pelvic fractures with dislocation of bone fragments. Fortunately, because compression is the main causative mechanism, we have a very low incidence of root avulsions and consequently a chances of spontaneous recovery in about 75% of cases. When we look at the nerve injuries in the lower limb, the ones which are more statistically likely to be encountered in your clinical practice are common peroneal nerve injuries, definitely the most frequent in injury in the lower limb, and sciatic nerve injury. And I think we are going to talk about how diversified and versatile can be nerve surgery, especially figuring what we can do in these cases. So sciatic nerve injuries may occur along the course of the nerve subgluteally or in the thigh. And although we may have even such a proximal impairment, for instance, with denervation of the gluteal nerves and instability of the pelvic, the most impressive clinical thing is the steppage due to the foot drop. And this is why we usually provide the patient a kick-up brace in order to overcome the foot drop. Now, subgluteal sciatic nerve injuries are usually iatrogenic, mostly frequently described in cases of hip replacement surgery. And this is due to the fact that when the orthopedic surgeon is trying to access the coxofemoral joint, they have to put retractors that might be responsible of an excessive traction on the nerve. It's difficult that you can do a transection of the sciatic nerve. It's a thick nerve. It's as thick as my thumb. So it's usually an overtraction. So this explains why we have a high frequency of spontaneous recovery that takes quite long because it might be up to 18 months. And usually the only cases where we would give an indication for surgical exploration at the subgluteal course of the nerve is when the patient has severe pain that might be consequent to displacement of the prosthesis, process of scarring, fibrosis, but this is quite an uncommon occurrence. In irreversible injuries, actually, the pattern is very peculiar because the internal component of the sciatic nerve almost always recovers, but it's the denervation in the CPN distribution which is permanent. So we have learned that going to proximal for a nerve repair is not actually very useful in terms of outcome, and this is why these are the cases where we give indication for tibialis tendon transfer that provides an immediate recovery of gait with no steppage with very high satisfaction of the patient. Another cause is exactly intramuscular injection, which seems to occur very likely if the patient is quite thin, especially in LMIC countries. These are problems because intramuscular injection may be given by poorly trained medical staff. And they seem to be more frequent in children. Now, a misconception, which is very common, is that the nerve damage is consequent to the needle injury. It's not like that. This is a chemical injury. We know that when the needle pinches the nerve, we inject a neurotoxic agent. Some are more neurotoxic than others. And we may actually have the development of the palsy in as fast as 30 minutes after the injection. Now, the acute onset of a foot drop after an intramuscular injection advocates for surgical indication as soon as possible. The literature would advise to go even within the first 24 hours after the onset of the palsy. But I may tell you that actually I have experience of having done cases several months later. In these cases, you do an external and internal neurolysis, and usually the results are quite favorable. But sometimes the patient may be referred to you after a very long time, like the case of the little girl I showed in the video. She was referred to me 5 years after she had the intramuscular injection. And then again, in this case, I did a tibialis posterior tendon. In the thigh, the sciatic nerve may be injured because of displacement of fragments due to fracture of the femoral bone. It's difficult that you have a complete transection of the nerve. And then gunshots. And Lucas may say more about that, but the sciatic nerve injury may be different depending on the kind of weapon. So bullets can actually cause a complete transection or a partial damage on the nerve. Shrapnel more often do cause a neuromen continuity, and sometimes there might actually be some partial preservation of function. Stab injuries in the thigh. This is something that happens usually as consequence to an aggression
exactly on time. I misspoke. If people are patient, we have.
No.
She wants to just give it here. She declines.
No, I mean,
Do we have a
was sup-
popular vote?
I was supposed to give a third talk, but I don't want you to drag Thirda into this ordeal of listening to me. So, I mean, I think we can just close here. It's not a problem.
Again, thank you all for participating and turn it over to Tariq.
So just thank you very much, everybody. I think we are now coming to the last section, and really, it's been great. And I appreciate and thank everybody, all the international delegates, all the national delegates, all the staff, and everybody who has been so hardworking in this thing. So just a couple of housekeeping announcements. So for the international delegates and for the national faculty, we'll be leaving for the dinner and music in the village at 7 p.m. And everybody should be in the buses by 7 p.m. So not in the lobby, they should be gone and sitting in the buses. Also, tomorrow morning for the international delegates and for the national faculty who want to go to Khyber Pass, I hope everybody wants to go to Khyber Pass. The faculty, I mean, should be in the buses by 8:15 a.m. because the military escort will be there and they may not tolerate any delay. So also, we have these, just in case you have a problem with checking out in the next 2 days, the numbers are there. And if you have a problem with airport transfer, the numbers are there. So just in case, but my number you all have, so you can call me anytime. We would want you to reach home safely, and we will stay awake until you reach home safely. So now, unfortunately, Professor Najia Al-Abadi, the president of World Federation of Neurosurgical Societies, could not make it to this conference. At the last minute, she had to cancel. So we have a video recorded from her, and we would like to play that video for everybody, please.
Good morning. And I am happy to be with you, even if through this video, because there is a technical problem with the Zoom, and this is why I am here with. I sent this video to, of course, extended my profound gratitude to the organizer of this grand global neurotrauma surgery meeting, particularly Dr. Tariq Khan and his great team, and for this dedicated effort in ensuring the smooth executions and the success of this exceptionally high quality scientific congress, as I said in the program, which can rightly be considered one of the finest in the world, and also thanks to Pakistan and all our friend colleagues from Pakistan for their legendary hospitality. I had also the honor to knew the first group of the global neurosurgery with first Tariq Khan and Walt Johnson, Key Park, Gabe Russo. But the first three names we had organized in 2017 in Morocco, the first international conference on the global neurosurgery of medical students, but also for seniors and surgeons and also neurosurgeons. This international conference was the first in the world, and of course I remember, of course, this device for the first time when I saw that in Rabat. I hope that you of course enjoy your stay in Rabat in 2017. So today we will speak about the global neurosurgery. The global approach is in a light of the recent assumption of the current administrative committee. This new area celebrating inclusively and levelly the field in starting with an African woman as head of the World Federation of Neurosurgical Surgery. It is no surprise that the main focus of this mandate is a vision of better governance, cohesion, and unity, which can only be achieved through synergistical improvement of neurosurgical care around the world. Global neurosurgery as a part of the global surgery, you know that, 2003 to 2013, movement recognized at the World Health Assembly resolution, so 680.15, aims for universal access to timely, safe, and affordable surgical and anesthesia care for our patients. Globally, and even more so in a lower and middle income country. One of the main obstacles is the insufficient number within the neurosurgical workforce. Estimates show that around 5 million neurosurgical cases should be performed each year, with a need for additional adult and pediatric neurosurgeons, rising up to 23,000 surgeons. Consequently, neurosurgical training must be an essential focus point for the reform to come. We were able to double the amount of scholarship offered in the, for example, I will take my country, but sorry, because I have this proposal for sure. East Rabat Center, Rabat Reference Center for Young Neurosurgeons from Africa in Morocco, sharing these experiences with other training centers in the spirit we try to install through the WFNS, and that must be carried out by each and every one of the neurosurgical workforce around the world. This center start by our big master, Professor Khamnishi in 2020, and this 2022. And today we trained more than 60 young neurosurgeons. And that time when we start this center, there is at least most countries in Africa have zero neurosurgeon. Today there is no countries in Africa with zero neurosurgeons. Cost effectiveness as well as equitable distribution of available resources are the two connect and treat. However, counterintuitivity associate when developing neurosurgery strategies globally. On-site international education after completing of the neurosurgery training program is encouraged as it encourages the trainee to think in line with requirements and needs of global health. Additionally, to teaching them to think outside the box. Prior to the recent, for example, COVID-19 pandemic, this request to traveling abroad, the registration fees and the travel expenses oftentimes were prohibitive to the majority of young neurosurgeons, even for seniors. In the aftermath of the pandemic, many questions were raised about the essential of global health and the management of the health system. Concurrently, education has shifted to the use of video conference and platforms to elevate the counseling of all courses formally requiring attendance, lectures and conferences, as well as case discussions and meeting covering various neurosurgical topics where all held electronically. E-learning appearing to be an attractive, easy, comfortable, cheap solution to help educational social gathering. But it has also shown some downsides, resistance, financial issues, infrastructures, and dedicated AT information technology. Nevertheless, the rapid increase in the speed of the travel and communications, as well as the economic independence of all nations, has led to a new level and the speed of globalization that can be a driving force. So a global neurosurgery is by definition an international matter. Effort must be put into promoting the building of international canal between high income and low high income and low and middle income countries. Cross selectional study through dissemination of a web-based survey to evaluate the state of global neurosurgery activity amongst European neurosurgeons, published in 2022 by Medirata and the collaborator, has shown that amongst the barriers to more prominent European participation to global neurosurgery, at that time, there are individual obstacles, chiefly cost and family duties. Carrying the neurosurgical torch means honoring a legacy and furthering research in homogeneous international evolution in an effort to ensure access and equity for all the serving actors to achieve the best quality of care for our patients. Our ultimate goal as a community should be provide a better quality of life for both the patient and the surgeon also, and a true research for humanity overall. So therefore, a long-term solution to reduce the hardship of access to education and research for training in LMIC should be discussed. Is very important. As they not only serve a deeply human purpose, but they are also highly beneficial, if not necessary, for the individual growth of young trainees by developing critical thinking and encouraging independence. Moreover, inclusivity should never be seen as a setting lower standards for ourselves. Instead, it's keeping the door open for all worthy candidates, no matter their background, so that brilliant idea don't get lost in social gap. Thank you so much. And I hope you wish you a successful meeting.
So we heard from Professor Najia El-Abadi, our friend, president of WFNS. I would like to request my good friend, first president of WFNS, Professor Keenan Arnautovic, to come and say a few words here as well, please. Please, Keenan. Thank you.
Good afternoon, ladies and gentlemen. I would like first to thank Professor Tariq Khan for the opportunity to speak. I don't have really much to add to the notion that global neurosurgery is so important nowadays at this junctional point of development of our profession. I think that this first meeting of the global neurosurgery organized here in Peshawar, beautiful Peshawar in Pakistan, is a beautiful start of one organized activity towards that end. I'm sure that World Federation of Neurosurgical Societies will fully support those activities, and I cannot see the better leader for this endeavor than Professor Tariq Khan. He is fortunate. He has just been nominated and confirmed as the chair of the committee, but he's very fortunate that he has a strong people with him, and he obviously has surrounded himself with those people, not only theoretically, but practically. We can see our great Key Park here. Let's give him a round of applause for everything that he has done. Professor Franco Servadei, who is our great leader and mentor. And of course, Gail Russo, last but not least. And in this audience, we can see a lot of officers, present and former, from various societies, from EANS and AANS and CANS, and I don't think we have anybody from Flank, to my knowledge, but I'm sure they will all support this mission as a very important one. I forgot one more, Dr. Val Johnson. I don't see him here. Is he here? And of course, Russell Andrews. Sorry for this. So anyway, I will close with wishing all the best. I'm sure it will be very successful, and my miniature will help as much as I can. Thank you so much.
Thank you, Kiran. Thank you very much. Yeah, I'm going to talk about something which started when I was in Oxford last May or June, when we were there in Cambridge, where we were at the opening of Professor Hutchinson's NIHR program, and myself and Professor Ante Figaci were talking, and we were discussing how to improve services for neurotrauma, and we thought that maybe the best thing to do is to try and make neurotrauma a notifiable condition. Since then, I've been raising this point everywhere, hoping that people will join me. And interestingly, a group has already formed about whom I'll let you know. So first of all, just to briefly make our audience understand, nowadays, notifiable conditions are mainly infectious diseases and foodborne illnesses, and there's the role of public health surveillance in that. And presently, only in Australia, and the Government Department of Health includes TBI in its reporting, and no other country is doing that, making it notifiable. So if you look at the WHO Global Health Estimates, and that is why it's important to make it notifiable. If you look at the top 10 global causes of death in 2019, I think you can't see traumatic brain, spine, or peripheral nerve injuries. And thank you for reminding me about that, Professor Deborah. We will include that as well in it. And if you look at the top 10 global causes of disability adjusted life years, again, road injury, not TBI, is number 6. And then if you look at the state of health in Pakistan and its provinces and territories, and that's what made me thinking at that time. Professor Andrew Maas sent me this article and said that it's very strange that traumatic brain injuries or road traffic accidents are nowhere to see in these graphs, really. So, but you know, the reality is different. You have seen these photographs before also. And then we looked at some papers that, you know, TBI is very important and we need to look at it. And this was the Lancet Commission report in 2017. But the systems of care for people with TBI greatly and very greatly and disconnects exist in the chain of care. And strong evidence to support treatment guidelines and recommendations is scarce. And current treatment strategies insufficiently target the needs of individual patients, generally being based on a one-size-fits-all approach. So the Lancet Neurology Commission highlights priority and provides expert recommendations to reduce the global burden. But obviously, if you cannot see the numbers there, you cannot tell the government or anybody to act more or give more finances or give more help to traumatic brain injuries prevention. Brain, spine, and peripheral nerves. Sorry again. So Ernest wrote a paper regarding the neurotrauma surveillance in national registries of low middle income countries, a scoping review. And then there was another paper regarding that it's a long overdue priority, the national trauma registries. And we already had been having, and everybody has their own registries, I'm sure, but like there's no connection between any of them. You know all about this, that the GNS outcome study, which was done by the Cambridge group. Many of us were a part of that study and did that. And it's become more important when Key Park and group and ourselves, we did the comprehensive policy recommendations for head and spine injury care in LMICs. And these were recommendations for policymakers. But until we can give them the numbers, and we can't give them numbers until it becomes a notifiable condition, so it can't really happen. So why neurotrauma should be notifiable? It will improve surveillance. There'll be early detection intervention, improved data collection and research, better resource allocation, preventing secondary complications in policy development. Of course, there are a lot of challenges in that. So what we did was that this group which got together, and just name of myself, Professor Franco Sarvade, Professor Walt Johnson, Professor Anthony Figacci, Professor Peter Hutchinson, Professor Gail Russo, Professor Key Park, Professor Asra Al-Fawzi, Dr. Almaz Khadak, Dr. Megan Still. We had a Zoom meeting, I think, some weeks back and discussed that, and we talked in South Africa as well to look into it. And we have shared this document with you. It's a brief outline of the actual document which is going to be made. And the plan is that we can work on this, and then we can hopefully try from our experience from many people, the neurosurgeons who were in the G4 Alliance and who were there in the World Health Assembly, who made it possible through Kemal Ghatme and everybody, and Gail Russo and Jeffrey Blount and so many other people, made it possible to have folate fortification approved by the World Health Assembly unanimously, so that now the governments of all over the world are supposed to report every 2 years to tell them what they have done regarding folate fortification. So what we hope that with this idea and this experience, we can try and push, especially when Gail Russo is the chair of the G4 Alliance, so we can get G4 Alliance to leverage the World Health Assembly to try and make this notifiable. So we're working on it. It may not happen this May, but it may happen next May, hopefully. But we should work on it and try and do it as much as possible, because it will save lives, it will improve patient outcomes, and it will contribute to better understanding of these injuries. I spoke briefly because I would like all of you to speak about this and give your opinion about this. I have to, as a duty, put this up. The chief editor is sitting here, of course. So I thought I'll have time so everybody can give their own opinion. Dr. Almaz, can you make notes of this also? So see, you can get a paper and pen maybe. Thank you very much. So, thank you. So anybody has any suggestions? Professor Key Park. Yeah, you can, yeah, or you can. No, regarding neurotrauma and the notifiable condition. Yeah.
Yeah, I just want to, sure.
Yeah.
I'm completely on board with this. I think one of my frustrations in looking at the global burden of disease data has always been if you look at the data visualizations of DALYs and years of life loss due to disability, mortality, et cetera, for both communicable and non-communicable diseases, each disease entity is listed by diagnosis. And I think it implies a certain health service delivery pathway. But then when you look at injury, all of the injury is classified by mechanism of injury. And you don't see how people are dying. You just see that there's road traffic incidents and you see falls and assaults, et cetera, et cetera. So I think this is a huge gap in the global public health space. And count me in to support with this.
Great. Thank you, Ernest. Please.
Thank you. Without a doubt, we need to obviously support this. But policymakers are not medical people. And when you want something like neurotrauma, the next question they will say, what is neurotrauma? Please explain to me. We already have TBI, traumatic brain injury. And I would suggest that we make TBSNI the term that we would use. So traumatic brain spine nerve injury as the notifiable term, so that the individuals in the policymaking world can immediately see what are we talking about. We're talking about brain, spine, nerve injury. So I would fully support this, but I would say we use an identifiable term such as TBSNI. Thank you.
Yeah, very good. I think Key Park mentioned this, gave this sort of comment in the G4 Alliance meetings regarding SOTA care, because people don't really understand that meaning of that. So I think it should be something. Yeah, good idea. We can look at that. Anyone else would like to?
Yes, please.
Yeah.
So thank you, Professor Tariq Khan, for an excellent meeting. Yes, neurotrauma is a big deal. And you can, again, in the words of Ernest, you can count me in. But what point I always wanted to make, and I've made it to Beverly before, is to think of the causation, especially in the low middle income countries. When Professor Gay Russo was talking, she was talking about fall. Professor Sabade is one person whom I'm aware knows the fact that in the developing countries, it's trauma, it's road trauma. But what's even more peculiar, interesting, curious for me is the fact that historically, when you talk road trauma in developing countries as causation for neurotrauma, you'll be talking motor vehicle accident and a sprinkling of motorcycle. Now, motorcycle has actually taken over. And to me, it's one of those funny, unconscionable human behaviors that you want to mass move people with monotransport. It's an oxymoron, right? You want to move people, mass movement of people with monotransport. If you're looking for something through which neurosurgery can advocate to the World Health System in the realm of public health, I believe if there's something that can be done to seize the movement of people with monotransport, that would be a big deal going forward. If you can wipe out the use of motorcycles, maybe I'm talking too idealistic, maybe what I'm asking for is too impossible to chew when beaten. But I think if you can get motorcycles out of the way as means of mass transit in the developing countries, not only neurosurgical public opinion importance, even orthopedics, they may also be able to work with us. Thank you very much.
Thank you. I don't want to take advantage of being chairman. What you mean, one final comment so that we can move forward?
I'll be very brief. With most resolutions that go to World Health Assembly, you need partners. And our fortification and the surgery resolution are no different. We need to find partners that can help us with this and not try to do it solo, because that's not going to be very successful.
Great.
And the second thing, just like our fortification and the surgery, we look for different subjects like fortification. There was iodine and iron and everything. I think we need to look at other issues that should be reportable, whatever they might be in the world, and find them as partners and add it to this resolution. It has a much higher chance of success.
Thank you. Thank you very much, everybody. So I think we're going to move forward to the next very important part, because I believe, I hope that everybody thinks that we had a very successful first ever international WFNS Global Neurosurgery Conference. But where do we go from here? I think that's very important. We don't want to just have the conference and then end of the story. You know, I think there's a lot to do. And I think global neurosurgery movement is really, really pushing in a big way. So we're going to, I'm going to request Professor Key Park to come and moderate this session. And I will request Gail Russo, Franco Savade, and Professor Robert Dempsey to come on stage and we can discuss the future. Key.
Hey, let me see if I can set the stage. How do we get to where we are today before we talk about tomorrow? Once again, I want to congratulate Tariq and the incredible organizing team. This has been, outstanding. So 7 years ago, there was a thing called Bogota Declaration. How many people have heard of it? Right, great, awesome. In fact, most of the people that were involved with that are here today. It was drafted. Tariq was there. Franco was here. Franco was there. And we handed it to Walter Johnson as the WHO representative. It was a piece of paper, blank, but we just took a picture and saying, this is it. But the Bogota Declaration was a way to punctuate and publicly declare that we have a problem. And what it called for was a, yes, please. Walt, you should come up too. And yeah, okay. And it was one thing it called for, collective action. That's it. Collective action to meet the current unmet needs of neurosurgical care. Now, since that was in December of 2016, it was in Bogota, Colombia, and a lot has happened, a lot. And I'm going to try to just recap that. Just be patient with me. So first thing is, Franco, there he is. In 2019, when he was the president in Beijing, said, we need a global neurosurgery committee. And the president has that power, right? It's an ad hoc committee. And he asked me and Abdusalam Aluabi to be co-chairs. And we started a global action plan on global neurosurgery. Then Nelson Oyasiku, 2 years later, asked me to continue on as president or chair of the Global Neurosurgery Committee. And then just in Cape Town, in Graham's meeting, we had, I finished my term. We had an amazing global neurosurgery series of sessions, right? One of the best attended sessions, multi-day. And then Tariq has taken over since that time. He is now the de facto, or we're not sure exactly what to call him, but he is the GNC chair, as far as I can from my point of view. Now, the continental societies have also institutionalized global neurosurgery, right? Andreas is here, the European Society. They've created, and Lucas is the chair of the Global and Humanitarian Neurosurgery Committee. AANS has created a global strategy committee. Alistair? Oh, hi, Alistair. The British Society of Neurological Surgeons have started. We just saw that this weekend. AANS is having actually either half-day or full-day session during the AANS meeting in Chicago on global neurosurgery. CNS has a funded fellowship, global neurosurgery fellowship. On top of that, we now have a number of global neurosurgery centers, or what I would consider teams, research teams, really. PGSSC was, one of the first ones, which I led, and we've had a number of fellows come through in the program. And Ernest is actually one of our previous fellows, and he's an example of someone that actually went out and created his own global neurosurgery program within his own institution, and we see a number of that. Barrow, Gail's associated with Barrow. Downstate is Ernest's program. Vanderbilt, Michael Dewan, who's really the person behind all the baseline papers, 23,000, 5 million. He's the quant. I'm just the ideas guy. He was the one that did all the proportions. Now, I was so pleased this weekend to see so many presentations using the same definition of global neurosurgery. Because if you, 3 to 4, 5 years ago, we had 10 different definitions, but now we can agree the clinical, right? How to do surgery better, and right, there's a new dimension to it, the public health practice of neurosurgery. It's a practice, and we have a purpose, right? It's really a social justice issue. We want to eliminate health disparities in neurosurgical care. So it's really about those places where there's no access, no care. So there's more. I mean, the journals, right? One of the things that we wanted to do in the Global Action Plan was to get sections within the major neurosurgical journals to include global neurosurgery. We have Gail now is the section editor of the Red Journal, and we have the World Neurosurgery. I think Russell is here, right? Yeah, he's the section editor for the global neurosurgery part of World Neurosurgery, right? More or less. It's called doing more with less, literally. And then there's a whole new journal, ladies and gentlemen. I mean, I haven't talked about it much, but it's called Journal of Global Neurosurgery. It's a fledgling new journal, no article processing fees, always open access, and preference to LMIC authors. And you can see why it's fledgling, right? We don't make any money, but it exists. And we'll talk a little bit about what to do with that journal. Okay. So what kind of activities has gone on since then? We've had, among all the subspecialties in surgical care, neurosurgery is at the leading edge of what a subspecialty can do to address unmet surgical needs. So we are actually on a third iteration of the global neurosurgery workforce map. We're actually tracking it. That 49,000 number is actually outdated now. We have over 70,000 neurosurgeons in the world, which is remarkable. The increase, well, yeah, give yourselves a hand, because who knows what would have happened if we didn't talk about that, right? So that's been a remarkable increase. But the increase is happening mostly in high-income countries, right? There's percentage-wise in Ethiopia, they went from 3 to 100. Looks dramatic, but still that's not enough, right? So there are some issues, but people come to us and saying, "What did you do? How did you do it? We wanted to create a map just like you." These are other subspecialties. We have global neurosurgery country coordination with teams. We are not an NGO. We're not an implementing partner. We don't get grants to go out and build up buildings and train people. But what we do have is connections. We have networks. So Tariq was the coordination lead during the last Global Neurosurgery Committee, 2021 to 2023, and started the Sierra Leone team and the Afghanistan team. And their work will continue in the future. So that's been a positive development. We're thinking about other countries. There are a number of countries actually with 0 or even like single-digit neurosurgeons, and they need help, right? And how do we best help them? And then we just saw the comprehensive policy recommendations for head trauma, spina bifida, hydrocephalus, and most recently we have the brain tumor recommendations that will be coming out very shortly. So that's where we are within the 7 short years of global neurosurgery, from a declaration, we had nothing on paper, no research, to now where global neurosurgery is a thing. So congratulations. So we're going to spend a little bit of time today to hear from some of the seasoned veterans, but we really want to hear also from all of you. where do we go from here, right? What do we need to do differently? What have we not thought about as we move now, next 5 years, 10 years? So let's start. Oh, we have someone, please. We have a note taker, right? Yeah, okay, okay, great. And just raise your hands and even over there, yeah. Okay.
First of all, I would like to thank Dr. Tariq Khan for a wonderful organization, a wonderful conference, and I'm very happy to be here. Actually, when I got the invitation, I'm the chairman of Neurosurgery in Qatar. I was not certain whether I should come or not, but I thought this is a good idea to come and see how things are, and I was really amazed. So thank you. The second thing that I have in mind is for those countries who are underprivileged or they don't have a system or neurosurgeons, how we will reach to them. Like I'm originally from Libya. I practice in Qatar, I trained in Canada, and I practice a little bit in US. But in Libya, there's this huge need for a neurosurgeon. They don't have a neurotrauma. During my last visit there, they don't even have an ATLS programs. So as an organization, as you guys are doing a wonderful job, how can we connect to such countries? Is there something?
Yeah, I have an answer. That's a great question. By the way, welcome. Thanks for coming. Let's go over there first with some answers.
Thank you very much for bringing this point up. We had a meeting yesterday, the Global Neurosurgery Committee, and what we are looking at is that any country which we feel, and we're going to circulate the map to all the people, all the lists, we are looking for a champion in each country. We had a champion in Sierra Leone. We had champions in Afghanistan. And through those one champion, then they became many champions. And then the government got involved and slowly it developed. And it's not, we're not talking about giving aid or anything like that. That's out of the question. What we are talking about is that there has to be champions and the government has to be on board. And the champions have to ensure that the governments get on board. You know that there are a number of centers, most prominently is the Rabat Center, and there's other centers as well, where we can try and push and the idea is to push the WF Foundation to get more centers recognized and more scholarships for that. Let's say if you are a champion in Libya, you can approach us and talk to us and we can further these things that way. So, yeah.
Yeah, anyone else from that panel?
Yeah, I would just add that we don't make any we don't do neurosurgery or make any progress in a vacuum. So very often in countries where there are no neurosurgeons, our champions are general surgeons who are doing neurosurgery. So we work with the surgical society of that country or with their regional society in developing high quality task sharing systems until such time as we can help them develop a proper neurosurgery training program.
Yeah, there's that phrase in Turning Point by Malcolm Gladwell, the rule of the few, right? So you need that few champions. Should we go to Max then, please?
Well, Tariq, thank you. Tariq had invited me to have another course this time. And we had a successful meeting today with about 120 physiotherapists and physiotherapy neurosurgeons, surgeons attending. So I think neurorehabilitation should be integral part of this global neuro aspect, not only neurosurgery, but neuro taken together. We would like to participate in this endeavor.
I have a follow-up comment on that. So what we saw in Cape Town was people coming to the meeting who weren't neurosurgeons, right? Normally neurosurgery meetings were only for us, right? But global neurosurgery, if you're trying to improve delivery of neurosurgical care, you don't actually have to be the one doing the neurosurgical operation. We needed nurses. In fact, there were some really outstanding nurses giving one of the best talks in Cape Town. So if we ever decide that we want to have let's say, a new organization, just saying, right? If we say we want to have a Society of Global Neurosurgery, you have to include other professions beyond neurosurgeons. And also the students are amazing. The students can do incredible advocacy work. They literally changed the budget in the US to do grassroots efforts to increase, to put language within USAID to support surgical system strengthening. So just a follow-up comment on that point. Yeah.
maybe global
Oh, Mike, please.
committee is the only committee where we already have nurses in that, and we are looking for other allied people. Like Max pointed out, we had a very good nursing course yesterday, 2 days back, with more than 100 nurses participating. We had nurses from Qatar and from other places who came, and from Aga Khan who came, and they taught them. So nurses and allied rehab, everybody has to be a part of this global neurosurgery commitment. Sorry.
Yeah.
I just want to follow up on this. The key in starting anything is to be invited and to listen. And one of the most important things is listen to the strength that we possess and how we utilize it. Neurosurgeons aren't very special. There aren't many. We're nothing that special, but our patients are, because we interact with so many severely important conditions, trauma, congenital anomalies of children, etc. And we do that by partnering. So that's where, the nutritionist, that's where the government, that's where the advocacy comes in, because we can influence them. And so the future is by carefully picking those partners, listening, and then developing on that expertise.
We actually had 2 people from the Ministry of Health of Sierra Leone, very high level up, come to Cape Town meeting. And thanks for giving them a discount, by the way. They're like, why do I have to get CME credits and pay for that? But that's a new thing, right? They're interested because they have no neurosurgeons in Sierra Leone. And they said, how do we improve that? How do we solve that? Bill.
Yeah, thank you. First of all, congratulations to you all, because I think it's amazing update that I received today listening to all of you speak. And it's amazing the work that's been done and how organized you're becoming. And the one point I wanted to make is we actually started a research track in our residency. And I just wanted to present this as a model that you could consider. So we have a research track that is global health for our residents to choose, and they can study and implement policy, etc. And we also have last year, one of the White House fellows was Jeff Nadell from our program.
I know Jeff.
Yeah, and he's amazing. And he has spent his year in Washington looking at inequities in care and how to, resolve inequities in delivery of care across the nation. So he would be a great nidus, because I think you need to get some younger people involved and get some research programs going and integrate young people as they come along and develop a broader research enterprise than just what you can do. So,
Bill, thank you. I know Jeff. By the way, this is a US thing, but there are other examples of this.
it can be extrapolatable to other
Yeah,
countries.
yeah. There might be ways where, so this model is, they take really, really bright people and super competitive. I think 30 a year, you have to have like the recommendation from the president or something. And then they spend a whole year embedded in the White House.
Right. Yeah, he did his research year there. And he was, I think, the third neurosurgeon has been a White House fellow. Sanjay Gupta was one of them.
Yeah.
The CNN health guy. And so I just think it's a great opportunity. He's kickstarted already, and he could probably put together a research, sort of a portfolio for you to consider.
Great. Okay, I'm not sure who was next. I think, go ahead first, yeah.
I want to tell very grateful, very thank you to Tariq and your group, Gael and the others. I'm a member of Francophone Sub-Saharan African neurosurgeons. We discover global neurosurgery in Cape Town at the WFNS Congress. And it was amazing for us. Before we thought it's only for Anglophone. And since 2 months, we are beginning to make organization around us to join the group, to make action plans for developing our specialties in around 20 countries. I call especially for each leader in each 20 countries. They want to enter society. I want to to talk to Mahmoud Kreshi, nothing without cans. Be sure we are with you. It's not another part of group of neurosurgeons. It's the same group. And without any framework, we help Liberia, where there is one neurosurgeon, is Anglophone. We help Gambia, where there is one on now a girl come for the second neurosurgeon for all the countries. We have the Senegalese have their bit to go in Gambia to help him because he has his training in Senegal. Me, I go with Alvin Doe to help him in Liberia. We didn't know about Sierra Leone and Fatou. I know. I cross her in Cape Town. We are able to help those Anglophone countries for mission, for sustainable teams of neurosurgeons, many things, but we need the experience of a global neurosurgery group. If you help us, I think we can do many things together. Thank you.
I am so impressed that you're able to come to Pakistan. That's amazing. Yes, please. And then I think Ernest.
Well,
yeah.
I'm Dr. Khalikuzaman from Islamabad, actually. Just wanted to introduce myself before I say anything. First of all, I must thank all the distinguished guests and all the delegates from abroad and giving us the opportunity to host. And I hope, and I'm sure that you enjoyed your stay. And one thing that I would like to appreciate is it's the first time that we are empathizing rather than sympathizing. So that's the big thing that I have felt over the period of last 2-3 days, especially with all kind of distinguished experts around. One thing that I thought I would share with you is that when we are in a close hall like this, we think we are very powerful. Every time we speak, every time we share with each other. But I think it's a community and the decision makers are really not here anymore. You know, we can talk, but we may not be able to influence those people who are actually the people who matter. For example, community leaders, politicians, the government leaders, and the departments. For example, I would suggest that, for example, next time that we have a global meeting like that, we should have at least somebody from the authorities that or somebody, some of the pressure groups that you should involve the community as well as the officials, the decision makers or the policy makers, whether they are influential people, for example. And I think when they would come, they would not actually take us as a very orchestrated or distinguished people that they cannot talk to us. But we are actually today, this time, it was not about high technology and high results. It was about sharing the resources, whether it is knowledge, skills, or technology with each other. And I'm sure if we take all those decision makers of your each country of ours, for example, if today there would have been, say, a health minister or a health secretary or a DG health of, say, even just KPK sitting here and attending the whole conference, he would have had the message and probably it would have been easy for us to materialize whatever we actually have talked about over the past 2 or 3 days. Thank you so much. That's all I wanted to share.
Thank you. Ernest, then we'll go to the panel. Yeah.
I think my comments relate a bit to the last commentary and then Bill Colwell's to an extent. I'd like to see us continue to advance global neurosurgery research and the science of global health delivery and global health equity within neurosurgery, which is what I feel global neurosurgery is fundamentally about. And I think as we're looking to do that, listen intently to the critique that we hear. For instance, at the last Consortium for Universities Global Health conference I attended, I remember hearing a lot of comments about global health being a high-income country construct and the problems with that. And I know that we have premier centers for the science of global surgery and global health in South Africa and in Rwanda at the University of Global Health Equity, and other places. And I think it'd be interesting for us to advance, for example, not only generating the research and data that we use for all of our advocacy platforms, but as we have conferences in low and middle income countries, to push the multidisciplinary aspect of it and invite the sociologists, invite the anthropologists, the historians, the politicians. I mean, I recall at PGSSC, we had a global surgery in Latin America meeting in Bogota, Colombia. And what was very powerful about that, we did it at the Universidad de los Andes. And so that university grounds was very much an apolitical ground that I think felt safe for a lot of politicians and scholars to attend. And they did some really powerful work in that environment and actually had the kind of multidisciplinary conversation that constitutes what I think we're aiming for global health to be. So I'd like to see us advance global neurosurgery research in that way.
Thanks, Ernest. I'm going to go to the panel and see if there are any actionable items that we can take home from here. And then we'll come to you, gentlemen. Yeah.
Well, one small issue going with what William said before and what you commented, Alistair is here. We had in Blackpool in UK at the British neurosurgical meeting, I think 1 year ago, a discussion about shifting our trainees to countries in need and giving them the possibility to be trained for, we are not talking about anything like humanitarian or charity, it's training, simple training. We have difficulties, I'm talking about Europe, but I believe US is similar in some part at least. We have difficulties in training properly people for trauma, for instance, because the numbers are very small, except in a few centers. Most training programs in Europe do not have enough workload for trauma. And the same is true for pediatric neurosurgery, and the same is true for infectious disease related to neurosurgery. We don't have enough exposure. So we were talking in Blackpool how the two society can help. We have achieved in my country the possibility, it is recognized now, we can send them around keeping the salary, like if they work with us. And since the salary is small in Europe, but it's not small in many countries in the world, they can be self-maintained. In UK, they have adopted a different system. In your website, the SBNS, there is a list of possibility for getting scholarships. It's two different approaches, but the main issue is the same. Giving the possibility to our trainees to have at least 6 months exposure to a reality where first they can learn how to operate and how to deal with emergencies and trauma and disease that they see very rarely. And second, contribute to data collection and work with them on a project common to both sides. So I think this is important that we should apply. It's not only we collaborate, practically speaking, we have to make it possible.
Anyone else there?
I think that one thing that, actionable item, which we've heard here today, is if we really know who these partners will be, and we do, these the people that we're trying to influence, the ministers of health, we now have a critical mass of people talking about it that we need to include them and listen to them, and they listen to us. And so by all means, the meetings as we go forward become more inclusive in every way, not just not just regionally, which is essential, not just by income, which is essential, but also by authority and job description. We need the lawyers. We need in some of these countries we need the army, but we always need the government involved. And I think that, and the universities, and to include them would only strengthen us.
Well, I would say that this is really critically important because we can and should be proud of the fact that neurosurgery does lead global surgery. It's also a responsibility, right? Because we're a leader. So I would like to see us select goals, smart goals, specific, measurable, actionable, time-bound goals that are meaningful to neurosurgery and the delivery of our care. I'd like to see us coordinate our activity. We're doing a lot of good work, but sometimes we're not aware of what others are doing within and outside of our specialty. So we could be more efficient by communicating better. I'd like to see us develop a cadence of regular meetings and conferences and reporting so that we can keep traction on our good ideas and our good works and accelerate our progress. And I'd like to see us regularly recalibrate, reevaluate, and recalibrate to make sure that our vector is in the right direction. But most importantly, I think that we need to continue to recruit and grow and guide the younger generation who are the future of our profession and will be there to provide the care for those 5 billion and growing neurosurgical patients who don't currently have access to our specialty.
But I think we have a startings of a Peshawar statement. Based on, yeah. Walt?
I would take a little bit different approach. Most ministers of health have an agenda. And instead of going to ministers of health saying, this is the neurosurgical agenda, let me tell you how we can help you, listen to them because they have an agenda that they want to get done. Their political appointment or the Secretary General or Permanent Secretary, whoever you're meeting with in the Ministry of Health, has an agenda of what they want to get done in their country. They know what they need, the priority, whether it's helmet laws or seatbelt laws or road safety or whatever it is. We need to anchor what we want to do into what they already want to do. We'll have a much greater chance of success if we listen first, assist second, and then we will accomplish our goals if we work together with them.
Perfect.
Yeah, and thank you. I think certain things are very clear. What we want to do and we have been doing is, number one, identify countries which need to start neurosurgery, find, as we said, champions, and find countries which need capacity building, and then find organizations. We already, as Bob said, we know so many organizations who can help us. We need to focus on those organizations to get together with them and work with them. And so many heads of organizations are here right now, sitting here, I think. So, and also then talk to the governments of those places, because unless you have the governments on board, you cannot do really anything. And yes, as Walt said, that maybe we should ask them their agenda and try and weave around that. I think neurosurgeons are very good at being able to make way through. So I think we can do that. Thank you.
Thank you. We're just a couple of minutes over. Is that okay? I'm going to go to Bev for final comments. Bev, I've already seen your note, by the way, about conference, but it was excellent. Yeah.
Our little secret is out.
It's really good.
And I think that one of the things that is a challenge with the name of global health, as captured by Ernest, is that it can seem to be domiciled, particularly in the America. So my request is around looking at it as an implementation science of how you'd grow a service, both in public health as well as in the surgical expertise field. And there are, shall we say, areas where there's greater expertise, for example, the Harvard program. My request is whether through the global neurosurgery, you can make available through open access a toolkit, for example, on advocacy, on how to do a surgical plan, etc. A little bit the way like the Open University avails resources that anybody can utilize to help them. Because a lot of the, most of you kindly who are sitting in front are much more senior, but in most countries, senior leaders are relatively young. They're, within 10 years of finishing their qualifications. And so to amplify the work you're doing, they need access to the resources that enable them to do the work. That's the first thing. The second thing is looking at this as an umbrella body rather than a club or by invitation. And that's looking for how we're going to disseminate the information in different languages, in Arabic, in Lusophone countries, in Spanish, and that's leveraging the young people who can use this technology to translate into different languages. And then the last one is maybe some training courses, a little bit like the way the ENS do, or the SBNS, where we young people can come and have sit round table and exchange ideas about how we are going to deal with several things. So thank you.
Excellent. Okay, real quickly, sir.
May I say something,
yeah.
Bev? I think, Bev, thank you very much. I think we all believe that as far as at least I'm concerned and we are concerned, this is not a global neurosurgery committee. It is a forum for people to sit and discuss, and anybody who wants to join this forum is more than welcome to join, because I think as many people are here, like Yvonne and yourself and many of you are already part of that forum. So I think it's very important to have everyone together. And yes, we need young people also. And sorry, I forgot earlier on the medical students who've been doing already a great job. So I think they're very important as well. Thank you.
Yeah, let's be clear that there's the Global Neurosurgery Committee, but then there's the community of global neurosurgical practitioners, which is all of you.
Okay, so thank you very much. My name is Dr. Rahim, and I am finally a resident at Leriding Hospital, which is just half a kilometer away from here, and which is the most crowded hospital, as the Professor Tariq is the ex-chief of the neurosurgery there. So we are operating, just I want to bring one point into your, in your kind notice. That is that we are working a lot. Like in my, if I talk about myself, so we have operated hundreds of the surgery. As in one the presentation, one of the senior presenter who said that most of the data that is from the developed countries, whether from the low-income countries, like that was like iceberg phenomena. The presentation and the papers were mostly from the developed countries, but the trauma is mostly frequent in the low and middle income countries. So my request is that, being a trainee, I am as a representative of the residents of the Pakistan. So we do operate on the patients, but we cannot share the ideas internationally. Like I haven't published even a single paper during my residency, though I have operated more than 400 cases in the neurotrauma. So my request is from my senior and from the ICANN, from the global neurosurgeons, that how can you help us in regards that how can we equalize the standard of the training? Like it is a very famous quotation in the Arabic that "An-nasu ma'adin, kama'adin al-dhahab wal-fidda," means humans, they are like mines of gold and silver. So they're with the sharing of the knowledge and with the sharing of the ideas, they can get benefited from each other. So as we are benefited and we are sharing the ideas on the higher level, when we reach to the age of 50 and 60 years, why not at early stages?
Your point's well taken.
Yes.
Yeah.
Why not? Why not at the age of 25 and at the age of 30, we can equalize?
Thank you very much.
Yeah.
Okay.
I think the most important thing which is required for writing paper research is data collection.
Exactly.
And the data collection has to be done by you and your department. Unless you collect data, nothing is going to happen.
By the way,
Yes,
also,
exactly.
yeah, thank you for that excellent comment. That's your final comment at this point, because we have to move on to the next. But I will tell you that GNC has always, the first committee, second committee, and now the third, prioritized the young neurosurgeons. We've had them inclusive at the governance level from the get-go. At Congress in Cape Town, we learned that I think the median age of neurosurgeons in Africa is like under 40 or something like that. So how can we have people like me tell the younger people what to do? So we absolutely have to have the young neurosurgeon's voice at the governance level. In fact, we went a step further, and I think, Kenan, you weren't there, but we were at a session and we said the WFNS AC should have some young neurosurgeons, at least as an observer, at least, yeah. Sorry. Yeah. So Kenan, take that home with you. But thank you, everybody. And I'm going to turn it back to the chair here. Thank you for the panel.
Thank you very much for an excellent session. Thank you, all the panelists. Thank you, Key, everybody who spoke there. Really, thank you very much. Some more good news is that we will leave for Landi Kotal Khyber Pass at 9:30 a.m. and not at 8:15 a.m. I just got a message from them because we have to miss Ali Masjid and we go straight to the area where we will see the border. So just inform you, you can have a lie-in. So now really a very important part of this conference, the person whom I believe really was one of the main persons and of course he was the one who started the Global Neurosurgery Committee, which we announced here in this hall in 2019. And so I believe that a tribute to him is required, and so I'm going to request a few people to come here and say a few words. First of all, I think Professor Najia Al-Ebadi has recorded a video, and maybe we can play that and see what she has to say.
In this occasion, I take this occasion again for and I would like to pay tribute to a remarkable, outstanding, and really very, very nice and kind person and a neurosurgeon who introduced me to the World Federation as officers. Because I don't forget that I was in the WFNS from 2002, 2002, and 2005. Thanks to our master Professor Habishi to organize the first Congress, World Congress in Africa in Marrakesh, 2005. It was really one of the best and one of the best meeting at that time. And really, I would like to tell you some word about our Professor Franco Servidei. I had a big affection for him. I was really he's somebody who inspired me in the WFNS, and he has consistently demonstrated to all of us that during our terms. 2 terms as assistant secretary, and then one of president-elect, is honesty, a skillful commitment to upholding the constitution and the bylaws. He is also, without doubt, a president who traveled the most in the poor countries in the world, and especially countries in the need like Africa, Asia, Latin America, and also who is one of the leaders of encouraging the young neurosurgeon not only to rise in the number of the center of reference, the center of training and training of in Africa, in Asia, in Latin America, but also he is one of the significant promoters of research. He did a lot of research, and I remember always that he started his talk with 2 or 3 slides, insisting, emphasizing the fact that the young neurosurgeon from LMIC are a lot of difficulty to reach the research, and he did a lot for this young neurosurgeon. And I am sure that there are some here that they can witness of his huge job in this And once again, I would like to thank him for everything that he did for our federation as promotion, education, research, and also to be honest to follow the constitution and the bylaws, and I hope in the future that we follow his path in the same. And the title of honorary president that we today, I think we had today is really one of is rightfully yours. Thank you so much, and thank you for a lot of that you are doing for the WFNS, and my congratulations for these big nominations. And also for your big work. Thank you so much.
Well, thanks to Professor Nadia, and I'll request Professor Kenan Arnautovic to say a few words as well, please.
Thank you, Tarek. Too much of me this afternoon, but I will be brief. So we know everything about our friend, mentor, leader, Franco Servadei. I'll just concentrate on several dozen fun facts about him. First of all, we all know that he has been a leader of the World Federation in various functions for 14 years. He has been 2 years president-elect, then he has been 4 years president, 2 years past president. He's now honorary president. And then the list goes on. He has been president of trauma committee for 4 years, and also, I believe, assistant secretary. So 14 years of service. It's a very, very long service, and the organization benefited very much. You know, when you have elections, WFNS is a rare neurosurgical organization when there are real elections. For example, in the United States, a lot of organizations delegate the presidents. But WFNS, you vote. And the bigger margin you have when you win, the bigger mandate you have. And he always had a huge mandate. He won his election 25% difference between the candidate. And I was not in that meeting. I believe it was in Italy. I heard he ran against the mainstream candidate, and since that time, he may have some hard time during his mandate with the office. But he took it the right way, and I know he traveled many times with his train from Milan up to Switzerland, and sometimes there were fun travels, sometimes there were not. But he also traveled in 42 countries around the world during his presidency. It's a huge, if you calculate, it's 1 country a month on average. And I know that he did courses there. He taught young neurosurgeons And there has been half dozen times when I met him on different airports around the world. We ran into each other. I remember when we go to Nigeria and we were going to United States and so forth. He is a great mentor to many of us. First of all, his home Italian neurosurgeons, some great leaders coming after him like Francesco Sala and Marco Fontanella and many, many others. And also, I am privileged to consider one of his people. I met him about 10 years ago, and since then, I always ask for his counsel, and he always delivers the right recommendation for some problems that we may encounter. I was recently visiting professor at an honored guest of Italian Society, and I was impressed by several things. I was impressed first a little bit how he unified. You know, there are 7 departments of neurosurgery in Milano, and they were not talking very much among each other. They were not communicating very well. But since Franco came there, they have regular dinners, regular business meetings, and just camaraderie is flowing across town. He was able to connect. You know, sometimes our neurosurgical personalities are not the easiest ones, but you were able easily to connect them. And I was privileged to have a beautiful dinner with you guys, and I enjoyed all the camaraderie that you have amongst yourselves. But you know what impressed me most, Franco, about you is when we went to your university, Humanitas University, and when you kindly invited me to give 5 lectures to your students. And, you know, there were about 150 students there. And I was watching you and I asked you, who is going to be with me to communicate with students? And you say, it's going to be me. I mean, you. And like many times when you go somewhere as a visiting professor, you go with residents, they leave you alone with residents. But you were sitting there, you were asking questions, you were seconding my teaching to the residents, and you made sure that the message of the guest and teaching to your residents and students was delivered. And then what even more impressed me about you, when we were there sitting with residents, long hours, whole day we had lectures, we enjoyed their bright questions. You knew every single resident, 150 people were there, and you were telling me this girl is going to plastic surgery, this girl came from Afghanistan. By the way, there was one student from Afghanistan, a lady student who did not have opportunity to finish medical faculty there. Franco made sure she came to Milano, and she is now on the verge of completing her study, and she's gonna, I understand, get the residency. So this is one of the huge things that we did. I remember I have also a picture with her. And you know, every residence where they're gonna do how many examinations they have, and that takes a true leader and mentor, and that speaks a volume about you. So this is all what I had to say. I respect you, I love you, and all the best.
May I request Key Park? Come on.
I won't, for the sake of time, list all the things that Franco did and didn't do. But I remember you were the candidate from the floor. And and then when you won against the picked, right, the designated successor, there was a sense of hope, right, a new start for the organization. And you certainly were that person. I had worked with other presidents in the past, and it was like layers of people to get to that person. Franco, you and your wife actually came to Cambodia. I was living and working in Cambodia in a government hospital. And, you know, he came to visit, wanted to see what I was doing. You know, when I told you about global neurosurgery, he's like, okay. And he came to the World Health Assembly, you know, and he came to the meetings and attended some of these events. He wanted to see for himself, and then made it. So he made it his business to understand what you were doing. He was interested in what you were doing. So Franco, that really touched me. And of course, you'll always be known as the president of WFNS that started global neurosurgery, really institutionalized it. And without your decision to do that and creating the committee, we would not be anywhere near where we are today. So, muchas grazie.
And my friend, Professor Gail Russo, please.
Well, I would second what all have before me have said, that you are really Il Papa for us, and for this movement in particular. And in the interest of time, I'm going to limit my remarks to just 3 of your many extraordinary qualities. The first is your vision. I mean, this is what Key just said. You made it your business to understand where the profession needed to go in the service of humanity. And then you brought that vision to the organized structure of the neurosurgical community worldwide. And you emphasized service. And that is just so remarkable and so important. It's the empathy side of neurosurgery. So first is vision. Second is your phenomenal ability to share leadership. You are great at your ability to identify and recruit talent and then put people in the right place. And a great example is Tariq Khan being the chairman of the Global Neurosurgery Committee. It's a perfect assignment for him and for moving the organization forward. So shared leadership. And then finally, the deep grounding in research. You have been really key in, and I think unique in, pushing the aspect of research, which must underline the clinical and public health practice of neurosurgery. So you've emphasized the quality and the equity aspects of research in the grounding of the practice that is so important to us. So for all these things and so many more, thank you.
Thank you, everybody. So I will request Professor Franco Savade to come to stage and say a few words, please. Thank you.
Well, obviously, I will not speak about myself because you already heard everything. I come from a culture, the Roman culture, the Latin culture, where you cannot be celebrated before you die. You know, that's my culture. In Italy, is forbidden to nominate a square or a road with the name of someone who is still alive. It's forbidden because our culture say you can be celebrated and tributed only after death. I am very happy I did it before, so I could listen to all these very, very nice comments. So I cannot say anything else. And when I won the running for the presidency of the World Federation, it was just a case, a poor case, because I was not the candidate, the official candidates, which was a very good neurosurgeon, already had letter of support of 64 societies in the world. At that time, we had only 96. So he had 2/3 of votes already. So who will run against him? No one. But we thought we need some changes, me and many others. So I tried and I was rewarded. And I think, as you heard, that we did something important. We should continue. And these meetings is showing, by the way, Tariq, the success of a meeting is measured by the last session. This is usual because if you have a very successful meeting, Andreas knows, but at the end, in the last session, you have only 10 people that's not working. Today, we have almost the room full. We have a very successful meeting. I would say I'm I see it my life as a young guy who is starting again to work with you for the global neurosurgery. I will bring with you all the experience we have. I thank you all for staying here such a long time to listen to celebration. As I told you, it's a bit different. And I believe Tariq will do a fantastic job for our future. Thank you very much.
Thank you very much, ladies and gentlemen. We have come towards the end. I would ask Dr. Naveed to please come to the stage for a formal vote of thanks.
So before starting any goodbyes, I remember this gift that the Professor Franco has. We met in Peshawar in a meeting, and we had just 5 to 10 minutes talk during our lunch. And then I went to Ian's in Lido, and I wanted to kind of reintroduce myself. And I said, Professor, do you remember I was there? And we were talking, and then said, of course, how can I forget? We shared kebab together. So it's a great gift that he has. So we would not call this a goodbye, but a welcome to our next WFNS meeting, of course. Saying goodbyes is always difficult, but of course, it's something that we do ceremoniously. So I would say that good afternoon, everyone, distinguished guests, speakers, and fellow delegates. It's an honor and a privilege for me to stand before you today and extend my heartfelt gratitude for you on behalf of the organizing committee. It is said that the world is run by those who are willing to sit till the end of the meetings. So I respect all of you sitting together at the end right now. So first and foremost, I would like to express our deepest appreciation to our esteemed keynote speakers and panelists. Your profound knowledge, innovative insight, and invaluable contribution has been instrumental in shaping in the thematic discourse of this meeting. I also extend our sincere thanks to all of the presenters who have shared their pioneering research, clinical experience, and best practices. Your willingness to engage in academic dialogues and exchange ideas has been critical in fostering an environment of intellectual growth and collaboration. We are deeply grateful to our organizing committee, those who work tirelessly and meticulously planning have been, it was pivotal in orchestrating this momentous event. Your dedication, attention to details, and seamless coordination has ensured that every aspect of this conference ran smoothly and flawlessly. So here I would specifically mention Professor Tariq, without whom it could not have been possible. He worked tirelessly more than 2 hours for this moment. So I really congratulate him. I myself gained immense wisdom and organizational skills from my senior committee members like Dr. Shahid Ayub, Dr. Mumtaz, Dr. Athar Inam, in terms of capacity building and effective communication, which was the theme of this WFNS conference as well. We cannot forget the efforts and support of international WFNS committee members in helping GNO meeting gather in Peshawar despite all the odds. As I said, it took us 2 years almost of wait to bring this moment here. This could not have been possible without the personal interest of President Professor Naji Al-Badi, Louis Borba, Dr. Keepak, Dr. Professor Franco Cervede, Dr. Robert Dempsey, Dr. Gail Russo, and many others. Of course, I cannot name them all because of time constraints, but everybody worked that this works out. So thank you, everybody. One cannot forget to acknowledge the indispensable role played by our diligent volunteers and support staff. Of course, it could not have been possible without them. Your hard work, professionalism, and unwavering dedication was the backbone of this conference. Here, I would specially mention Dr. Wasim, Dr. Siraj, Mr. Amir, and Muzammil for helping us out. A special note of gratitude goes to our sponsor and exhibitors, of course, for their unwavering support and belief in the mission of this conference. Your partnership has allowed us to have a vision and a platform for disseminating the cutting-edge technologies and pharmaceutical advancement in neurosurgery, of course. Last but certainly not the least, I want to express my deepest appreciation to all the participants and attendees. Your active engagement, thought-provoking discussions, and eagerness to learn have been driving force behind the success of this gathering. As we reflect on incredible journey of Global Neurosurgery Conference, let us carry forward the spirit of collaboration, innovation, and excellence that has defined this conference. In closing, I extend my deepest gratitude to each and every one of you who worked and had an unwavering support, enthusiastic participation, and meaningful contribution. It is through our collective effort and shared passion of neurosurgery that we have made this conference a phenomenal success. Thank you, and may the spirit of collaboration and discovery continue to guide our noble endeavors in the field of neurosurgery. See you at the next WFNS event. Thank you very much.
Usually good. And that would be I'm not a sure I get. That means your personal. Oh, yeah. Yeah, because I wasn't sure. Yeah. Okay, that's what I remember. And the, will you send me your remarks? Yes. Yeah, because they're. How would I get like one of these? Yeah. As soon as we're done. Yeah, that would be great. I know sometimes I send it out to the. Perfect. You'll send your remark. Good. It's last one.